CSI. So over to our respected chairpersons for starting the session today. There are certain hygienes also that we try to maintain the time limit unless there are some compelling reasons. And I requested all the speakers in the interest of the very comprehensive program that we stick to our time. So over to you, sir, for starting the session, and very wonderful, and have a wonderful, great meeting for 1.5 days.
Thank you, Mohit. I think it was a wonderful beginning to a extravaganza for 2 days. I think we are hoping to learn lots and lots and come up to date on the newest technology and data. The first session today is hypertension, the newer horizons, as we all understand. And the first speaker is Dr. Ashwini Mehta. He is, without wasting time, let's go ahead and listen to him. He's going to talk on recent treatment goals for hypertension, a clarion call for blood pressure control in India. Dr. Ashwini Mehta, please.
Thank you, Dr. Mittal. I'd like to thank, first of all, the Delhi CSI for giving me this opportunity today to be a part of this wonderful program, and I look forward to 2 days of great extravaganza. And just to begin the session today, we're going to talk about hypertension, and my subsequent fellow speakers are going to talk in detail about certain other topics. And I've been assigned to talk about the recent goals of hypertension, a clarion call for blood pressure control in our country. Now, why this clarion is there? And we need to understand that the prevalence of hypertension in our country, although roughly estimated, we do not have very great studies, but in rural areas also is very high. And it's about 16 to 33%. In urban areas, it may be as high as 33 to 35%. And overall, if we look, we know that we are looking at a population, about 1/3 population, 30% population having hypertension. So that's very high levels of hypertension which we have in our country. And the incidence of hypertension is almost uniform, but there are few states where the incidence has been found to be high. And we know the prevalence also varies, but what is something very disturbing today is that hypertension now is coming even in younger age. And in one of the studies, it looked at the population between 18 to 25 years, and the prevalence was about 12.1%, which is a very high incidence. And we know that it's a big problem. And as we know, as the screening is increasing, that every 2 in every 10 children might be suffering from hypertension. And this is the headline of one of the newspaper. So that makes us stare at a huge magnitude of problem in our country. There have been various guidelines, and to make things complicated, each guidelines have given their own calls, but more or less they've been similar. We have ESC guidelines, we have JNC guidelines, but if you look at the last year's guidelines of International Society of Hypertension, there was a little pegging back of the goals. And what it talks about was that the normal blood pressure is about less than 130 by 85. And again, it talked about high normal being 130 to 39 and diastolic between 85 to 89. And hypertension starts at the level of 140 according to this. Now, just before this, we had ACC guidelines, now which were a little more strict, and it talked about the normal blood pressure of 120 to 80, and it defined hypertension if the blood pressure was 130 and above. There has been some criticism of this, and if we apply these guidelines, the ACC criteria, a large chunk of our population would be hypertensive, and they have their reasons to say so, because we know when we treat it, we find that the outcomes are better. And one of the landmark study which brought about changes in the goals of hypertension has been the SPRINT trial. And what it showed was that there was a dramatic reduction in incidence of heart attacks, heart failure, and cardiovascular events if the target was brought down to 120. And the reduction was to the tune of about 25%. And it also meant that about 27% lower risk of death. So what this really did was it churned around thinking all over the world, and the goals of hypertension treatment are getting pegged down, and they need to be treated aggressively. the evidence now is getting overwhelming. So in our country, on one hand, we have a huge problem of awareness, huge problem of treatment. On the other hand, the evidence is coming from all over the world that the lower is better. So is it time to change this old paradigm? Is it a time to change the goals? Or do we need to shift the focus to CVD risk? The old paradigm has been that we must treat the blood pressure thresholds and targets for treatment. But there have been recent calls that instead of moving just to the blood pressure threshold and target, we need to define the cardiovascular disease risk. Why we need to do that? When we target that, then the outcomes are much better. And it has been embraced by various guidelines. And we had our own Indian guidelines of hypertension, which were published in 2019. And what it said was that the threshold for starting antihypertensive therapy should be 140/90 in most of the patients. But if the patient has coronary artery disease or heart failure, we treat it much earlier. And the target should be less than 130/80 in patients who are less than 60 years of age. And in the elderly patients, we need to individualize this therapy because of the risk of falls and all that. You need to be careful in such patients. Now, whenever a patient of hypertension is diagnosed, all patients should be screened for the kidney disease. And then the monitoring of the renal functions should be done regularly. Now, our own guidelines also talks about two other things, which are the associated risk factors. If we treat that, the outcomes improve. And one of the biggest associated problem is obstructive sleep apnea, and it does talk of that to be treated and accordingly if there is a OSA which is present. And similarly, statins in hypertension in patients who have dyslipidemia has shown, as we know evidence from HOPE-3 study, that the improvement occurs. So the focus now is not just control of blood pressure, but also control of the CVD risk along with hypertension, which is one of the very important factors which we must take into account whenever we treat hypertension. But in our country, the challenge of blood pressure control is very significant. Why? Because the prevalence of awareness is very low, just in about a quarter of rural population, and just in about 2/5 of urban population, we know they are aware of hypertension. And only in a quarter and a third of those identified in urban and in the rural areas, they receive treatment for it. So on one hand, the awareness of hypertension is not there. On the other hand, the adequate treatment is not there. There's also a challenge of misdiagnosis in our country because of poor standardized techniques, poor equipments, and also reliance on a single reading, on a single visit. So it needs to be changed accordingly. In our country, what we know that there are certain unique features of hypertension we must keep in mind if we need to address this problem, which is the earlier onset in life of hypertension, as numerous surveys are now showing. And there is a rural-urban divide in prevalence, but this divide is getting blurred day by day, and the incidence of hypertension is rising in the rural areas. Clustering of multiple cardiovascular risk factors, seasonal variations, especially in the northern part of our country, is not uncommon. We do see patients coming in winters with very high blood pressure, and we need to adjust it in the summers. The rising average blood pressure of general population, the health records show that. And on top of it, we have low awareness, treatment and control rates. And also we have a much higher rates of hypertension-mediated organ damage. Now, all this is because of sedentary lifestyle, increasing obesity, a high level of salt intake, alcohol, tobacco consumption, and also one of the very unique problem of our country is lack of awareness, compliance, proper treatment, and also to some extent, even in the urban areas, resistant to the modern medicine. We need to emphasize that if we need to treat it adequately, they need to be treated with proper medication, and the proper allopathic medication needs to be treated. There is a need for a clarion call for managing hypertension in our country. Why? Because the levels of blood pressure control are very, very low in our country, just 20% in urban and 11% in rural. And we know that hypertension accounts for approximately 57% of stroke deaths 24% of coronary deaths in our country. So if we treat hypertension, we would be able to reduce this huge substantial burden. And improved detection and adequate treatment would reduce the preventable burden of cardiovascular disease. So there's another interesting study which did talk that just about 2 millimeter decrease in the blood pressure in systolic in our country would prevent 151,000 deaths due to coronary artery disease and 153,000 deaths due to stroke. So this is the crux of need for a clarion call all over the country for awareness, for waking up of the huge potential to reduce morbidity and mortality due to cardiovascular disease. So how does monitoring, how does improving the awareness of hypertension affect the reduction in events? So one study was done by the name ARIC study, and what it showed, a 5% proportional reduction in unaware hypertension has a potential to reduce 1.55 even per 1 lakh person per year. And we have a population which runs in crore, so which we can really take care of. A 10% proportional reduction in unaware hypertensive population would reduce events of 3.1 events per lakh years. 15% proportional reduction, about 6.21. So there is a huge scope of improvement in our country.
Ashwini,
There have been
you'll have to
various
wind up.
measures. Yeah, there have been various measures, and there have been National Health Survey and guidelines. They do talk of that. So I would like to end my talk by saying there is a clarion call to increase awareness. We need to reach the goals much sooner and much faster. We must combine lifestyle and use representative drugs from all 5 classes of antihypertensive therapy. Thank you so much for your kind attention.
Thank you, Ashwini. It was a wonderful talk and very clearly mentioned about the changing treatment goals on hypertension, and what is more essential is in our country, it's a big burden and we have to take enough measures to control and realize the hypertension as well as control. The second talk today is by Dr. Anunay Gupta, and he is going to be delivering the talk on ambulatory BP monitoring, current status in developing nations. Dr. Anunay. Anunay, you are muted.
So, are you able to see my slide?
Yes.
Yeah. So, a very warm good morning to everyone. First of all, I would like to thank Delhi CSI for giving me an opportunity to give a talk today. And topic of my talk is, ambulatory BP monitoring. What is the current status in the developing nations? So, outline of my talk will be, I will discuss about what is ambulatory BP monitoring first, and what are the various data we obtain from ABPM. Then I will go ahead and discuss the role of ABPM in our clinical practice. And then what's the first all about ABPM? What is the prognostic value of ABPM? Then a study on an Indian study on ABPM, and how are we currently using ABPM in our clinical practice. Then what are the limitations, and then a take-home slide. So ABPM is basically a regular blood pressure monitoring over a 24-hour period, and it provides us a more accurate pattern of BP pressure than once recording in doctor's OPD. So what happens, a patient wears a upper arm cuff, usually in the left hand, and then a portable device is connected to it. So patient can sleep according to his sleeping time. And when the important thing which we need to tell our patient is that they should continue their routine normal activities, and just what they have to do, whenever the alarm beeps, they have to keep their arms still and relax straight down at the side of the body when the cuff is inflating to have a proper BP recording. As Sarah discussed earlier, the definition of hypertension has undergone a dramatic change from JNC 2018, followed by ESC and AHA. So as we can see here, the ambulatory BP, which defines hypertension, is a daytime mean of more than 135/85 according to ESC guidelines, while AHA suggests a systolic target of 130 and diastolic of 80. The night time is 120/70 according to ESC, while AHA suggests, while the AHA suggests diastolic of 65 in the night, while a 24-hour is more than 130 according to ASC and more than 80 for diastolic. And the mean will be around 125 for AHA guidelines and 75 diastolic for AHA guidelines. What happens when we measure ABPM? It helps in defining our patient into the 4 classes. If a normal office BP is there and ambulatory BP recording is low, so the patient will be defined as normotensive. There's some problem in the slide. And if the office BP is low, well, the ambulatory BP recording is high, so it will be defined as masked hypertension. With a high office BP but a normal ambulatory BP, the patient will come into the category of white coat hypertension. While if the both office and ambulatory BP both are high, the patient will be classified into sustained hypertension. There are two more definitions which are defined from ABPM in the patients who are not taken on medicines. One is isolated daytime hypertension, in which patient is hypertensive only during the daytime, while it is normotensive in the night. And another definition is isolated nocturnal hypertension, which will be discussed more in detail in a further talk. So this is an example of ABPM recording. ABPM gives us the 3 main features. First is the ambulatory BP, 24-hour daytime, nighttime, and morning BP. Second, the important thing is the nocturnal BP fall, whether the patient is having fall in DP or increase in BP, or there is no fall. And third is the circadian variability. So these are 3 important things which we get from ABPM recording. So this is an example of an ABPM recording. As you can see here, we have set that interval for 30 minutes during the day and 60 minutes through the night. Awake and sleep period time are well predefined from 5 a.m. to 10 p.m. in the night. And these the BP thresholds are according to the ESC guidelines. Machine tells us how many BP recordings have been taken correctly. And there is no specific validation, but it is just suggested that around 70% of successful program measurements should be there. And it usually corresponds to a 14 daytime readings and at least daytime and 5 nighttime reading. So, and there we get a nighttime dip. So as we can see here, there is only a 9% dip in the systolic blood pressure, which is not adequate, where there is a adequate dip in diastolic blood pressure, which is around 17%. Machine also gives us the BP load, in which it defines how many BP recordings are in the day are above the threshold of 135/85, and how many recordings in the night are above the threshold of 120/70. Patients can be defined by the average night fall into 4 categories. First is dipping. When the patient's BP fall, there's a normal fall of around 10 to 15% compared to the daytime, then the patient will be called as dipper. If there is a less than 10% fall, then the patient will be called non-dipper. And this has been proven to be a risk factor for development of heart failure and stroke. While if there is an excessive fall in the night blood pressure, which is defined as more than 20%, these patients are also at increased risk of stroke. And the fourth one is the reverse dipper or riser, in which there is no fall or increase in the BP in the night. So this is an example of a fall in night while the patient is having a morning surge. So morning surge is defined as when the average BP from the first 2 hours after the awakening minus the average nighttime BP. So this morning surge is also an increased risk factor for stroke. Similarly, here on the right side, you can see that the patient BP is well controlled. However, there is no fall in the night. So these patients are at increased risk of stroke and further heart failure events. So the basic role of ABPM comes in a triad of perfect 24-hour BP control. As you can see here, it tells about a strict 24-hour BP control. It tells about your circadian rhythm, and it tells about the BP variability. And all these 3 things finally culminate into a cardiovascular protection. White coat hypertension can be easily diagnosed by the use of ambulatory blood pressure monitoring, and it should be suspected in patients with grade 1 hypertension on office BP measurements and patients who are having high BP but without any evidence of hypertension-mediated organ damage. It is more common in older adults, women, and smokers. And in a study of resistant hypertension, it was seen that around 40% patients who were found to have resistant hypertension were actually having white coat effect. So here lies the importance of doing ABPM in all resistant hypertension patients, because it can help in defining the cause of resistant hypertension. This is an example of white coat hypertension. As you can see here, all BP recordings are normal, and while all office BP recordings were higher. So these patients were wrongly prescribed on medicines, and then you can see their blood pressures are significantly on the lower side due to the effects of the medicine. Another role of ABPM comes in defining the masked hypertension. Masked hypertension is defined as patient having a normal clinic BP while they don't have normal BP when they're in either in the morning or in the daytime or in the night. So as you can see here, these patients have morning hypertension due to other risk factors such as alcohol, smoking, in daytime due to work stress, home stress and exercise and smoking, and in the night time due to higher salt intake, presence of chronic kidney disease, diabetic, obstructive sleep apnea, poor sleep, and Asian ethnicity. So all these three things can be diagnosed with the use of ABPM in such subset of patients, and in a meta-analysis it was clearly seen that these patients are at higher risk of CV events compared to patients with white coat hypertension. Nocturnal hypertension will be discussed in detail in the next talk, but a few points about it, that its prevalence is very high. It's around 40% in untreated patient and 50% in a treated group. It differs from non-dipper, which is basically a less than 10% fall. It's more common in males, and in these patients, nighttime dosing can be helpful. Another role of BPM is in defining the risk factors for resistant hypertension, detection of white coat effect, detection of masked hypertension, and it can also give us clue to the secondary hypertension causes. There are few other indications of BPM also, which can be used in our clinical practice, whether when we can monitor the drug therapy, whether it is effective or not, whenever the patient complains of any postural symptoms of hypertension, so they can be assessed for that. It is very highly effective for a good BP control in pregnancy. We can define and diagnose labile hypertension, and we even can suspect pheochromocytoma in these patients, and how adequate BP control is of the patient on a drug therapy. The prognostic value of ABPM was well defined in a trial which was done around 20 years back and was published in New England Journal of Medicine. It was seen then the relative risk associated with ABPM reading was with per standard deviation of 8 millimeter of mercury, which was higher than the office blood pressure, and was adjusted for age, sex, smoking, diabetes, cholesterol level, and OBPM. And it was seen after the 5 year of follow-up that it was highly associated with increased fatal and non-fatal cardiovascular event, increased fatal and non-fatal myocardial infarction or stroke, but there was no difference in death from any cause in between the two arms. So ABPM has a highly prognostic value, and it helps in the proper management of our patients. Similarly, in a study published in Journal of Hypertension, in which survival analysis was done, and when the ambulatory BP recordings were used and the patient were classified into 4 groups: normotension, isolated daytime hypertension, isolated nocturnal hypertension, and sustained hypertension. As you can see here clearly, the patient who are having sustained hypertension, isolated daytime hypertension, isolated nocturnal hypertension at higher risk of adverse event compared to patient with normotension.
Anuna, you'll have to wind up, please.
Okay, sir. So one last slide. There is a one study which was done from our country, and it included around 28,000 patients. And you can see here that white coat hypertension was seen around 12% of patients. Masked hypertension was done in around 20% of patients, and isolated nighttime hypertension was diagnosed in 12% of patients. And the most striking result was that office blood pressure monitoring was not collaborating with ABPM. So finally, there are a few limitations also. So it's a costly equipment, it's not available, there are sleep disturbances, and patients have a poor compliance. So final take home message of my talk is that there are significant unique data which ABPM provides. This is mean day and night BP, circadian rhythm variations, systolic and diastolic BP loads, and it can be useful to assess white coat hypertension, masked hypertension, resistant hypertension. It usually avoids overtreatment and is highly cost effective. Thank you.
Thank you, Anuna. I think it was wonderful disposition on the latest available understanding on ambulatory BP monitoring and its role. Let's move on to the next talk on combination therapy and timing in hypertension. What are the new kids on the block? Dr. J.K. Sharma would deliver his talk on this topic.
Thank you, Dr. Mittal. Good morning to all. My special thanks to Dr. Mohit Gupta and CSI Delhi. In the next 10 minutes, I'll be talking about the combination therapy and timing in hypertension. What are the new kids on the block? The rationale for the combination therapy is that when hypertensive patients do not achieve the adequate control of their blood pressure, the options to try and achieve required treatment goals are to increase the dose of increase the dose of monotherapy, which increases the risk of side effects, or to use the drug combination with minimum side effects. And the mechanisms that led to a blood pressure increase in a patient are diverse. Fixed dose combinations, both drugs in the same tablet, offer additional advantages such as improved adherence by 24%, easier indications, and potentially reduced cost. And their limitation is less possibility of titrating the dose, only one of the drugs. The use of combination therapy provides greater protection to a target organ than increasing the dose of the monotherapy. Now, how to use the combination therapy? There are several ways. Each individual component can be titrated, and once the appropriate dosage of each is reached, a fixed dose combination that contains the approximate dosage of each component can then be given. Start the therapy with a single agent, then use a fixed dose combination that includes a second agent and the dose of drug 1 as the next step. Start the patient on a fixed dose combination with small doses of two different classes of drugs, or this approach may achieve the good BP control more quickly with the minimal side effects. So which combination is best? Antihypertensive management should be individualized according to the characteristic of each patient. So it is difficult to generalize. However, two meta-analyses have recently found advantages for combination that include a RAS inhibitor with a calcium antagonist. The first study, which included more than 25,000 patients from 8 clinical studies, and found that associating a calcium antagonist, whether it is dihydropyridine or a non-dihydropyridine with a RAS inhibitor, whether it is an inhibitor of the ACE or an ARB, which was accompanied by a reduction in the cardiovascular mortality, non-fatal MI, non-fatal cerebral vascular disease, when compared with other combinations, despite similar reduction in the blood pressure. And the second study, meta-analysis included more than 49,000 patients from 27 studies, and found that in hypertensive patients with type 2 diabetes, the combination of RAS inhibitor plus a calcium antagonist achieved greater reduction in mortality than monotherapy or other combinations, though it is related to a greater reduction in blood pressure figures with this combination. So the advantages of the combination, we have seen that greater reduction in BP figures compared with monotherapy, reduction in adverse effects of the each drugs, several physiopathological mechanisms of increased BP are blocked, greater protection to target organs, there is faster control of blood pressure, and the combinations may have some effect that are independent of their antihypertensive action, like the anti-inflammatory and metabolic and anti-counter regulates also. So multiple mechanisms involved in pathogenesis of hypertension, effectiveness of monotherapy limited by stimulation of counter-regulatory mechanism, effective BP control seen in only 50% of the patients on monotherapy. Combination therapy results in much higher responder rate, that is more than 80%, and BP goals difficult to attain with monotherapy in patients with diabetes or target organ damage, and that is why we have the combination therapies. The other effects which are independent of the antihypertensive effects of these drugs are the metabolic effects, nephroprotective effects, hemodynamic, vascular function effects, inflammation, and in patients with heart failure. But along with that, there are certain disadvantages of combination therapy, like the dose flexibility may be lost. The fixed dose combinations may not have the appropriate doses for one or both of the drugs needed to treat some comorbid conditions. And in treating heart failure, for example, where large doses of ACE inhibitors are often necessary, the fixed dose combination might require giving excessively high doses of the other component like the diuretic than would be appropriate of those patients. This is not usually a problem in the management of most hypertensive patients. So now the theoretical requirement for a rational antihypertensive combination is that each component should contribute to the final effect. Results should be superior to those achieved with a single agent. Dosage form should be adequate relative to the bioavailability, and major portion of the target population should respond. Physicians should be easily familiarized with the individualized components. Possible combinations, we all know about that. There may be thiazide diuretics, ARBs, ACE inhibitors, alpha beta blockers, calcium channel antagonist, and we can see that all possible combinations with these drugs can be made, and the treatment and the combination is tailor-made according to the patient. There are certain pharmacological rationale for combination therapies like the ARB and diuretic. ARB causes the antagonism of angiotensin 2 at the vascular and myocardial level by direct AT1 receptor blockade. Then thiazide diuretic blocks the sodium chloride reabsorption at the distal convoluted tubules. Like beta adrenergic antagonists and diuretics, then ACE inhibitors and diuretics, then ACE inhibitors and calcium channel blockers, ARBs and calcium channel blockers, ACE and ARB inhibitors combination, a little dangerous combination, centrally acting agent and the diuretics. So we have to look which patient of ours needs which combination depending on the underlying pathophysiological requirement of the patient, underlying and associated comorbid condition of the patients. Now, the other fixtures combinations with examples have been given here, which we can see and we have been using every day. The 2019 Indian guideline recommend drug combinations in younger population less than 55 years. We start with step 1, that is a drug. In older, A is ACE inhibitor or the ARB. In older individuals more than 45 years of age, either the calcium channel blocker or the diuretic. Step 2 is in younger individuals, or we can add A plus C or D. At stage 3, A plus C plus D. In cases of resistant hypertension, add MRA like spironolactone. If side effect, then use epinephrine. And in stage 5, add the alpha blocker or a beta blocker. In special situations, centrally acting drugs or the direct vasodilators can be used. Now, the newer agents in hypertension, they are the classical targets in hypertension. Classical antihypertensive drug include the renin inhibitor, ACE inhibitors, angiotensin 2 receptor blockers, beta adrenoreceptor blockers, aldosterone related blockers, and which here we can see that they are through the renin inhibition, the ACE inhibition, and the ultimate result is the vasoconstriction, and they cause the vasodilatation. So this is the various classical targets in hypertension. And the classical and counter-regulatory RAS pathways and the drug targets, they are the activation of the classical RAS pathway increases the blood pressure and target organ damage. And this pathway is the target for many currently available antihypertensive drugs, including the ACE inhibitors and the ARBs. Novel approaches to RAS inhibition, including vaccines targeting angiotensin 1 and the AT1 receptor, are being evaluated in the preclinical and the clinical trials. In contrast, activation of the more recently described counter-regulatory RAS pathway decreases the BP and target organ damage, and drugs that activate this pathway are being developed as anti-hypertensive drugs. And you can see the newer combination treatment for hypertension, the clinical trial status, sacubitril valsartan, it was in phase 3, but now we are using it for last 2 years. So I think it is no more in the phase 3, it is already in the market. This is an old slide of 2018. And the mechanism of valsartan and sacubitril, we can see that the ARB neprilysin inhibitor is a single molecule comprising the ARB valsartan and the neprilysin inhibitor sacubitril. This has been shown to lower the blood pressure and to prevent death from cardiovascular events and hospitalization for heart failure in patients with heart failure with a reduced ejection fraction. And since the time this drug, this combination has come, I think we all are using this combination until otherwise contraindicated. Now, this is the mechanism of the aldosterone synthesis and the action of MRH. The newer monotherapy treatment for hypertension, the clinical trial status, there are many drugs which are coming. Currently, 16 fixed dose combination medicines are ongoing clinical trials for the treatment of hypertension related comorbidities. Each of these contain at least one FDA approved antihypertensive medication. The 4 combinations contain 3 or more agents also. And these are the various new targets in hypertension. So to conclude, recent evidence for the beneficial effect of targeting lower BP goal in hypertensive patient has created a paradigm shift in the CVD treatment development. FDPs, polypills, and the novel therapeutic agents offer promising solutions as the treatment of hypertension. And future of hypertension to close the gap between the new stricter BP goals and the current suboptimal rates of goal BP achievements. So to summarize, the antihypertensive drug selection plays significant role in management of hypertension. Antihypertensive drug selection, comorbid conditions, patient's age, gender, other ongoing medications, contraindication, patient clinical condition are the major criteria that help to decide setting a drug selection for the treatment. Thank you very much.
Thank you, Dr. Sharma, by sticking to the time and wonderful disposition on pros and cons of combination therapies and also the new treatments on the block, which are up the pipeline. We'll move forward to Dr. Piyush Jain, who is going to talk on nocturnal hypertension. What do we know and what can we do? I'll request the audience that if they have questions, they can start putting the questions for all the speakers into the chat box so that we can, after the session, start the questions. Thank you.
So thank you very much, Sanjay. Can you see my slides?
Yes.
And can you hear me also?
Yes.
Yeah. So this subject of nocturnal hypertension has been dealt with as an introduction in one of the previous talks. And I'm going to dilate upon this further. And it's a very exciting topic for me because it gave me a lot of opportunity to learn new things. So coming on to the topic, just a minute. Yeah. So as has been alluded in the previous talk, in healthy subjects, the nighttime blood pressure decreases by 10 to 20% of daytime blood pressure. And this is referred to as dipping. So how do we actually calculate dipping? Because both systolic and diastolic blood pressure fall. The dipping is actually calculated by the degree of fall in systolic blood pressure, though there is a fall in both systolic and diastolic blood pressure. That is one point that needs to be remembered. It has already been said that the mean nighttime blood pressure below 120 and 70 is considered to be normal according to the European guidelines, and 110 by 65 millimeters of mercury or below according to the US guidelines, and anything above that is called nocturnal hypertension. But that is not the whole story. So you have, different blood pressure patterns. If you do an ambulatory blood pressure monitoring, a normal dipper will have a 10 to 20% fall in systolic blood pressure. And if there is a decrease in systolic blood pressure by less than 10%, such a person is designated to be a non-dipper. But there are certain patients who actually show an increase in systolic blood pressure and of course diastolic blood pressure in most of the instances, and these are called reverse dippers. There is another category which is less common. It's called extreme dipper. Now extreme dippers show more than 20% fall in the systolic blood pressure. Now what is the prevalence of these different nocturnal BP patterns? According to the data derived from the Indian ABPM study, and this is an India specific study consisting of 27,472 patients who had undergone ambulatory blood pressure monitoring, as many as 46% of the hypertensives, they have a non-dipping pattern, which is quite alarming and something which is not diagnosed unless ABPM is done. Reverse dipping was observed in about 13% patients and extreme dipping 5%. Now this dipper pattern is not limited to people who don't have hypertension. Even patients with hypertension, they also often exhibit the dipper pattern, but provided they don't have end organ damage. Those with organ damage, they often exhibit the non-dipper pattern. Now, I just want to have a word about extreme dipper because I'm not going to refer to this again. Extreme dipping, though uncommon, is a very important factor to consider during ABPM because it not only increases the risk of stroke, but in a more subtle manner, it does increase some specific complications. And one of the specific complications in the long run in extreme dippers is anterior ischemic optic neuropathy, which leads to a decrease in the optic, the visual, efficiency of a person over a number of years, and that may be related to long-standing hypertension with extreme dipping pattern. This also leads to cognitive impairment, and importantly, just because the nighttime blood pressure is very low, even the normal morning restoration of blood pressure in the early morning actually may be perceived as morning surge, and this may result in increase in the cardiovascular events because of this marked difference between the nighttime blood pressure and the early morning blood pressure. So let me go forward. So nocturnal hypertension has already been defined as an average of nighttime blood pressure of more than or equal to 120/70 according to the European guidelines, and average of nighttime blood pressure more than or equal to 110/65 according to the American guidelines. But there are, patients who show normal clinical or home blood pressure during daytime, but if their blood pressure is checked during the night time, you find that their average blood pressure is actually high. There is a nocturnal hypertension with both clinical or morning, home blood pressure less than 130/80, and these are called isolated masked nocturnal hypertension. So there are different varieties, but the crux of the matter is that nocturnal hypertension consists of an average blood pressure more than the limit set by European and American guidelines. The isolated masked nocturnal hypertension is actually estimated to be as prevalent as about 12% in the hypertensive population according to the Indian data. So a very important problem, provided it does increase the risk, it has got some prognostic value, and it does have prognostic value for sure. I will tell you in a few minutes. So the average nocturnal blood pressure actually does not really tell us everything. Now, you could say that it is the nighttime average blood pressure, which is average of all the readings that are taken during nighttime. And if this limit is not exceeded, you could say that this patient does not have nocturnal hypertension. But basically, during sleep as during daytime, blood pressure is something that is a highly dynamic variable, and it is affected by many things. It is affected by many things, and there may be brief nighttime surges. And if you look at the average, you may not find and you may not capture these brief nighttime surges, which may also be important, or rather they are important. So instead of showing the details of this graph, I have just summarized the other modulators of circadian rhythm of blood pressure besides salt sensitivity, which is one of the most important factors in causation of nighttime blood pressure. And these are basically blood pressure surges triggered by obstructive sleep apnea with apneic spells, sleep interruption or arousal during nighttime, insomnia due to physical and psychological stress, nocturia, older people particularly get up 3 or 4 or 5 times during the night time. And all of these lead to episodes of brief increase in blood pressure, and this may contribute to nocturnal hypertension. But if they are not very common and not very frequent during nighttime, all you may get is an average nighttime blood pressure, which does not fall into the category of nocturnal hypertension. So one has to actually look into these things. Unfortunately, ABPM takes blood pressure estimations at fixed intervals. Average generally is taken after readings taken every half an hour. For research purposes, you could reprogram it to 15 minutes, every 15 minutes. But it is not triggered by things like hypoxic spells or a fall in, or pulse rate, or an increase in pulse rate, or changes in the patterns of the sleep, like REM sleep versus non-REM. So we need to actually look into this more closely, and there are methods now available which can tell us what is actually happening throughout the night, and not only at fixed half an hour interval or 15 minutes interval. Now, one quick point regarding the morning blood pressure surge. Now, how do we define the morning blood pressure surge? Well, it is basically a difference between the mean morning systolic blood pressure minus the mean nighttime systolic blood pressure. When does it become significant? It becomes significant when it is more than 90th percentile in studies done in the general population. I already said that exaggerated morning surge is associated with extreme dipper pattern because of the marked difference between the two. But here I would just like to say that even a blunted morning surge is also reported to confer a risk of cardiovascular events, and I did not know about that. And this may be because of the fact that if there is a blunted morning surge early in the morning, when the person actually gets up and starts doing his day-to-day course, it may lead to a rebound increase in blood pressure, and that may also be deleterious. And this is most often seen in patients who have got orthostatic hypotension due to autonomic dysfunction, and other varieties of autonomic dysfunction. Now, what are the determinants of nocturnal hypertension? Now, as I said, high salt intake is the most important factor, but high salt intake added to aging, leading to stiffness of the arteries, and importantly, increase in the salt sensitivity with aging, diabetes mellitus, chronic kidney disease, and obstructive sleep apnea. So these are the most important factors, but there are so many other determinants. But here, these are the most important factors. The corollary I derive from this is that when we are following up a patient with hypertension, we should actually be doing an ABPM at least once on treatment in patients who are aged, those who have diabetes mellitus of long standing, those who have suspected or proved obstructive sleep apnea, and chronic kidney disease. Because if we don't do that, it is possible that we may just measure the daytime blood pressure, either clinical blood pressure or home blood pressure, and think that the blood pressure is under control. But what actually we are doing is we are converting hypertension into a masked hypertension, masked nocturnal hypertension, which if untreated may have a lot of a prognostic significance.
Dr.
So,
Piyush,
I will just take 2 minutes because it's a very important topic. So salt sensitivity is a very important thing, and it has got prognostic implications. We know that it trigger the cardiovascular events, but in addition to cardiovascular events, it also causes subclinical organ damage. And this may take the form of silent cerebral infarcts, microbleeds, white matter disease, psychocognitive dysfunction, hypertensive heart disease, vascular damage, and CKD. So tracking by ABPM is not enough. A home blood pressure instrument that can actually measure the blood pressure and the patient can keep it for long periods or even own it, it has been developed. That is one message that I want to give. Secondly, there are research tools which actually can measure the home blood pressure during night time, triggered by either hypoxia or by extremes of pulse, and therefore they are very useful in patients who have got particularly OSA. Managing, now this is the last point that I will say. Managing, we don't have specific guidelines for that, but for that it has been suggested that you need to look into the pathophysiology, and if there is an evidence for circulating volume increase, then salt restriction, diuretic, MR receptor blockers, or a sacubitril valsartan combination, that is, or SGLT2 inhibitors might be a good therapeutic, strategy for those. Those who have got vascular disease, calcium channel blocker, particularly given at the night time. Those who have got OSA and sympathetic activity, CPAP may be beneficial, but sympatholytics, and there is a potential role for renal denervation in them. And for insomnia needs to be treated. So to conclude, instead of going into trials which are actually in the initial phases and not enough to tell us how to treat nocturnal hypertension, I would like to say that nighttime blood pressure is often a variable, and it is because nighttime is a blind spot in terms of monitoring the antihypertensive therapy. But it is an important therapeutic target to prevent CV events, especially heart failure and stroke, as well as age-related organ damage such as CKD and cognitive dysfunction. So I thank you for your patience. I'm sorry, Sanjay. But,
no, that's all right.
Yeah.
Wonderful talk, Dr. Piyush. I think it was a important talk also because very less realized and less understood nocturnal hypertension is Pandora's box, which is going to possibly have a lot of ramification in the future. I'll request now Dr. Vinayak Agrawal to deliver his talk on difficult to treat hypertension, new insights and therapeutic perspective. Again, a reminder to the audience, if they have questions, please ask. Although we are going to be running out of time, but a few questions we can take. Dr. Vinayak. You are muted.
Thank you very much. After some really wonderful talks, I'll quickly move on to this very important topic of difficult to treat hypertension, and will dwell on the new insights and therapeutics perspectives also. Now, if you look at the hypertensive population in general, there is a population which is controlled, and then there is a huge amount of population which is actually uncontrolled. Within the parameters which are defined by various societies, which again I'll be touching upon to show you the variability in them. And a part of them is an uncontrolled, difficult to treat hypertension. There is a set of resistant hypertension, which can be pseudo hypertension or true resistant hypertension. And let's just dwell on these aspects as we go along. So if we look at the umbrella of hypertension, about 10 to 30% of these patients can be difficult to treat. We may not label them as resistant hypertension because that has a significant, there is a particular definition for it. But then there is a definite set of people who do not actually achieve the target blood pressure control that we want to achieve. Now, the problem is that there are no uniformity of guidelines or even recommendations. And look at these guidelines which have come up in the last 2018 to 2020. So ACC, AHA, and ESC in 2018, look at the definitions of blood pressure are variable. Normal is the same. So one defines it as normal, the other is optimal. One defines elevated as 120 to 130. The other one calls it normal. There is no grade 3 hypertension in ACC-AHA classification. And there is a variability in target blood pressure in various subsets like CKD, etc. Now, if you look at the Japanese society, they take a middle path. They do have a grade 3, which is very similar to European guidelines. And ISH, which was the latest guidelines, have no grade 3. They're more close to ACC-AHA. So the fact that you have topmost guidelines by the topmost societies, which are variable in nature, just adds on to what you call as properly treated hypertension at all. Now, in 2021, very latest, just last month, we have a sprint sub-study which shows that what were the factors which came out in patients who failed to achieve the intensive blood pressure targets as in sprint. And if you look at the age, patients who were elderly in the age of 70 to 80 and above, with more systolic blood pressure at baseline, CKD patients with initial cognitive impairment were more likely to have failure to achieve the intensive BP targets. And also the patients who had initial serious adverse events were also unlikely to achieve, like for example, CVA, etc., were unlikely to achieve the target blood pressure. On the contrary, those who did achieve or who are likely to achieve are the Hispanic ethnicity and the BMI people with BMI more than 30 were actually more likely to achieve the blood pressure control. There is also an issue of automated office blood pressure measurements, human errors, and how you sit. So there was a red chip improvement in BP measurement program, which was published in 2021, and they've shown how important it is to sit properly, back supported, uncrossed legs, the monitor, the cuff at the level of the heart, and they have, how you measure the 3 measurements and you take an average of them. All these things have been emphasized upon in terms of blood pressure control. Now, when we come to resistant hypertension, there is another problem. It's quite arbitrary. Again, the European and the American guidelines differ. On an average, we define resistant hypertension as patients who achieve blood pressure goal with optimal doses of 3 or more than 3 antihypertensive agents, out of which 1 should be a diuretic. There is another definition which says if you have uncontrolled hypertension with 4 medication classes. So if you look at the various criteria of AHA and ESC in 2018, you can see that the concurrent use of 4 antihypertensives is not part of ESC. They have they need a compulsory need of a diuretic use in combination with ACE or ARB and a calcium channel blockers to be labeled as resistant hypertension out of the 3 antihypertensive drugs which are being used. The pathophysiology of such difficult to treat hypertension involves the RAS SNS system with sodium retention, RAS activation and SNS activation with increase in the heart rate, especially like as Dr. Piyush showed, the nocturnal hypertension. So you can have either vascular resistance going up or the excessive volume, which can be salt sensitive. renin-based, etc. So the overall resistant hypertension can be apparent treatment-resistant hypertension, where you have to rule out the white coat hypertension, rule out non-adherence, and only then you will label them as true resistant hypertension. The non-adherence is a very important thing. Cuff-related artifacts, osseous phenomenon due to hardening of the arteries in an elderly individual, and white coat hypertension are very, very important aspects before you start labeling them as resistant hypertension. If we go by the trials, the average prevalence of resistant hypertension is about 30%. And if you go by the recent trials where they take the apparent treatment resistant hypertension, it's about 15% or so. There is a definite need for ABPM in these patients, as has been already elucidated, so I'm not going to go into that. That also shows 70% resistant hypertension in these patients, who tend to have much more mortality, CKD, CVD, heart failure, stroke, death because of uncontrolled hypertension. There is another even more sinister variety of uncontrolled hypertension, the so-called refractory hypertension, where you're using more than 5 drugs, including diuretics and MRAs. And they also have increased target organ damage, mortality, CKD, CVD. There is a secondary causes of resistant hypertension, like OSA is very common in almost 60-70%, primary aldosteronism, renal artery, renovascular hypertension, drug-induced, alcohol-induced, and thyroid, which can be probable causes of secondary hypertension. How do you treat them? First and foremost, and very, very important, is the lifestyle changes. Weight loss, very, very important. Moderate intensity exercise of 30 minutes, at least 5 to 7 days, about 150 minutes is what is recommended minimum. Salt restriction, alcohol restriction, and high fiber, low fat diet. In fact, REGARD study and a lot of other four of these studies are ongoing about the effect of exercise on resistant hypertension. Drug adherence, as I've said, is very, very important. Almost 50% patients tend to be non-adherent and non-compliant. So suboptimal treatment is one of the major risk factors for uncontrolled or difficult to treat hypertension, so-called. The treatment of the resistant hypertension is based on the same ACD. So you have a diuretics, calcium channel blockers, ACE inhibitors, or ARBs. The fourth line has to be aldosterone or eplerenone MRAs, and then the fifth line, like beta blockers, labetalol, alpha blockers, etc., will come in. If you look at the most rational treatment, we have to use the ACD. We have to also look at the fact that aldosterone has, in various clinical trials like Pathway 2, has shown significant benefit in resistant hypertension in the dose of 25 to 50 milligrams. There is a tremendous underutilization of diuretics in these patients, and chlorthalidone and thiazide-like diuretics are preferred over hydrochlorothiazide. Diuretics can be used in CKD. So if you look at the drug combinations which we should avoid, one is beta blocker with thiazide, which may precipitate diabetes, and ACE with ARB, of course, we know in on-target trial was not recommended. The other secondary hypertension causes, which we have just mentioned, I'll quickly go through. So renal artery stenosis, again, controversial treatment because most of the STAR, Astral, and Coral trials did not show stenting to be much of benefit. However, it still remains valid for flash pulmonary edema, resistant hypertension with bilateral or unilateral renal artery stenosis, which is not being treated with 3 or more drugs, including diuretics. CKD, we should have, the master plan study has shown that there is a 15% increase in CVD and in these patients in heart failure. And these patients should be treated with, if they have albuminuria, then ACE inhibitors actually preferred over ARBs in the AHA classification. And ARBs only if they're intolerated. The ACE inhibitors are not tolerated. FIO, we usually use the surgical resection of adenoma. We use phenoxybenzamine alpha-adrenergic blockade, which is followed by beta blockers. Never give beta blockers before phenoxybenzamine or alpha-adrenergic blockade. And if you have crisis of hypertension, nitroprusside and phentolamine are preferred. The primary aldosteronism is very important, seen in almost 20% of patients with difficult to treat hypertension and resistant hypertension. And these patients, we have to do the plasma renin activity, PRA, as well as the aldosterone levels. And if the PRA level are less than 1 nanogram per ml per hour, along with the plasma aldosterone levels of more than 15 nanogram, or the ratio is more than 30, then we can consider hyperaldosteronism, and then there is an algorithm to diagnose them. Obstructive sleep apnea is very, very important mechanism because it has various SNS activity, RAS activity, nitric oxide decrease, leading to nocturnal hypertension, non-dipping, and increased BP variability. The treatment remains CPAP, mandibular advancement devices, renal denervation, which has recently come in, and of course the antihypertensives that we have just discussed. There is a bariatric surgery which has shown to be of benefit in these patients, like by Gateway RCT. Some of the devices which have been proposed are baroreceptor stimulation.
You'll have to wind up.
Just to 1 minute more. Baroreceptor stimulator, BAT, VNS, spinal cord stimulator, and of course renal denervation therapy, which has been controversial because most of the trials had failed to show any blood pressure lowering effect in the previous studies. Recently, the spiral HT on, off, and radiance HT and solo have shown some benefit of renal denervation therapy. The Taiwanese society has in 2019 come up with so-called RDNI2, which is a preferred in patients who have resistant hypertension, who are showing target organ damage, non-adherence, who are intolerant to blood pressure drugs, and of course secondary causes which are not being treated. In them, you could use or consider RDN or renal denervation therapy. Another drug, which is firibastat, is also being used in one of the trials as antihypertensive. And the last 30 seconds, what we have latest in 2021 is the Morgam project, which has shown that the diastolic blood pressure adds to the systolic blood pressure in prediction of composite cardiovascular endpoints. So diastolic blood pressure remains important in less than 50 years of age. There is also polygenic risk scoring, which is being used or proposed to define patients who are at increased risk of future events. And calcium score more than 0 is also one of the risk factors where you could start statins in these patients early on, even outside the gamut of the guidelines. So the last slide, the future of blood pressure control will be an accurate measurements, medications, and device therapy and their interplay. Thank you very much.
Thank you, Dr. Vinayak. I think it was really difficult to treat hypertension and still a lot of problems which it poses. We are already short of time. I'll request the other panelists, Dr. Sandeep Singh, Dr. Ajay, to give short comments, and then when we can wind up.
I think all the speakers have done a wonderful job, and time is less, so we cannot go into the detailed discussion. Just one question I would like to ask from Ashwani, because he said that there is unaware hypertension which is bothering our society a lot. So what does he feel that, I mean, a person should be recommended to check his blood pressure? Is there any recommendation from our society or from an international society?
Dr. Ashwani Mehta, please.
I don't see Ashwini's name on the list. Vinayak, would you like?
Maybe we will discuss it. Yeah, Vinayak or anyone else can comment, or maybe we'll discuss it sometime later. We can move to the next. It's already 10 minutes late.
Yeah. So thank you everybody. Wonderful talks on all 5 very important topics regarding hypertension, a menace, and I think we'll close the session now. Thanks. Back to the organizers.
Thank you, Dr. Sanjay, for a great job, and all the panelists, Dr. Sandeep Singh sir, and everyone, and all the speakers for joining us in this session. Now we go on to the next session, lifestyle and preventive cardiology. And we have the chairpersons, Dr. Sanjay Sood, Dr. Sarita Gulati, Dr. R.N. Chabra, and Dr. M.D. Gupta. And we have all our speakers. And I just request that speakers, if they stick to time, we will have some time for the discussion also. So I request the chairperson to please start the session.
So first topic is optimal consumption of the salt, quantity and type, does it matter? This is under lifestyle and preventive cardiology. Speaker is none but less than Dr. Satyavir Yadav. I request Dr. Satyam Yadav to start his talk, and the time duration is 8 minutes, and the question answer will be discussion for 12 minutes at the end. So I request Dr. Satyam Yadav to start the session. Satyam Yadav.
Good afternoon, everyone. We had a wonderful first session. Now I'll be starting the second session, and the topic is impact of sodium on cardiovascular health. So the first,
sir, please share your screen, sir.
Am I audible or visible?
Yes, sir.
Yeah,
yes,
audible.
sir. Please share your screen,
My
sir.
slides are visible?
No, sir. Please share screen, sir.
Subsid, you have to share the screen.
Yeah, sir, I'm sharing.
The button at the down.
At the center bottom wherein you can share your screen.
Now is it visible, sir?
Please go ahead quickly. Please.
Yes, your screen is visible. Yes. So current intake of sodium is around 4 gram per day, which is a relatively recent phenomenon. Paleolithic humans used to consume less than 1 gram of sodium, and this current intake of sodium came into existence when the preservation of food by salt came into existence. And after that, the current intake of sodium is around 4 gram, which is equivalent to 10 gram of salt. And salt intake is related to very historical things like famous Dandi March by Mahatma Gandhi, which was due to high salt tax imposed by British government. So it has a historical importance also. So there are many sources of dietary sodium. Obviously, salt is a major part of dietary sodium. Apart from salt, glutamates, which is a flavor enhancer, and phosphates, which used as emulsifier, are also part of dietary sodium. So there were some studies in US population to identify what's the major chunk of their diet sodiums comes from. So around 2/3 of US population consume processed food, and their sodium comes from the processed food. Another study which was published in Circulation in 2017 also concluded that the most of this sodium in their diet comes from while added outside the home. So in these population-based studies, there are some methods of measuring sodium measurement. There are two methods of measuring sodium measurement. One is diet and another is by urine. So out of these methods, there is the most accurate method is the 24 hours urine collection, which should be done repeatedly in these population-based studies. So our main question is, does dietary sodium truly results in high blood pressure? So this relationship is not straightforward because there are multiple factors involved in it. So this slide is showing the proposed mechanism of target organ damage in high sodium. It generally causes structural changes in heart, kidney, and blood vessels, and it leads to increased blood pressure. So InterSalt study was the first major study was done to define the relation between 24 hours urine sodium excretion and blood pressure. So it was done in around 10,000 participants across the world. And it showed that excess consumption of sodium more than 5 gram per day, which is equivalent to 1 small teaspoon of the salt, causes increased prevalence of hypertension and increase in systolic blood pressure with age. And after that InterSalt study, another study, DASH sodium study, which was a short-term study and involved around 400 patients. And it also showed the same effect as InterSalt study showed. And the effect of sodium intake was irrespective of the races and ethnicity, and it was equivalent in men and women. As we can see in this slide, that when there were 3 subgroups in DASH study: high, intermediate, and low sodium intake group. So low sodium intake group was less than 2 gram per day. So when the diet changed from high to low, the change in systolic blood pressure was around 4 mm of Hg, and it was throughout the all subgroups. After that, large study, pure study came, and it studied around 1 lakh adults across 5 continents, and it also showed that there is positive but non-uniform association between sodium and blood pressure, but the relationship was much more steeper than intersalt study. The main difference between intersalt study and pure study was that their method of dietary sodium estimation was a spot fasting morning urine specimen rather than 24-hour sample, which was taken in intersalt study, which undermines the importance of this study. But it's not possible to take 24-hour samples in such a large study. And one important aspect of this study was that the most of the population was from China. So first time they included population from Asian subcontinent, and the results were similar to the global population. So after these studies, there are some meta-analysis which also studied the effect of salt reduction. And in this meta-analysis, as we can see, those who were hypertensive patients, the reduction in sodium intake led to around 4 to 5 mm reduction in the systolic blood pressure and around 2 to 3 mm reduction in diastolic blood pressure. While in normotensive patient, the reduction was not that much significant. It's around 2 mm of Hg in systolic blood pressure and very minimal in diastolic blood pressure. Another meta-analysis showed that if we reduce the 4.4 gram salt per day in the diet, the systolic blood pressure reduces around 4 mm of Hg and diastolic blood pressure reduces around 2 mm of Hg. And this reduction in the blood pressure is statistically significant in all age group and in hypertensive and normotensive both groups. After that, there is an important subset of hypertensive patients who have salt sensitivity. Around 50% of hypertensive patients are supposed to have salt sensitive blood pressure, and especially low renin hypertension, older age population, obese people, and metabolic syndrome people tend to have more salt sensitivity. So this concept of sodium sensitivity and blood pressure resistance came after this article by Weinberger. So they measured the blood pressure after infusing around 2 liters of normal saline, and after that there was low sodium diet along with the furosemide administration. So those persons who had reduction of more than 10 mm Hg in the mean arterial pressure and were considered as sodium sensitive, and while those who had reduction of less than 5 mm of Hg were considered as sodium resistant. But this sensitivity also influenced by other factors in the diet like consumption of potassium or calcium, which may attenuate or potentiate the effect of salt sensitivity. So it has been proved that sodium intake is strongly associated with high blood pressure, but whether this hypertension culminates into cardiovascular risk reduction is still questionable. Although we all know that hypertension is a major cardiovascular risk factor and it should reduce the cardiovascular event also. So there are some studies that I will discuss about the reduced salt intake and decrease incidence of cardiovascular events. So first was this study by Cook et al. And it was a long-term study.
Please
wind up. They followed the patient for around 48 months and they found that it also reduces the long-term risk of cardiovascular events. And another study by Bibins et al. In which was published in NEJM, it also showed that around 3 gram of reduction in the dietary salt causes around 15 to 20% reduction in cardiovascular events, and it was across all the groups, but obviously it was more significant in black people, black and hypertensive people.
Dr. Yadav, can we wind up, please?
Yes,
can we wind up?
Just 2 minutes, 2-3 minutes.
Time is very limited.
So apart from this sodium effect, they also compared this effect with other factors like smoking cessation, weight loss, and statin therapies, and found it to be significant. So I'll quickly go through next slides. So there is a meta-analysis also which showed that if you reduce salt by 2 grams per day, it decreases the cardiovascular events by 20%. But obviously there are some limited observational studies also which showed that if we decrease the sodium intake to less than 2 grams per day, it might increase the prevalence of cardiovascular disease. And the main reason behind this, because up to an extent, when we reduce the sodium below 2 grams per day, it causes the activation of hormones and lipids, and it may activate the RAS system, which might mitigate the effect of, which might mitigate the positive effect on cardiovascular disease. And one more thing, that the fall in blood pressure in normotensive patients is not that much. One recent study which was published in European Heart Journal.
Dr. Yadav, come to the conclusion.
Thank you.
Yeah. Sir, I am coming.
Conclusion, please.
Already on.
So just 2 more slides, sir. So WHO recommends that sodium intake should be less than 2 grams per day, and AHA recommends that it should be around 2.3 grams per day, and ideal should be less than 1500 mg per day. But I'll come to the concluding slide. So it's obvious that high sodium consumption and associated with decreased sodium consumption increase the...
Dr. Yadav, we are already running out of time. Kindly show the conclusion slide, or we will move on to the next speaker, please.
Ma'am, this is the conclusion slide only. So the main source of our diet is dietary sodium comes from salt, and the principal benefit of salt intake is reduction in blood pressure only, but there are lack of large randomized control trial which show the reduction in the cardiovascular events. So we need to have more large RCTs before we can say that it definitely reduces the cardiovascular events. So till then, the current evidence is that we should keep our dietary sodium from 3 to 5 grams per day, and it's too early to say that we should reduce this sodium intake further from 3 grams per day.
Thank you, Dr. Yadav.
Thank you, Dr. Yadav.
Thank you. Now the next speaker is Dr. Subhendu Mohanty, and the topic is exercise, how much, how intense, and current evidence.
Hi sir, Dr. Subhendu Mohanty is not available at this moment because of an emergency. So we can move to the next
Dr. Preeti Gupta, is she available? Dr. Preeti Gupta.
Yes, sir.
Topic is saturated fats, still searching for the sweet spot in my field.
Are my slides visible, sir?
Yeah. They're visible.
Yeah,
yes.
Yes.
Please go ahead.
Please.
And kindly stick to the time.
Definitely,
stick
ma'am.
to the time. Yeah.
Definitely, ma'am.
Thank you.
Yeah. So saturated fats, this is a very controversial topic, and we are still searching for the sweet spot in my diet. And the controversy can be imagined by the fact that the Dr. Salim Yusuf's talk on the Pure trial was removed from the official YouTube video of the conference he discussed the Pure trial. So we start with the background that most of the data is from the developed countries like the North America and the Europe. And LDL is considered a surrogate market for the cardiovascular disease. So what the current guidelines say, that the 2019 ACC/AHA guidelines say that the replacement of the saturated fats with dietary monounsaturated fats and polyunsaturated fats can be beneficial to reduce the atherosclerotic cardiovascular disease. So we being a poor country, can we totally replace the saturated fats, which is very much available to us in the form of the dairy fats or the animal fats, by the carbohydrates? So we'll see the evidence which is available with us. So in pursuance of these guidelines, now we have a lot of fat-free products available in our market, which are actually not fat-free. We are consuming more of refined starches, more of added sugars, more of refined flours in the form of these sauces, and it results in more of triglyceridemia, decrease in the good cholesterol, increase in obesity, and the increase in diabetes. So this is the food pyramid which we are currently following, that more of carbohydrates, fruit and vegetables in 3 to 4 servings, milk and meat products 2 to 3 servings, and fats and oils to the barest minimum. What I need to emphasize here, that it is not the total fats, it is the type of fat which is very important. We need to reduce the trans fat in our diet, and the trans fat is available in the so-called healthy food which are available in the market. So you see the pre-prepared salads, you see even the whole grain brown bread which we are taking, which has a lot of fats in it, which is actually the trans fat which we need to reduce, because trans fat is directly correlated with the cardiovascular disease, and we need to have a strict control, and the partially hydrogenated oils need to be very strictly banned in our country. And this is a pic from the FDA, which is showing that what is banned all over the world sells in India. So when other countries, even 2% of the trans fat is banned, in our country, it's the only country where even 5% is allowed. So I come back to the 7 countries study, in which the 7 countries all were the richest, and they showed an increase in the cardiovascular disease. And amongst those, the lowest incidence of the cardiovascular disease was from Crete and from Japan. Now, Crete had the highest total fat intake, which was at least up to 30% of the food. Well, the Japan had the very low fat intake, but both had the lowest incidence of the cardiovascular disease. So that means there is something which we are missing. There is a gray zone which needs to be captured. We go to the Women's Health Initiative trial, which show that there is no benefit of a low-fat diet on a heart disease, stroke, or the cardiovascular disease. So now we have 4 large international studies which had covered more than 2 lakh patients, like pure, on-target, inter-heart, and inter-stroke, and all have shown that the saturated fats, they decrease in total mortality, they decrease in the stroke, and they have no significant association with the cardiovascular disease or the cardiovascular mortality. So these are the spline curves available with us, in which we can see that when the carbohydrates are increased, there is an increase in total mortality, there is an increase in major cardiovascular disease, while with the saturated fats, there is a plateau and there is a no significant association of the major cardiovascular disease or cardiovascular mortality. So they had compared with the lowest intake with the highest intake, and especially in the Asian regions, which are poor countries, there was decrease in total mortality. There was no increase in the cardiovascular mortality. And when they replaced the carbohydrates with the saturated fat acids, there was decrease in total mortality and there was no increase in the cardiovascular disease. With such a robust data, these results, they have shaken the world, that the high carbohydrate intake increases the total mortality, the high fat intake decreases the total mortality, and there is no association with the risk of myocardial infarction or the cardiovascular disease related mortality. So the pure study shows that the greater fat intake and even the saturated fat intake was protective, more carbohydrates were harmful, high fat dairy was beneficial, saturated fat from the meat was neutral, and more vegetables was not any better. Like, we can't increase the carbohydrates to up to 70% of our diet and decrease the saturated fats to the lowest minimum. So we need to make a balance about it, being a poor country and with the milk being available in our country, while in other countries they are advising milk to reduce even to 1% or 2% of the diet. We in our country, we would advise milk to be taken at least 3 times a day. Another study, Pyramid study also, in which the Mediterranean diet was there, and in which the olive oil was more than 4 tablespoons per day, and in low fat diet it was less than 2 tablespoons per day. You can see that the Mediterranean diet reduced the cardiovascular endpoint by up to 30%. So, which fats to choose in our diet comes to be nuts, seeds, avocado, fish, dairy foods. And I conclude by saying that the saturated fats in moderation are good. MUFA is preferred. Fruits are protective. Carbohydrates are used in moderation. Vegetables are neutral. And we need to evolve to a hypothesis in which we just can't culminate all the culprit to be saturated fats. And we need to see the HDL ratio, the triglycerides, the ApoA1B ratio, and the non-lipid factors like the blood pressure, endothelial function, oxidative stress. They all need to be taken into consideration because it is a multifactorial disease and not just one. Thank you so much.
Thank you, Dr. Preeti. The message conveyed very well in a very comprehensive manner. That's really good. Nice. Any questions? Or we move on to the next speaker.
So
next speaker is Dr. S.C. Manchanda. Oils in my diet demystified. We have Dr. Manchanda with us.
Yes. Yes, Professor.
Trying to get my slides.
Good afternoon, sir.
Good afternoon.
Please share your slides, sir.
Trying to get my
slides
on. No. You have to tell me how to share the slides, okay?
Sir, at the center bottom, you will see a share screen option.
Share screen.
Green color, green color.
Okay.
Yes. Now we can see your slides, sir.
You can see my slides. Okay, thank you.
You can.
Let me just increase it as much as I can. I'm very poor in this. Is that all right?
Yeah, it's okay.
Visible, yes.
Yeah.
Well, thank you. I'm going to talk about a very controversial subject called oils in my diet. We have very little knowledge about this, and even the guidelines don't tell us too much about these oils. But selection of a healthy oil could be very significant in causation of heart disease and prevention of coronary heart disease. Actually, American Heart Association says if you use a proper mix of fats, then it can be as effective as statins are. Now, how to select a healthy oil? When we go to the market, we see a plethora of these oils with all sorts of claims, and one is confused. Not only general public is confused, but also the doctors as well as the nutritionists are confused. And there are no two doctors or two nutritionists who will agree to which is the better oil. Now, to find out which is a good oil, I think we have to know three characteristics of the oil. One is the fatty acid constituents of the oil. We have to know whether it is refined or non-refined. We have also to know what is the method of cooking. Like in India, we have frying as most of our cooking, which is subjected to high temperature. So our oils will be different than in the Western countries. I will talk about the Indian oils mostly, what is true in the Indian subcontinent. Well, these are comparison of oils. This is a chart which is prepared from National Institute of Nutrition, Hyderabad, by Dr. Gafur Nisa. There may be slight variation in the other charts that you see sometimes. So there are, these are fatty acids are three types: the saturated fatty acid, the monounsaturated, and the polyunsaturated fatty acids. So there are several oils which are rich in saturated fats, like coconut oil, like palm oil, and AC ghee. They have been considered bad by the American Heart Association, but as you heard from my previous speaker, they may not be bad. The second are the oils which are rich in monosaturated fats and polyunsaturated fats. They are supposed to be healthy because they decrease the cholesterol. But there are two types of polyunsaturated fats. One is called the ELNA, called the N3 or the omega-3, and the others are the N6 or linoleic acid. Now, oils which are high in ELNA, N3, are supposed to be healthy. And the highest ELNA is found in the mustard oil. If we use too much of omega-6, there is decrease in LDL, but also the HDL decrease. And too much of N6 can cause even atherosclerosis and even cancer and all. So the oils which are rich in UFA are considered very healthy, and the most important there is the olive oil, and then is the rapeseed and the mustard oil. Then even sesame and groundnut oils are high. We will discuss about them. So what is the ideal cooking oil? It should be low in saturated fats. I think that is questionable. You heard from Dr. Preeti also excellent talk. The saturated fats may not be bad, and I will also highlight that again. The oil should be rich in monosaturated and polyunsaturated fats. The polyunsaturated fats, I said, should be high in N3 type. And the ratio, which is recommended by various associations, which is cardioprotective, is N6 to N3 should be 5:1 or even less. Lesser the better. And it has several other. N6 and N3 are essential fatty acids which are not found in the body, and they have to be substituted. They do very important roles in our body. Of course, there should be no trans fatty acids, as you heard from Preeti. Also, unfortunately, a large number of cookies that we see and the products that we see have trans fatty acids, and I think the CSI must say that we should not accept that 5%. It should be stable at high temperature, high smoking point, and we should not use refined oils, but extra virgin. It should be low cost. Now, what is refined? Refined oil is made by chemical and mechanical process to extract the oil from seeds. It involves several chemicals which can be harmful to us, and it also exposes the seeds to high temperature up to 270 degrees multiple times. First for extraction, it results loss in antioxidant and sterols. As you know, oils are very rich in antioxidants and sterols, phytosterols. It can even produce free radicals, trans fats, and polymer compounds, which are atherogenic themselves, and they can even cause cancer. So one of the hypotheses, many people say refined oils are causing cancer because of these products. Unrefined oils are better oils. They're produced by hydraulic pressing or minimal heating. They're more nutritious and healthy because they retain the antioxidants and the flavor. And smoke point is very important from our Indian point of view. Temperature at which an oil starts to break down and burn. It is important for Indian cooking and deep frying, because if you use an oil with a low smoking point, it produce toxic effects. Refining increases the smoking point. That's the good point of it. But if the polyunsaturated rich oils like sunflower and corn, they decompose earlier than the saturated fats. So the oils like ghee and coconut oil are much better. Now let's talk of some of the oils. Olive oil is considered to be the best heart healthy oil. I think most of the associations do that. It has highest monosaturated fat 76 and reasonable saturated fats 13%. Several studies have shown it reduces LDL, increases HDL, reduces inflammation, thrombosis, and hypertension. Especially the extra virgin, which is non-refined, is supposed to have extra benefits because of phytosterols which are there. It has been shown, you saw the several trials, Peroperative also, that it can reduce the risk of coronary artery disease, both in primary and secondary as a part of Mediterranean diet. It has, unfortunately, extra virgin has low smoking point, although the refined one has a high smoking point, but we don't want to use refined ones. Secondly, it's costly, and it is low omega-3. So I think it's not an ideal oil for Indian cooking. So which is the ideal oil for Indian cooking? I believe it is the mustard oil, because it has the best fatty acids constituted, the highest monosaturated fats like olive oil. It has also low saturated fats, much lower, and highest ELNA, omega-3. It is 20 times higher than in olive oil. It is 10% as against 0.5%. And it has a very high smoking point, appears very, very ideal. But it has high uric acid. That's why it's not even allowed in the United States and many European countries. Uric acid has been shown to produce myocardial injury in rats. However, rats are deficient in enzymes which oxidize this uric acid. Other species, studies have been done by ICM or NIN, and man has not been shown to have any ill cardiac effects. And actually, a multi-center trial has shown that mustard oil may reduce. I will talk about this study because very few good studies on nutrition are there. It is cheap and appears best for the Indian. This is a study I would like everybody to read. This was diet and risk of ischemic heart disease. This was a collaborative study between Harvard School of Public Health, All India Institute, and St. John. 350 patients of acute myocardial infarction were studied, including their oil consumption, and 700 controls. And it was found that use of mustard oil was associated with lower risk of than sunflower oil by 71%. Myocardial infarction decreased by 71% in those people who were using mustard oil as frying as against sunflower oil, and even 51% in those who were using it. So there is some evidence that it is helpful. Canola oil is another good oil. It's rapeseed oil. It is closely related to mustard family. It has lower levels of uric acid. That's the only difference. It has an excellent.
Sir, unmute yourself.
Unmute yourself. Sir, unmute yourself.
Am I audible?
Yeah, yeah.
No.
Okay. Okay. So I was talking of canola oil. Like I said, extra virgin has a low smoking point, not very good for Indian cooking, although refined one has a high smoke point, but we don't want to use the refined one. What about ghee? It's a controversial thing. You see, it's high in saturated fats, as much as 65, but it's also high MUFA, about 30%. It has been shown to increase LDL and HDL especially. The LDL, which has been shown to be increased, is by high dosages. The moderate dosages, we did a study long back in All India Institute of Medical Sciences that replacing the usual 4 spoons of a polyunsaturated oil with a ghee does not change the LDL. So in moderate quantity, it does not. Even if those studies in which LDL has been shown to be increased, it is the high density LDL, not the low density. You know that low density LDL is atherogenic, so it is not. It has the highest smoking point of 250, extremely good for deep frying. However, has high saturated fats, which you just now heard may not be harmful. You saw the study which was done in India, and the more saturated fats will decrease the coronary artery disease, less saturated fats will. And total fats even are not that important because it has been suggested in the pure study 35%. And several meta-analyses, as you saw, have clearly shown that all the published studies do not show increase of coronary artery disease, stroke, or death because of saturated fats. Coconut oil is still more controversial. It's very high. It's the highest in 90% is there. But the saturated fats which are high are called medium chain fatty acids, which are different. They may not increase the cholesterol. Considered harmful by the American Heart Association, it is called as a poison. But on the other hand, it's being sold as a superfood in the United States.
Sir, can we conclude the slide? We are running out of time.
Okay, I will just do that. There are populations who use mustard oil 60%. They do not show increase in this. Then groundnut and sesame oil could also be used because they are rich in omega-3. But this is my final slide, the concluding slide. So what do I want to convey? I think the Indian cooking conditions you must understand subjects oils to very high temperatures like deep frying. Certain oils like refined oils rich in polyunsaturated fats, they degrade easily to free radicals, trans fats, and aldehydes, which are potentially mutagenic. So one should not use this for frying, although they have a high smoking. One should avoid the refined oil because refining subjects to high temperatures and they can have toxic products. Reheating of oil should be avoided as trans fats are produced. And healthy cooking oil for Indians appear to be cold compressed mustard oil. Other healthy oils are extra virgin olive oil, extra virgin canola oil, and maybe cold compressed groundnut and sesame oil. Ghee and coconut oil can be used in limited amounts for frying. And of course, one has to avoid trans fats. I hope I have demystified some of the points.
Thank you, sir, for a wonderful talk. Thank you so much. Now we move on to the next speaker, and it is Dr. Vishal Batra. He'll be speaking on polypills in CV health.
Thank you, ma'am. So is my screen visible?
Yeah.
Yes, yes.
So good afternoon, everyone. I'll be speaking about the polypills. So basically, this was some 6 months prior to the COVID pandemic when a large trial came, Polyiranian trial, where again the discussion which was started 2 decades earlier, it became again a hot topic, whether again the polypill reduces the incidence of heart disease and stroke, whether this is a feasible, well, whether this is a feasible or not. This debate started just prior to COVID, and within COVID pandemic, it was somewhere hidden. So basically, what is polypill? It is a medication that combines multiple active pharmaceutical ingredients. So basically, we can classify polypill in 3 types. One, either a single pill which contains an antiplatelet, aspirin, statin with multiple BP lowering agents. Second, it is only blood pressure lowering agents, 2 or 3 agents at low doses, either 1/4 or 1/3 doses. And the third one is a blood pressure lowering agent with a statin without aspirin. As aspirin has fallen out after the ASPRI trial and other things, it has fallen out of primary prevention. So this was another concept, that without aspirin, medication with lowering agent and a statin. So what are the approaches for polypill? The approaches can be either risk-based or a population-based. The risk-based approach is for a particular individual who are at high risk, therapy which is tailored according to the risk profile of the individual and which is tailored according to the some lab tests and clinical parameters like LDL, CRP and other things. And second one is population-based approach, which includes all population, which will intervene in all population, will help in a low-cost therapy with a lesser side effects, but it will be a mass approach for everyone without stratifying the risk. So this concept, when polypill concept came, the population-based approach was used for developing nations, but this was not feasible for developed nations where risk-based approach was more feasible. So from where this hypothesis came, like CVD, it is a large burden, more than 18 million deaths per year and almost 80% in the developing countries. Risk factors are graded and most of the medicines which are used like statin, beta blockers, ACE inhibitors and aspirin, these reduced CV risk by more than 75%. The hypothesis was generated by Wald and Law earlier in 2002. So where they hypothesized by combining all these 3 drugs, there will be 80% relative risk reduction for MI and stroke. So when you combine 3 BP lowering agents at half doses, they'll reduce 40% relative risk reduction in MI and stroke. Reduction of LDL by 1.8 millimole, again 40% relative risk reduction. Aspirin, 25% relative risk reduction. So the history goes back to 1970 when first potential polypill was aspirin and atenolol was used, but it was somehow fallen out. But then again in 2001, after this Wald and Law discussion, WHO and Wellcome Trust started to discuss about these polypills combining aspirin, statin and a BP lowering agent. So initial proposal was for mass approach, giving polypill to everyone more than 55 years of age, but which had a major controversy and it was never applied. So what all polypills we have available right now, most of them are from India, like Red Heart Pill 1 and Pill 2 from Dr. Reddy's in India, then Polycap 1 and 2 from Cadila, and there are 2 more from Cipla, Star Pill and Polypill. So the most studies are Polycap by Cadila Pharmaceuticals. They had Polycap 1 and 3 trial. So what are the advantages of polypill? The most important advantage is better patient adherence and reduction in complexity of the treatment, like multiple medications can be combined to one, ease of prescription. Most important is lower cost of medication. In developing nations, the cost of polypills is even less than $1 per day, which reduces too much of healthcare cost. And even this also prevents hospitalization also, resulting in a greater cost reduction. Then in terms of preventive strategy, mass prevention, entire population, which was never an upcoming idea because of side effects, because it will lead to a medicalization of healthy population. There will be adverse effects, fears of adverse reactions. So the preventive strategy was never given uplift. So it was always risk-based approach. So what are the drawbacks? In primary prevention, there are absence of studies which prove that there is efficacy of polypill as compared to other things. Difficulty in selecting doses and adjustment of dose, that one size doesn't fit all. Difficulty in identifying the suitable patients at primary prevention level. In secondary prevention, only issue comes with individualizing the doses, reaching the target doses. So sometimes this is the only hindrance in secondary prevention. Although ESC 2018 guidelines has given class 2B indication for polypills in secondary prevention, but optimization of doses always become difficult. So what are the new concepts for polypill? Who, which, and how? So first is initiation indication. This is the indication where the use of individual for whom all included drugs are recommended at included dose. The polypill can be initiated. Second is the step-up indication, in which for whom all included drugs are recommended at included doses but are not being taken, like patients who are not adherent to all those doses but they require all those doses which are in polypill, they can be stepped up to the polypill so that adequate doses can be given. And the third one is substitution indication. This is mostly for secondary prevention in people who are already stabilized on the same dosage of the drug that are in the polypill. So these three are the indications now: initiation, step up, and substitution. So in secondary prevention, it is always the step up, and the trials which supported this were Crucial trial, Impact trial, Kenyani trial, TIPS 2, and Empire. In primary prevention, it is either initiation or step up or sometimes substitution. And the trials which supported were Poly-Iran, TIPS, and Wald crossover. So coming to the issues with polypills, first is the pharmacokinetic issues. The efficacy of giving multiple drugs in a single pill has been proven, but there are some issues with that. Number one, whether all the active ingredients are safe and tolerable. Are there any drug-to-drug or drug metabolite interactions in the polypill which can lead to suboptimal effects or some toxic effects or some adverse events? Or is the bioequivalence or bioavailability of the all components are preserved or altered in a polypill? So these were the issues and which were mainly tackled by TIPS 1 study, which was phase 2 study, which revealed effect of all 5 drugs in the polypill. This was a 12-week study which showed that blood pressure reduction and reduction in thromboxane B2, which were used as a surrogate marker for antiplatelet, were equivalent in those groups. The second, but there was slight less reduction of LDL in this study as compared which was expected in the study. Then Empire study, this also showed that blood pressure reduction and cholesterol reduction was equivalent in the polypill arm. And the space meta-analysis, which showed slightly less blood pressure reduction, but a good cholesterol reduction in the polypill arm. So this was more or less equivalent, but some studies showing less cholesterol reduction, total cholesterol reduction. Then other outcomes data. So Polyiranian, this was the first large study which came in 2019, almost 7,000 patients.
Time is out.
Just combining all 5 drugs, which showed that it had quite effectiveness in the first CV events. Then came the Polycap study, in which more than almost 50% patients were for India, and it had a good long-term follow-up of 4.6 years and showed tolerability of polypill. And this was used in patients who had intra-heart risk score of more than 10. So they
kindly conclude. Dr. Batra, kindly conclude. Kindly conclude.
Yes, ma'am. Yes, ma'am. So coming to adherence, more than 80% patients were adherent in this polypill study, according to the space meta-analysis. Although some deterioration in renal function was observed, but this was not observed in space meta-analysis. So adherence was never an issue with polypill, and it was better as compared to the individual components. And cost effectiveness, which I have already studied, that it costs less than $1 per day and saves a lot of cost of hospitalization and outpatient department, which was studied in Empire population, Empire subset in India. So what are the barriers? This is my last slide. So barriers are reluctance of physician to prescribe, outdated trials, there are no current trials, the different dose, different versions which are not fit for everyone, and non-availability in the public health system of the polypills. So potential facilitators, how we can facilitate is multiple with different drugs. We can size the polypill according to the patient. We can change the doses of the drugs. Present in the government hospitals for reimbursement, low cost, and education of the physician as well as the patient. So whether the polypill contains atorvastatin 40 or 80 should not be the central discussion. The main part of the discussion is to have access to the polypill and to impact and follow the treatment to impact the global healthcare. Thank you.
So dear friends, the next topic is city coronary scoring in the CV health. As we are talking about the lifestyle diseases, so what is the role of this scoring? So I request Dr. Sanjeev Sharma, please. Dr. Sanjeev.
Good afternoon, dear friends, and I'll start moving, and because we're already short of time, and I'll be discussing a very important topic which is probably very underutilized in our clinical practice, that is a CT coronary scoring in cardiovascular health. Why we need this? Because we have a tremendous burden of cardiovascular disease in India, 50 million people, and there is a long asymptomatic period precedes any clinical manifestation. So it is of utmost importance to develop a screening strategy so that these asymptomatic patients before a clinically relevant or even fatal potentially event occurs. So how do we do that? Three groups need to be identified. That's a low risk, 40% of the population, as per the standard AS/CFS criteria. Intermediate risk, 40%, and high risk contains about 20% group. So this is the intermediate group, which is the one for screening is of greatest value. And how do we screen these patients? We have been screening them for cholesterol, CRP, and other things, but they are not found to be useful. So that's why we have come to this coronary artery calcification, that is the CAC. Why? What does it mean? What does coronary artery calcification means? It is a specific marker of atherosclerosis, and it does not occur in normal arteries or any other pathological condition, and it has no relation to the injection of the oral calcium. Why the basis for this coronary calcification? Because traditional risk factors like age, hypertension, cholesterol, diabetes, smoking, and family history, they predict only 50 to 60% of the cardiac risk, and we need to have a system which have a direct plaque imaging and leads to coronary artery calcification, and for that we have a CT, and when we do a CT scan or a coronary calcium scan, we need to have a prospective gating, and should be done in a with a variable with a fixed RR interval and mid diastole, so that there is a less of radiation, and the detail of this is beyond the scope of this talk, but we need to understand how do we do a coronary artery calcification scanning. What should be the feature of an ideal coronary artery calcium score? Should be highly correlated with total plaque burden, highly correlated with the high risk plaque, strong predictor of coronary and cardiovascular risk, simple scan acquisition, low radiation dose, fast interpretation, simple numeric score, and easily communicable to the patients over the values, high inter-scan reproducibility, high intra-observer reproducibility, meaningful measures of the coronary artery calcification progression, can be estimated on not-gated studies, ability to retrospectively validate, and ability to automate. And how do we do that? We have various scores. The most commonly used the get-sent score. 0 is very low, 1 to 99 widely increased, 129 moderately increased, and more than 300 is moderate to severely increased. Others, we have visual scores and other scores, but the Agatston score is the most commonly used in all the clinical trials and in practice. This is the way Agatston score is measured, but I'll just, because not the scope of this talk. The variables, other score variable are the Agatston score, volume, and mass score, which probably out of these, all these scores are equally predictable, but the Agatston score is most commonly used in clinical practice. Why do we use and where do we use practice? Most commonly should be used in asymptomatic people, those with intermediate risk with traditional methods. That is, we have so much of a score available to us, and where we found that they come into intermediate risk, this calcium artery scoring should be done. Other indication being symptomatic patients which are stable and they have 10 to 60% pre-test probability, as an adjunct with other anatomical like CTA or function like a stress test for cardiovascular risk assessment. But this indication is less common, and we should be using more commonly with asymptomatic people, those with intermediate risk. And then we have to see how do we use that. We have to use in male more than 40 years, female 50 years. And once we have this assessment has been done on this group of patients with the Framingham risk and JBS3 score, but if they come into low, less than 10%, then lifestyle modification, if they come into intermediate risk, that is 10 to 20%, then these are the group of patients who should undergo coronary artery calcification. Scoring known high-risk patient more than 20%, probably we need to have a more intensified treatment for this group of patients, not the topic of this. If there is a calcium score is absent in intermediate risk, then they can be left on medical treatment and counseling. If the calcium score is more than 100, then these needs more intensive medical treatment in the form of statins or maybe more intensive investigations. We all know that as the calcification increases, the prognosis is worse, and if it's more than 1,000, these are the group of patients who undergo serious cardiovascular events in the future. Various guidelines have given us some insight. Till now, till 2017, the guideline was 2B, and recently in 2000, ACC-AHA guideline, it has been recommended to second A. There's still the fear being the radiation, probably because of the recent increase in the improvement of the CT machines with the dual projectors. The radiation dose has come down and it's almost as low as 0.5 millisievert. Framingham risk score we commonly use. However, Framingham risk should be embedded with the calcium score, because each quartile increase in the Framingham risk score can be differentiated on the basis of the calcium score. If it is 0, it is a less risk, and if it's a black, that is the highest, more than 300. So Framingham risk score should be embedded with coronary calcification score to see the long-term impact of this score. So let's have an example. There is a 60-year-old male, hypertension with a high of LDL levels, and with the basic traditional score, he comes in the category of 29%. That is a pre-test possibility of a very high risk of CSD. When this patient undergoes a CT scan for the calcium score, it comes to 0. His value comes to 14%, and his CT angiogram is normal. So this patient is de-risked to a lower category where he was earlier taken as a high-risk score. So these are the group of patients who are benefited from calcium score. What is the significance of calcium score of 0? 80% of the patient have a normal arteries, and very less than about 2% going to have a significant coronary artery disease, and mainly seen maybe in the young patients. 0 score significance has been shown in various trials where it was shown that the coronary artery disease was as low as 2 to 3.5% in group of patients, and number of patients being as high as 10,000 patients. So calcium score gives us a very good prospective insight into the prognosis of this group of patients. This was a very popular study quoted in the Lemon of literature, multi-ethnic study of atherosclerosis known as MESA study, and it was shown that with the patient, all those who on CT scan had a 0 calcium score, the hazard ratio was 1 of developing any cardiovascular event. If the calcium score more than 300, they develop the hazard ratio was as high as 7%. So survival in patient with increasing calcium score but non-obstructive CID goes up as the calcium score goes high. And the other benefit of calcium score is a compliance, because knowledge of one's calcium score may improve medication and lifestyle compliance, although available data are mixed. The patient comes to with a, and then with this INSET trial result published show that the significant resource benefits are there, the patients who go undergo calcium score. I'll take just another 2-3 minutes more. So there was no difference between the groups, and coronary artery calcium can help patient lower heart disease risk without increasing test and benefits. So cost benefit are significant, with a significant reduction of the cost, because we don't have to go further for invasive testing. Other advantage, no complication, faster to interpret and report, no need to control heart rate, no need for IV contrast. However, the limitation being that it just assesses the atherosclerosis and does not tell about the coronary artery stenosis. some restriction with some concerns with the radiation, though in recent, most of the recent machines, they have a less radiation. To summarize, coronary artery calcification, presence or absence, its amount and distribution are powerful prognostic indicators. Coronary artery calcification is a reliable marker of atherosclerosis and vascular age. Coronary artery calcification should be seen primarily as a marker of atherosclerosis and not the degree of stenosis. Coronary artery calcification assessment can help physicians reclassify patients of the risk status as considered appropriate. So this was a recommendation from the chief of Cedar Sinai Center, that the recommendation by major professional organization in cardiology that coronary calcification be measured is likely to have as great an impact on saving lives as the recommendation that cholesterol be measured and controlled. With this, thank you with a comment on that the demand for certainty is a one which is natural to man, but is nevertheless an intellectual wise. And thanks for your attention.
Thank you, sir. Sir, boliye.
What about the Shibendu Monty? Is here, or we should conclude the session?
Sir, we should conclude because we are overshooting the time, sir. The next session was to start at 1:30.
Yeah.
So it would be better if we start the session and try to remain in time, sir. And thanks for a great talk. And thank you to all the speakers. I think that it would be a better idea to start the next session since the time is already there. Hello.
Want to have some questions or something?
One question to Dr.
I think, sir.
There's many topics.
Organizers are not ready to take over the mic.
5 minutes you have to give. You started 10 minutes late. So, whatever. I mean, you decide. You are the. But I thought some questions should be.
I think we can have one or two questions, probably.
Yeah.
From each speaker, yeah.
Can we?
Or maybe the chairpersons can ask. Each speaker one.
Dr. Vishal?
Yes, sir.
Dr. Vishal is not there, I think.
Yes, sir, I'm there.
Do you think what is the place of in India, Polypill?
Sir, still now for primary prevention, no, it is still a big no. But yes, for secondary prevention, people who are stabilized on same doses, I think we can start them on Polypill to reduce the cost and number of pill burden.
Yeah.
And one other thought will be, I think we should substitute some of the components of the Polypill. Like simvastatin, I don't think so is any longer used now. It should be substituted with atorva or rosuvastatin. And again, disadvantage with atenolol will be a BD dosing, better to convert it to a metoprolol or some other drug. So I think we need a lot of modifications in Polypill.
Dr. Sanjeev, what is the role of the, can we go for the every patient we are suspecting for the coronary?
I think I just said, explained in my this thing, this should be only for intermediate risk on the basis of whatever scores we have. If the patients are in the intermediate risk, those patients can be encouraged to go for coronary artery calcification score.
Okay. I think organizers are not ready to take out the mic.
A small question to the person who had the talk on exercise. Any recommendations for the children?
Actually, the talk on exercise didn't happen.
Yeah.
Oh, I missed that one. And
Let's
Dr.
conclude this
Manchanda
session.
talk.
Very
Dr.
important
Manchanda,
exercise.
because I got disconnected.
Skipped, I think.
Let us conclude the session.
Got disconnected. I have got myself reconnected. वो बीच में disconnect हो गया था वो. I think net पता नहीं क्या problem थी. So Dr. Manchanda sir से एक ही सवाल है. अगर Dr. Manchanda sir is still there.
I'm there, very much there.
Sir is there on the.
Yes.
हाँ sir. Sir थोड़ा सा oil का ना. There is always a confusion. Or you are the master in oil. So simple one line अगर एक patient पूछे.
I made it very simple. First oil is, I said, cold compressed mustard oil. It's possibly the best for Indians, and I have given the reasons. It has the best fatty acid And there is a study also which shows that it could reduce MI by as much as 71. Of course, more studies are needed. I'm not saying that this is the final one. It appears to be the best. If you see fatty acid constituents, as it's very good for Indian cooking also. And so the only thing is uric acid, which I think studies have clearly shown that it's not harmful at all. It's not allowed in US and in many European because of uric acid, but that's not a concern at all. And there are a large number of studies now which are available where the mustard oil is used in plenty. There's no increase in heart disease and so on and so forth. So similarly, we could use, you see, very high saturated fats also, like ghee is extremely good. And I think
Sir,
we have been...
why I'm asking this question is, there is a huge marketing blitz going for olive oil in a country like India.
No, I know. Olive oil, I said, is a good oil, but it is very, very costly to take.
Yes, exactly.
You see, 1 kilo for 1,000 rupees, that's extra virgin. 1,000 rupees, how many people can afford it? And secondly, it does not have omega-3. It is 20 times inferior to mustard oil.
Yes, exactly.
Omega-3 is 20 times less. So I think, although we don't have too many studies on mustard oil, but I think theoretically it looks appear, whatever little studies there. So for Indians, it should be cost effective. As I said, I don't mind if olive oil was so cheap, and we cannot use it for frying. Indian conditions do not allow this. It's only good for dressing, if you cold.
Hi, sister.
But I must tell you, the problem is of the refined oil. They should be not used at all. Am I audible? I'll give you.
Yes, sir. Yes, sir.
Yes, you see, in 1900 in United States, saturated fats like butter was used for 18 kilograms per person per year. And there were no refined oils. There was no incidence of cancer as well as heart disease. I'm talking 1900. 1950, the refined oils increased 5 or 6 times, and the so-called natural sources like butter decreased markedly. And both increase in cancer as well as heart disease. So I think refined oil are the biggest culprits. They look very nice, but I think refined oils for our cooking are extremely bad, and we should use stable oils like ghee, coconut oil, or mustard oil.
I think, thank you, sir. I think we must close the session. We are a little beyond time, and I think the organizers can switch over to the next session.
Thank you very much all.
Sir, we have the chairperson and speakers already present for the next session. I would request Dr. Rupa Sarwan to present her slides.
Good afternoon, everybody. I hope I'm visible and audible.
Yes, ma'am, you are visible.
Yes, you are visible, ma'am, and it is clear. So we will start with the next session. Dr. Rupa Salwan is there. She's Senior Director at Max program, and she's working at Max Super Specialty Hospital, Saket. So we all understand that ST elevation MI is a very important event that we all need to take care of. But yes, there are a number of problems in the golden hour also, and otherwise also, and transitioning and reaching tertiary care centers is not an easy job. So we will look forward to Dr. Rupa Salwan dwelling on the issue on roadblocks to STEMI care in India. Madam, please.
Thank you. It's been highlighted, and I think all the talks earlier, that 80% of the heart disease burden is coming into low middle income countries, and the transition has happened rather fast. So we have a dual burden of communicable and non-communicable diseases. In our context, STEMI affects younger people in the working age group, and the whole poverty health nexus, the whole concept that it's a disease of affluent and elderly is gone. It is the low and the middle income class that is really getting affected, and it affects all of us. Hartzler was the first to really do primary angioplasty way back in 1981. And it is ironic that 40 years later, we are struggling to see that a majority of our population gets the benefit of this therapy. STEMI is the most time-sensitive intervention in the field of medicine today. Whether we do an fibrinolysis or we do a primary angioplasty, time is important, and the outcomes worsen the more delay that happens. And for a lot of time, we understand whatever you do, you have to do it timely. And we also understand that almost 50% of patients with STEMI are not getting therapies which are very standard in hospitals that are practicing it. And the effort has really been to move to the community and get more people to benefit from this procedure. So what we do in the lab is procedure, and process is how to reach out to the community, to link hospitals, to see that there's a timely delivery of care for most of our community. Now, the aim is to do an angioplasty within 120 minutes or less if you don't have access to a primary hospital. And all the non-primary hospitals, have very set protocols to get patients to the right place fast. Now, all societies which we follow have given a class 1 recommendation for a regional system of care. There is absolutely no ambiguity. They are clear that it is central to the delivery of STEMI care. What happens in an ambulance, in a non-PCI center and a PCI center, they specify clearly what and how to go about it. And what is central is you must have a single telephone number, you must have ambulances, a pre-hospital diagnosis, and protocol at every point with a lot of support from the healthcare authorities and administration to do this. And how they started was way back 20 years ago when they set up 2 big registries, the GRACE and the NRMI, where we saw an angioplasty increasing from 2%, 16% to good 44% of patients were having primary intervention. And Europe, it evolved very fast because they have ambulances which are manned and they could give pre-hospital fibrinolysis. But US worked very hard to get the non-PCI hospitals to get their patients. There were various hospitals started a hub and spoke model in Minneapolis, in Carolina, and in the Mayo Clinic. And in LA, they had a very good ambulance system where the ambulances started triaging and going directly to the cath lab. Now, this led to AHA-led meetings and focused STEMI updates where, Mission Lifeline and STEMI Accelerator happened. So it was a lot of work over 2 decades that really got them, and their work led a lot of countries into doing it. Technology is very important, and we know that ECG is very important, but the interpretation of ECG can be flawed, which leads to problems. Latin was a fabulous trial in the Latin American countries where they placed ECG acquisition and various spokes, and then they got a 3.5 minute time to telemedicine diagnosis, and they triaged the patient to the closest hospital capable of primary, where the door to balloon time was just 48 minutes, and they got the STEMI mortality down to 5.2%. So China also understood that nothing happens overnight, and they put a 10-year goal where the first phase, each hospital is going to optimize its process. Phase 2, you're going to connect hospitals. And phase 3, it's the cities. What I'm trying to say is everybody has got a structured 10-year, 5-year, time frame to get it. And stakeholders, not just the cardiologists, the clinical and the interventionists, but a bunch of people. And I find most of our meetings that we've had, we've just not included other stakeholders. And that's why we've not really made progress. So this bridge the implementation gap. Good individuals need to collaborate in hospitals, multiple hospitals, and nationwide to really make systems. It's very important, a statement by Deming that a bad system will beat a good person each time, and we've just learned to live with mistakes. And in all humility, if you go back, a lot of our discussions of difficult cases are actually a bunch of mistakes, and we have to really learn to trim that down because it's not acceptable. We have to be comfortable with measuring what we do. And we have made progress in the last 10 years. Unfortunately, none of it has happened in Delhi. CREATE started the first registry. Kerala ACS has taken a huge lead. And surprisingly, a state like Himachal has got a registry going for the last 7-8 years where they've increased their primary rate from 2% to 22%. And the hospital mortalities have declined from 9% to 6%. Tamil Nadu has worked hard to create a hub and a spoke model where 4 hubs and 35 clusters, they showed an increase in the primary rate from 20% to 40%. And at the spokes, a larger number of patients were coming into the hospital for treatment to about to 20%. Now, Kerala, this is a very important study that came out last year. They studied 48 cath labs of the 92 cath labs in the hospital and 5,560 patients. 50% of the hospitals were low volume, covering only about 900 of these 5,000 patients. 3,500 patients were done at high volume centers, which were only 10. They were covering a lot of poor patients below the poverty mark, and 80% of patients are still self-paying in our system. And what they found was it was the median volume hospitals that had the best outcomes, and the usual concept of volume and outcome was defeated in this setting, where the experienced mid-volume operators were actually giving the best outcomes. And this is great insight, where they say that maybe in the high volume centers, some optimization of processes will be saving more lives. a beautiful white paper, a lot of contributed by a lot of people even from Delhi. And but they said that all these guidelines are for, the high income groups, and we have to talk of what's relevant to us. We don't have ambulance systems, and we cannot make programs with ambulances centered to all of the care. And patient is navigating layers of the healthcare. So local resources have to be optimized, dialogues have to be made, and we have to accept that the first care provider could be a Ayurveda, the Unani, or a homeopath doctor. We have to integrate them as first care providers, because in our system, it is the patient who has to find the right hospital, the right doctor, and the right time frame, along with the right amount of money in his pocket, which is the most, actually it is no system. And patients are going to, there's a very good psychological analysis that it's not random. Patients use their, advice because they are trying to get the best for their patients. And in a crisis, none of this is going to be valid. While it is fine for for stable diseases, denial and non-acceptance is contributing to this mistrust and lack of confidence. It is great to find actually people are addressing it. Now, the answer is going to be in this white paper, public-private partnership, where, you cannot put them in different brackets and everyone has to contribute to, get the, so what it clearly says that in each area you must have, there are 5 levels of hospitals. One is a GP clinic without ECG. Level 2 is a clinic with an ECG. Level 3 is a lytic possible. Level 4 is a daytime primary. And level 5 truly is a 24/7 cath lab with in-house personnel capable of doing a STEMI intervention. And once you map your area and you link them, and you have to create confidence in existing hospitals, existing systems of care, then constantly create doubt and confusion and put up, and then make working relationships, involve the people in policy. As physicians, we have to get used to working in teams, and we have to make solutions which are customized to our area. Now look at Delhi with a population of 23 million. If we see we have an incidence of MI, we have about 1.5 lakh patients with STEMI. And if with these systems we get down mortality, we will be saving a good 8,000-9,000 patients' lives per year, which is, I think, huge. And let's not underestimate our sources. We have 220 cath labs in Delhi, which is very big. There's no shortage of sources. And if you see the hospital structure, there are about 60,000 beds, of which 30,000 beds are in the private sector. And the hospital, the government has increased its expenditure to almost 1,900 crores. I'm sure within to creating systems is hardly going to take a fraction of this. And if we don't start doing the right things, it is going to become a mandate. While Delhi has taken pride in being the first to do everything, from Rota, DCA, ASD closure, VSD closure, blah, 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 you name it all, we've been the first. But I think when it comes to teaming and getting to our community, we have got left behind, but I think we are all very capable. And if we make up our minds, we will get to doing it. And saying it's not my problem is not the answer. And there's no going back to the world before COVID. And it is time that we build, what we build and what we create is what we do. We have to change our mindsets in this new century. Collaboration and competing with an idea of improving health of the population is what we have to do. And I just say, let the dialogue begin. I thank you all for your attention.
Thank you, Dr. Rupa, for starting the endless flow of STEMI and bringing out such beautiful points of eye-opening for all of us to make this endless flow in a proper direction and in the benefit of the society and the future next generation. Next, we have an excellent, brilliant speaker, Dr. Suman Bhandari. He is going to talk about choice of antiplatelet therapy in STEMI. Dr. Bhandari, sir.
Yeah, I'm just actually in the hospital and trying to get my phone to get the slide. So just give me 1 second.
In case there is a delay, sir, we can next talk first, please, in the interest of time. Dr. Mani?
Yes, sir. I think Dr. Bhandari can I call Dr. Viveka, another brilliant Delhi cardiologist. The current indication for prolonging DAPT, balance is the key. Dr. Viveka, sir, please.
Yes. So good afternoon, all friends, and special thanks to Dr. Mohit for organizing such a nice meeting. So let's go on, so this is an era where we are talking about decreasing the DAPT duration, but, my mandate is to, where can we increase the or prolong the DAPT duration and what are the data. If you look at the challenges in secondary prevention of acute myocardial infarction, it needs a call for action. The reason being that approximately 50% of the major coronary events occur in those with a previous hospital discharge diagnosis of ischemic heart disease. So it's very crucial. If you look at the Apollo data, 1 in 5 patients were event-free for first year, and subsequent MI were there within the next few years. So that means that, it is very important that we take care of the, subsequent years beyond 1 year. And again, Apollo Helicon shows that the risk of cardiovascular event continued beyond 12 months and was greater in patients with certain high-risk features. So we need to identify that the diabetics and patients with CKD, patients more than 65 years, they are the people who will be having higher event rates, meaning thereby that there are a good number of people who are at a high risk and they would be needing more protection than single antiplatelet beyond 1 year. So let's look at the data where the clinical studies beyond 1 year of DAPT, what does it show? And two outstanding data are in this direction, DAPT and the Pegasus, where more than 1 month, and both were fairly decently represented, more than 20,000 patients in each. In fact, DAPT had 25,000. And if you look at the main differences between the two trials, that was DAPT's main aim was to ascertain the benefit of extending the duration of thiopyridines plus aspirin beyond 12 months after coronary stent procedure in a mixed population of stable coronary artery disease and ACS, whereas Pegasus' aim was to prove long-term treatment with ticagrelor and aspirin reduces the cardiovascular event in high-risk prior MI patients. So this is a baseline difference between, if you compare both the trials to put things in perspective. The comparator, comparator in Pegasus was aspirin monotherapy versus, 60 milligram or 90 milligram of ticagrelor. And then if you see the DAPT trial, there was 12 months of clopidogrel or prasugrel with aspirin, followed by 18 months of aspirin monotherapy. And primary safety endpoints was obviously the reason that we needed to know the bleeding issues. So, and the composite cardiovascular death, MI and stroke were looked at in these trial, and obviously the stent thrombosis as well. So if you look at the 12 or 30 months of DAPT therapy after drug-eluting stent, the DAPT trial did show that DAPT decreased the incidence of stent thrombosis. Understandably, the DAPT decreased all-cause mortality, myocardial infarction or stroke, and DAPT increased the frequency of moderate or severe bleeding as well. Whereas in Pegasus also, if you see, the risk factors which were included was multivessel disease, chronic non-stent, end-stage renal disease, second prior myocardial infarction, diabetics, and age more than 65. So all of us would agree that these are the people who would need more, care as far as the thrombotic events are concerned. And if you look at the primary endpoint, there was clear benefit, of event rates when ticagrelor 60 milligram compared to the placebo arm, which was aspirin alone. There was 7.77% reduction, and number needed to treat was just 79. And again, the safety endpoint, which is we wanted to know that is there any significant trade-off of increased bleeding? The answer comes loud and clear in this trial that the major bleeding was significantly higher when we look at the ticagrelor, but this intracranial hemorrhage, hemorrhagic stroke, fatal bleeding, and fatal bleeding, non-fatal intracranial hemorrhages were significantly not very high. So diabetic subset, if you look, the body of evidence suggested that diabetic patients who suffer an MI may derive particular clinical benefit from long-term treatment with ticagrelor with aspirin, and death reduction was almost 22% and cardiac death almost 34% in diabetic patients. So they were significantly benefited with these strategies. What happens in multivessel disease? There, the patients with prior MI and multivessel disease, ticagrelor is an effective option for long-term antiplatelet therapy, and 36% reduction in coronary deaths were there. And bleeding, so bleeding was understandably higher, and TIMI minor bleeding was, again, the 90 milligram was having more bleeding compared to the 60 milligram bleeding compared to the placebo. So the conclusion of this trial was that there was reduction in cardiovascular death, MI or stroke, 29% in death, and 20% in all-cause mortality. So these data provide further evidence of the clinical benefit of prolonging the DAPT with ticagrelor 60 milligram twice a day, potentially informing on which post-MI population may have more marked benefit in the long-term settings. So who should get and DAPT beyond 12 months, and what do the guidelines say? So if you look at the guideline, that's very clear that beyond 12 months DAPT, it's a class 2B indications, and ticagrelor 60 milligram twice a day is preferred in patients with prior MI and high ischemic risk. So we need to identify these group, and there the ticagrelor 60 milligram will be a better choice compared to the other molecules. So treatment with DAPT, ticagrelor 60 milligram plus aspirin beyond 12 months. Who, when, and why? So the patients with prior MI at a higher risk of atherosclerotic event, multivessel disease, multiple prior mitral infarction, diabetics, 65 years or older people, and chronic kidney disease. But we should not be giving it in patients who have got bleeding diastasis, prior intracranial hemorrhages on anticoagulation, active pathological bleeding, severe hepatic impairment, and not patients with prior ischemic stroke. So these are the patients where we should re-evaluate in patients about the tolerance, risk of ischemic event, risk of bleeding, and recent bleedings. And obviously the contraindications for this therapy should also be looked at. To reduce the risk of further atherosclerotic event component endpoint, we need to give this to decrease the cardiovascular death, new spontaneous mitral infarction, including the STEMI, even in non-culprit arteries, it decreased the MI, ischemic stroke, and including the disabling events are significantly lesser. So sum up, ladies and gentlemen, I would say that if the risk is high, persistent, which is there in acute coronary syndrome, beyond 12 months DAPT, ticagrelor, 90 milligram only up to 1 year, and beyond that 60 milligram twice a day. And the major international guidelines now prefer ticagrelor 90 milligram over clopidogrel for first 12 months. There are some conflicting data of late coming, but definitely as of now, this is a preferred therapy. And ticagrelor is the only P2Y12 inhibitor approved for extended use in post-MI patients remaining at continued long-term risk of event. So thank you very much for your kind attention, and over to Chairperson Dr. Krishnamani.
Thank you, Dr. Viveka. Excellent presentation, and elegantly enlightening us on the indication of prolonging the DAPT beyond 1 year. I call upon Dr. Bhandari, sir, to please, sir, restart your slides. Dr. Suman Bhandari, sir. I think he's not connected. Dr. Suman Bhandari is probably not connected. Can I, sir, can I call upon the Encyclopedia of the Current Knowledge, Professor J.C. Mohan, to enlighten us about the short and ultra short DAPT? Respected sir, please.
Thank you, Dr. Krishnamani. I would be talking about short and ultra short DAPT, rationale, evidence, and caveats in next 8 minutes. DAPT is the core therapy for acute coronary syndrome and patients who have undergone PCI. The selection of adequate intensity and duration of DAPT is a challenging clinical decision, and Dr. Viveka Kumar made a pitch for high-risk individuals to have prolonged DAPT therapy. Classically, class 1 indication is 1 year of DAPT therapy, and class 2A indication in 2020 guidelines is for prolonging the DAPT therapy in high ischemic risk and low bleeding risk. Shorter therapy for 6 months have been recommended by ESC in those who have high bleeding risk, stable chronic coronary syndrome, and those who have been given BMS. Short-term DAPT is a cliche in intervention cardiology. What is short-term? 1 month, should I call it ultra short? 3 months, should I call it short? 6 months, should I call it short? So conventionally, anything which is 1 month or less would be ultra short. And I think 3 months probably would be a right thing to call it short DAPT. 3 to 6 months could also be taken as a short DAPT therapy. We also already know that from this prospect study conducted by Dr. Greg Stone that patients after acute coronary syndrome and after PCI continue to incur events both in non-culprit and culprit lesions to the equal extent, so that in next 3 years there are 20% events, half as a result of non-culprit lesions and half as a result of culprit lesions. Obviously, some of these problems can be prevented by prolonged DAPT therapy, and in others, maybe a short DAPT would be appropriate. So who are the individuals who can have short DAPT and who are the individuals who should have long DAPT is a difficult decision to make. Obviously, you need to have a parameter which is absolutely exact to find out the ratio of ischemic versus bleeding risk, or risk of stent thrombosis and recurrent events versus bleeding risk. And if you can find it, then you, in patients who have that risk ending or reaching 1 at 3 months or 1 month, you can give short DAPT, and those where the risk takes much longer or the ratio takes much longer to achieve a figure of 1, you can prolong the DAPT. Ideally, the benefit should be twice compared to bleeding or the risk, at least twice and preferably 3 times. So you need to find out a risk of 3:1. If it is achieved in 3 months, so be it. If it is achieved after a prolonged DAPT, so be it. We need to keep in mind one thing, that the ischemic and bleeding risk are coupled. As you move along DAPT quantitative scores, the bleeding risk also increases and ischemic risk also increases. However, there are situations where 2 risks are out of phase. For example, a culprit stable lesion with no lesion in other arteries, the ischemic risk tends to taper off by 3 months and bleeding risk remains stable. Here is a classic case where you could probably give a short DAPT therapy. The other example is a patient with acute coronary syndrome and multivessel disease. Here the 2 risks are in phase, they're not out of phase. As the ischemic risk decreases, but it doesn't plateau and the bleeding risk remains stable, you have a gap between the ischemic risk and bleeding risk, which persists, although it over a period of time, it may decrease slightly. By and large, that difference persists, and it tells you that such people would require long-term DAPT therapy. The first study as a proof of concept was Optimize, conducted in Brazil 8 years back. And this study looked at 3 months DAPT versus 12-month DAPT and found that 3-month DAPT was equal to 12-month DAPT in patients with stable coronary artery disease and low-risk acute coronary syndrome with regard to net adverse clinical events. Optimize study also looked at landmark analysis beyond 90 days, between 90 days and 365 days. When they looked at the data was no different whether the DAPT was given for 3 months or 12 months, clearly indicating that in stable coronary artery disease and low ischemic risk ACS, short DAPT therapy is okay. However, there are caveats, and if you look at occurrence of myocardial infarction in Optimized study or in this study, the SMART DATE study, you find that although bleeding risk is high, the bleeding risk is high in patients who are given 12 months of DAPT. Myocardial infarction risk is high in those who are given 6 months of DAPT therapy. So who are these individuals who have high ischemic risk? Individuals with prior myocardial infarction, diabetes, ejection fraction less than 30%, prior stent thrombosis, and CKD. Here, of course, DAPT may be prolonged in case there are 2 or more risk factors. Angiographically, there are high ischemic risk factors, multiple stents, multiple PCI, complex PCI, LMCA, stent length more than 60 millimeter, and stenting of last remaining vessel and diffuse multivessel disease. These are individuals who are not candidates for short or ultra short DAPT therapy. However, there are people who are candidate for short depth therapy, those who have a high bleeding risk. These are elderly people, people with CKD, low hemoglobin, leukocytosis, thrombocytosis, frailty, underweight, and people who need oral anticoagulants, steroids, or NSAID. These are the individuals where the depth therapy has to be shortened. Stent also actually compel us, the type of stent also compel us to use short-term depth therapy. And there are data to suggest that stents which are thin struts, non or bioabsorbable polymer, and where we have done image-assisted optimization techniques, shorter depth therapy can be given. In fact, the initial push to this kind of thinking was given in 2019 ACC when two trials were presented called Stop Depth 2 and Smart Choice. In Short Depth 2, it was 1 month versus 1 year depth. In Smart Choice, it was 3 month versus 1 year depth. And the data in both these trials, and these were patients with all comers, and it included 50% patients with acute coronary syndrome. And both the trials showed one thing, that shorter depth is superior. Not only it is non-inferior, it is superior with regard to primary endpoints, whether you include bleeding or you do not include bleeding. And that is very interesting. It was followed by actually next year in ACC by TICO study, which looked at death, MI, stroke, stent thrombosis, target vessel revascular, major bleeds in those who were given 3 months of depth, followed by versus 12 months of depth, and of course ticagrelor was the other agent besides aspirin. And after 3 months, aspirin was dropped. Here again, the primary endpoints were actually, when you look at the major bleeding included, primary endpoints are higher in 12 months depth than 3 months depth. TICO STEMI had similar kind of data. If you had a 12 months of depth therapy, the events were higher, although not statistically significant. Roxana Mehran looked at the Twilight data, which suggested that after 3 months, if you drop aspirin and continue ticagrelor, you have less BARC 2, 3, and 5 bleeding, but the secondary endpoints, 3-point MACE, were no different. The recent data by Roxana Mehran in Science 90 and Science 28 have also shown, compared to historical controls with the Science stents, the bleeding risk is decreased, but the 3-point MACE is no different if you shorten the depth to 90 days. Similar data is available from Science 28, suggesting that the BARC 2, 3, 5 bleeding is significantly reduced by 1 month depth therapy without there being any great effect on stent thrombosis or death, MI, and stroke. The meta-analysis of these 6 trials where a short depth therapy of 3 months or less has been used, including global leaders Twilight, TICO, Smart Choice, Stop Depth 2, have shown that major bleeding, if you drop aspirin after 3 months, major bleed is reduced by 40%. Death, MI, and stent thrombosis are reduced, numerically significant but statistically insignificant, 12%. So to summarize, ladies and gentlemen, with regard to depth, one size does not fit all. You need to individualize the duration of depth therapy, and short and ultra short depth remain a viable option in those who have high bleeding risk, where you have used better thin strut stents, where post-procedure imaging optimization have been used, and patients who have relatively low risk, less disease as far as coronary atherosclerosis is concerned, shorter stents, and stable coronary artery disease. To summarize, it must be said that whatever choice you make, your choices reflect your hope, should reflect your hope and not your fears. Thank you very much.
So thank you so much, sir, for enlightening us with the short depth therapy. Can I call upon my co-chairs to please take over? Dr. Prabal. Anyway, if there one, I would request Dr. Suman Bhandari, sir, to please initiate his talk about the starting of the antiplatelets at the time when the first contact of STEMI. Dr. Suman, sir?
I think Dr. Suman is facing some issues with the connectivity.
Okay.
So we can move to the next speaker, so Dr. R.D. Yadav.
Dr. Yadav, my classmate, can I call upon Dr. Yadav, sir? Is there a case for antiplatelet monotherapy for after PCI? Dr. R.D. Yadav?
Yes, are you able to hear me?
Yes, yes, we're able to hear you.
Yeah. So I'm already repeating many things which was told by Dr. J.C. Mohan, sir. Definitely. So I'm going to give a case, 75-year-old male presented with acute extensive interval STEMI. He's a non-smoker, non-hypertensive and diabetic, hyperlipidemia with total cholesterol 240 milligram per DL, no family history of coronary artery disease. He underwent PCI with DS of proximal LAD and started aspirin to chew and then enteric-coated tablet and ticagrelor loading 180 milligram and 90 milligram twice daily. In CCU, after PCI, patient developed GI bleed and hematuria. What to do? So let's go with the evidence already presented by Dr. J.C. Mohan, sir. Is it safe to use monotherapy routinely? SAPT versus DAPT post PCI? Is aspirin essential in ACS and PCI? Let's see the evidence. Initially in STEMI, aspirin with streptokinase has shown the benefit, but that time P2Y12 inhibitor was not available. In NST-ACS also, if you see this trial, aspirin is superior as compared to no aspirin in NST-ACS, and PCI without aspirin is just harmful that time because there was no P2Y12 receptor that time, and aspirin both in primary and secondary was superior without any aspirin, and the dose minimum dose which is recommended is 75 to 150 milligram, which is the more effective dose. And but the P2Y12 was introduced by the CURE trial, and it showed that 20% risk reduction, although there is no benefit of mortality benefit in this trial. CURE trial, and PCI CURE has shown over 1 year period. And so P2Y12 was introduced in this trial. Overall, if you see, there is a overall 31% reduction cardiovascular death or MI at various intervals, up to 21% reduction. But it came with the benefit came with an increase in bleeding risk, and both major and minor bleeding risk is significantly increased. Now the question arises: increased bleeding is due to aspirin or due to clopidogrel? Here, the dose, as you see, the dose of in CURE trial, as the dose of aspirin increases, bleeding risk is significantly increases, and so the balancing the risk already discussed about the and as you know, anything which increase the bleeding will increase the mortality in post PCI patient. So what they initially discussed, that what are the high bleeding risk features, and those bleeding risk features, in those bleeding risk features you have to obviate these drugs, and as you know, bleeding risk increases mortality. So and many of the bleeding and the ischemic risk, as already discussed, is that it overlaps in both the females and males, and as the ischemic risk increases, the bleeding risk also increases some high risk features. So what to do now is to remove the aspirin and stay with the your newer, more potent P2Y12 receptor, that is ticagrelor. So first trial is the already optimized trial has been discussed. So here I'm going to discuss the TULIP trial, where the aspirin, where the ticagrelor monotherapy was compared with the ticagrelor plus aspirin over 3 months in acute coronary syndrome, high risk acute coronary syndrome. So not only selective high bleeding risk patient, all patients high risk patient, and they were randomized. And what it showed that BARC 2 and 3 and 5 bleeding risk is significantly higher, around 1.75 times more higher in the patient who were given both these drugs, whereas 3 and 5 bleeding was also double, and the all bleeding risk is higher in all the groups in these patients, whereas the ischemic risk, death, MI and stroke, no difference between the two. So clearly it indicates that all patients with high risk PCI, whatever PCI you do, should have one strong antiplatelet, that P2Y12 inhibitor, and that is the ticagrelor here. So similarly in TICO trial, also in ACS patients, here thin that is 60 micron stent was used, that is the Orsiro stent was used, and here 3 months was again compared with the 12 months, and what clearly shown similar design, that your 12-month clinical outcome is significantly lower with the ticagrelor monotherapy as compared to dual therapy and DAPT therapy. And in 3 months also, the bleeding risk, if you take major bleeding, is also significantly higher in this group of patients, both 12 months and 3 months. So clearly, a TICO telemeter is enough not to give aspirin at all. In TICO STEMI, say in a STEMI subgroup of the TICO trial has again showed that in intention to treat analysis as treated and Lenbach, that the bleeding risk where NACE was introduced, their bleeding was also included and found to be significantly lower with the ticagrelor monotherapy as compared to dual DAPT therapy. TB major bleeding was significantly lower, treated as well as intention to treat analysis. So major adverse cardiac event, cardiovascular events were all lower, or at least as treated is lower, although it was not statistically significant. So clearly that ticagrelor monotherapy is enough in this high-risk group of patients. Stop DAPT already told, was done in Japan, where clopidogrel was compared with the DAPT. Here clopidogrel was the main drug and giant stent was used, and clearly it showed that 1 month, after 1 month, there is no need of DAPT. The bleeding, if you see all the risk, bleeding risk is significantly higher. If you take the net clinical benefit, was also better with the superior as compared to 12-month DAPT. So here Covell chromium stent is clearly shown that in thin stents, you need to give only short period of DAPT. Even nowadays, even other trial, even 14 days DAPT is enough, or even omit the aspirin and give only the ticagrelor or even prasugrel. Although trial with prasugrel was not done up till now. So in classic trial, similar to that is the global leader design trial, and similar it showed that there is increased bleeding risk with the there is increased there is increased bleeding risk with the DAPT as compared to 1 month versus 6 months was compared, and it showed that that only single monotherapy after 1 month is enough, although here bleeding risk was significantly high. In Onyx 1 trial also what it showed, that it compared 2 stent platform, Resolute, Onyx and Biofreedom, and again here 1 month DAPT versus 12-month DAPT in high bleeding risk group. There is no difference between the 1 month and 3 months, although bleeding risk is significantly higher. Same repeatedly, I am telling you, multiple trials, multiple evidences. Giant shot DAPT here after 1 month and after 90 days, the clopidogrel was stopped in this trial and aspirin was continued. Yes, aspirin was the main drug, and in that trial also it showed that the bleeding risk is significantly higher. There is no harm at all, no increased thrombosis and no complications. In the Smart Choice trial already mentioned that there is a single same 3 months versus 12 months DAPT P2Y12 inhibitor monotherapy is enough. No need here. 3 stent category was also compared and found there is no ischemic harm. Only bleeding risk is significantly reduced in this trial. So there was a editorial last month in JACC intervention on these. But that's 1 or 2 slides.
Please come to your last slide, please.
Yeah, 1 or 2 trials. All meta-analysis has been discussed and told that single monotherapy is enough. So patient underwent PCI with newer DS in HBR patient, it is better to continue ticagrelor monotherapy rather than DAPT. It has been seen, in these studies, there are no increased ischemic complication with reduced bleedings. In my patients, I stopped aspirin and continued ticagrelor and gave PPI pantoprazole along with the sucralfate, which led to stoppage of both GI bleed and hematuria without increasing ischemic complications. Thank you.
Thank you very much, Dr. Adi Yadav. And I'm sure the talks were very, very elegantly presented and were very, very informative. Can I call upon my co-chairs, Dr. Sudhir Oswal, Dr. Anupam Prakash, Dr. H.S. Acer, and Dr. Prabal. Sir, can you please join and please give your own expert comments on this, on the present talks?
Thank you, Dr. Krishnamani. We had very nice presentations, and all the speakers have made their points very clear. where to give DAPT, whether short or ultra short, or where to continue even after 1 year. If Dr. Suman is now contactable, Suman Bandari, I think we should go ahead with the next session.
I think, sir, I think he's probably has some technical issues. I think we can proceed with some questions. Anyone has any questions, please proceed, Dr. Oswal, sir, please.
Yeah. So I don't have to add anything. I think if there are any questions, we can take up. Yeah.
Dr. Anupam, Dr. Prabal, Dr. Isar.
Yeah,
There are no
there's a
questions in the chat
question
box.
regarding
Questions, yes.
switching of one antiplatelet agent to other. What are the guidelines? Suppose a patient has been started on clopidogrel and we want to give the benefits of ticagrelor. What are the guidelines for switching?
Dr. Jasimon, sir, you like to highlight, sir, on us on this? I think sir has left it.
Yeah, I can discuss this about. You see those patients who are on clopidogrel, you want to give ticagrelor, just stop clopidogrel, load with the ticagrelor, that is 180 milligram stat, and then twice daily.
No, are there any guidelines or is there any benefit being shown?
No, it's not like benefit. It depends upon your choice.
What he means to say that it is an individual choice. There are no guidelines existing.
Definitely, it has shown by.
There are no guidelines as such, but it is the clinical experience of the operator and the team where to switch over from one antiplatelet to other, depending upon the patient's clinical situation and the side effects and the outcomes. There are no specific guidelines, sir.
Okay.
Dr. Isar, sir?
Yeah, thank you. Yeah, thank you. Very nice presentations by Dr. Rupa, Dr. Jasimon, sir, Dr. Viveka, and Dr. Yadav, sir. And there is one question for Dr. Rupa if she is here.
Sir?
Yeah. Are you here, madam?
Yeah, I'm here.
Yeah, Dr. Rupa, thanks for the nice data presentation from Pan India. It is difficult to get data from India. We can get data from US very easily. From all over world, we can get data, but Pan India data is very difficult, and you presented very nice acute MI program data, whatever is happening in all India. There was one program started in Delhi also with ICMR and All India Institute. Are you aware of this, or I don't have any update on that?
Yeah, so no, these things have come in. They've not been published. I thought that 2 papers were published from AIMS, and they got their mortality down from 12% to 6% in a year. And I also know Dr. Balram Bhargav got a grant from ICMR to, do the motorbike and reach out. But we've already done that at Max. It's failed. Now, the tragedy is that everyone, in a position of importance is doing what he thinks is right, and there's no dialogue. And worst, the cardiologists are talking, but nobody's talking to administration, nobody's talking to ER. And without that, nothing happens. So these are little pockets. Then one CSI, there's an app launched. There's no follow-up. So nothing's going to happen unless we keep talking and saying, oh, we did this didn't work. Oh, come on, let's do this. And I think the paper which has come out from in circulation, the white paper, it's a very well-written paper. And it just says clearly that in your communities, you put down to level 1, 2, 3, 4 and start talking to each other. And I think the biggest barrier, you are in government, private and doctors are the same. I mean, whether you're working there or there, we're all practicing medicine. We've got to stop looking at each other with, suspicion and lack of trust. I don't see why, like in Tamil Nadu, there were government hospitals who were sending their patients to those 4 hubs, of which 2 are private. One is a trust hospital, one is CMC Vellore. So creating a sharing is very important, and within your areas, resources have to grow up. The telemedicine is very good. Now, if only we sit together and we decide, okay, we're going to do this and then come back. Oh, well, that didn't work. So the closure is not happening about whatever was started. And I think everybody has, tried to do something and it doesn't work.
You're right, ma'am. You're right. A lot of coordination is required. Coordination is something actually.
I must share with you that I attended a cancer meeting yesterday in my hospital, and I asked them, because for us everything ends up to money and business case and blah blah nonsense. They said that there is a national grid for cancer registry. And they are totally independent of Max. In fact, what's very annoying to me is when I speak about this, people just think I'm talking Max. It's not that, yeah, I'm talking science. So that national grid puts you independent of the hospital where you're working. You create a IT tool to collate data. You hire the fellows to, enter the data. And it's high time we start doing that. And there's a lot to learn from Kerala. I mean, in 10 years, they've really moved a lot. And look at the work they're doing. Now, of 92 hospitals, only 48 participate. Very good, but we can't even get, 5 hospitals. I'm willing, even in South Delhi, Dr. Isar, AIMS, us, we can collaborate, but let's start doing something. We've got to make a difference to society. Individually, all of us have done what we have to do, but at a society level, there's a lot lacking, and it's very important we start talking about it.
Yeah, absolutely. Very correct. Thank you.
I have one question. From all the speakers, anybody can apply. We have 2 sets of patients, one having bleeding tendency and the others who have no bleeding tendency. If we have to consider monotherapy, which is the one best for this first group or second group? Can you please explain?
In all the patients, whether high bleeding or no bleeding, nowadays monotherapy, particularly the stronger P2Y12 inhibitor, ticagrelor should be the preferred choice. Even from the first day PCI, you can continue with the ticagrelor and without use of, or even prasugrel, although data is not much enough, except ISAR React 5, that ticagrelor
Okay, and what about the other group?
Prasugrel rather than aspirin along with that, even in high risk patient, even high bleeding risk patient, without any.
Can I add something to this? In general, ticagrelor or prasugrel is to be given in ACS patients. And it is to be preferred in all ACS patients, other than maybe in bleeding risk, high bleeding risk patients already on oral anticoagulant, patient has already a intracranial bleed or GI bleed, or CRF patients, renal disease patients, they are high risk patients, or some hematological abnormalities. In these patients, maybe clopidogrel is okay in acute ACS patients also.
I think we'll have to, really relook at these things, because a patient who bleeds, suppose you put a 4 stent in a proximal RCA 18 millimeter, it's all right. Even if he came in with a STEMI, there's no harm in a clopidogrel. And we have to get our own data. And that's what, even this white paper says, that data of bleeding, I mean, a 45 kg, a 36 kg, 90-year-old lady, I wouldn't go to ticagrelor at all. So there's more factors, and we have to be very comfortable talking about our data. And I take strong objection, the whole data on clopidogrel resistance only came out till ticagrelor had to be marketed. Now that it's marketed, everything is forgotten. And finally, I think we have to just call our own, not get bluffed by things and have our own data. And they will be.
Still in Asian country.
I think some of the answers to the present questions will come in the next set of talks. I think I would request the next set of chairpersons to please take over. I thank Dr. Rupa, Dr. Viveka, Dr. J.C. Mohan, Dr. Adi Yadav for giving us such an excellent talk, and especially Dr. Rupa, who has brought out such a beautiful and excellent, a thought process to build up at the society level. Thank you very much, all of you, sir. Thank you so much. Can I invite the next set of chairpersons, please? Dr. Moy.
Sir, we have Dr. Vipin, Dr. Umar, Dr. Agarwal, Dr. Govil for the next session as chairpersons, and we have Dr. Rajneesh Kapoor will be speaking on the first talk, sir. I would request Dr. Rajneesh Kapoor to start his talk.
Well, thank you. Am I audible?
Yeah, audible.
Okay.
Rajneesh, you are very well audible.
Yeah, thank you. So just putting my slides on the slideshow. Yeah, so choice of antiplatelets and anticoagulants in acute coronary syndromes. I think there's a lot which has been discussed in morning about antiplatelets and anticoagulants. There may be some overlaps, but I'll try to skip all those. So I'll just go straight to my first slide. So objectives of the talk, I would say, is to how to utilize the current practice guidelines for the management of antiplatelet therapy in coronary heart disease patients, discuss the selection of different antiplatelet medications, determine optimal duration of dual antiplatelet. Again, a lot has been already discussed. Assess the CV risk versus
Sir, please share your screen, sir.
Rajnish, your slides are not visible.
Oh, just hold on.
So the share screen option is at the center bottom. You can see.
Yeah, I'm going there, share screen. Okay.
No, that's okay.
Now it's there?
There, but come to the full screen.
I'm coming there, yeah. Is it now visible?
Slides are visible.
Yeah, visible. Thank you.
But it's not
full screen. You have to put on full screen.
So I have lost it here.
One time stop your sharing, sir. Then again, sir, share.
Just hold on.
Please share again, sir.
I'm sharing again. Please come. So we're sharing, it's being shared there.
Where is the PPT?
This is the PPT.
1 second.
This is
कुछ प्रॉब्लम है आपके लिए? हैंग हो गया आपका सिस्टम?
Am I audible? There is some issue here. So I think my system is, it's not working. It's hang. It's hung basically. So can you go to the next talk while I repair this?
Yeah, it's okay.
Call the next speaker.
It's
Dr.
hung.
Kasliwal.
I have to reboot it.
Next speaker is Dr. Kasliwal. I think we should invite Dr. Kasliwal.
Share screen.
Dr. Kasliwal is there.
Yes, good afternoon, everyone.
Good afternoon, Dr. Kasliwal.
I'm there, yes. So Dr.
Yeah.
Mohit Gupta asked me a very specific question. Has COMPASS changed the management of chronic coronary syndromes? So in the next 7 minutes, let me see if I can answer that question adequately. But what is important is, can we share the whole screen? If you look at Bhatt's data in JAMA 2020, very clearly he demonstrated in the REACH study that those patients with chronic coronary syndrome, those who continue to have angina, will have increased CV death, MI or stroke, not necessarily, and also hospitalizations for heart failure and revascularization. So the new guidelines that
recommend a second antithrombotic to aspirin for selected patients with chronic coronary syndromes. And this was a good term actually given by the European Heart Society of Cardiology, rather than just calling everybody stable angina. How stable it is, we all know that. So the recommendations are clear. Whether the patient is high ischemic risk or it is moderate ischemic risk. High ischemic risk, very clearly, as Dr. J.C. Mohan also said, diffuse multivessel CAD, diabetes, recurrent MI, PAD, and they emphasized a lot on PAD, CKD, and also moderate ischemic risk as multivessel diffuse CAD. Now, in these situations, they said that there is an indication that truly you could continue, you could give an agent which was an antithrombotic agent. And the new guidelines also therefore then recommended 4 options for dual antithrombotic therapy. They said you can treatment options for dual antithrombotic therapy in combination with aspirin. So aspirin was there. You could give clopidogrel, you could give prasugrel, or rivaroxaban and ticagrelor. Now, there is a lot, there has already been a lot have been said about the continuation of ticagrelor and aspirin. I would just concentrate on rivaroxaban. But before I go there, just let's look at the dual anti-pathway inhibition, DPI. This is a new term and we've used it for the last 2-3 years. DPI makes a lot of sense for chronic CCS patients who continue to have angina or at high risk. Both platelet activation and persistent thrombin generation in chronic CAD. So let's see the acute phase first. In the acute phase, if you see, there is platelet activation is strongest in the acute phase. So you're absolutely correct if you gave these people dual DAPT, absolutely correct. But when you go into the chronic phase, and as somebody gave a very good example that I opened the culprit vessel, but there were other 2 vessels who were 30 or 40%. What should I be doing? Should I continue the DAPT or should I now think that, can I use a newer NOAC or a DOAC? And remember, this is exactly what we used to think long time back when there were no DOACs, that many patients after acute MI who were on actually warfarin or acetrom actually had less events. So blood flow, occlusive thrombus, hemorrhage, you have to weigh these things. It's not as simple as giving something and then the person comes down with a hemorrhagic disorder. So aspirin, we know, thromboxane A2, thromboxane pathway, ticagrelor and all these act at the P2Y12 inhibition, and then you have rivaroxaban, apixaban, and doxaban, and they act at the factor 10A. And does this make sense? That and it should make sense in 2 ways, that we don't get further events and also we don't get hemorrhage. That's important. So the first inkling of this came from the Atlas ACS STEMI study, in which there was a dose escalation study leading to selection of 2.5 milligram and 5 milligram doses for a phase 3 study. Then came in 2012 came your Atlas ACS STEMI. This study, I think, gave the first indication. This is, as we say, who started the fire? This is what it was. Addition of rivaroxaban, 2.5 milligrams BD into DAPT significantly reduced CV risk and all-cause mortality. Then, of course, Pioneer AF with PCI, again, a challenging question. And on a recent study called the FIRE study from Japan also said the same thing. And then came 2017, the COMPASS study, 27,395 patients. And I'll come to this. Rivaroxaban, in addition with aspirin, created a good feature that the angina was less, future events were less, and of course, there was less bleeding. So these were all stable patients. So the COMPASS trial was then postulated. If you read the REACH study by Dr. Bhatt, he also mentioned that as I'm finishing my work, the COMPASS study has already started. So this was the cardiovascular outcomes for people using anticoagulation strategies study, which 27,325 patients. Everybody got aspirin, 2.5 milligram BID with aspirin, or rivaroxaban 5 milligrams BID or aspirin daily. Good median follow-up, and the patient profile is what we see every day. Criteria for CAD: previous MI, multivessel coronary disease, multivessel PCI, or multivessel CABG. Patients with CAD met with the following criteria. These are all things that we see in everyday life. And of course, there were PAD patients as well. CAD was defined as prior MI less than 1 year, 1 to 2 years, 2 to 5. And you could see number of patients that, so it was a huge study. And it also had patients who had previous PCI and previous CABG. CAD with PAD, they had 20%, previous MI 69%, diabetics 37%, renal impairment. So to me, it appears like a study which was almost like a real world studies. And definitely we saw that there was a decrease in MACE. There was net beneficial difference. Just give me a minute. The MACE was reduced by 24%. There was a net benefit of almost 20%, and the mortality decreased by 18%. So there was no benefit for Riva with Riva alone, and Riva plus ASA versus ASA. So see, we were all in our minds for many, many years, just thought, okay, CABG has been done, we should start with aspirin, or we've done 1 year with Trecaglor and aspirin, we should come back to just ASA. Very classically, the study showed this. And rivaroxaban vascular dose plus aspirin reduces ischemic events. Sub-analysis. So the clinical implications of COMPASS were switch from dual antiplatelet therapy to dual pathway therapy with rivaroxaban plus aspirin works, at least in this study. Therapeutic use and clinical benefits of dual pathway therapy is beneficial both in CAD as well as PAD patients. And also the NICE guidelines from the United Kingdom recommended as an option for preventing atherothrombotic events. If we had this word in our mind, that we are looking at atherothrombosis events, then obviously we will be using this combination with CAD or symptomatic PAD who are at high risk of ischemic events. So in conclusion, Mr. Chairpersons and ladies and gentlemen, patients with CAD remain at high risk for ischemic events. There is no doubt about it. Many people are at really high risk. COMPASS study results provide support for the use of dual pathway therapy, DPI, aspirin plus rivaroxaban 2.5, with not too much of bleeding disorders and definitely much less ICH. In stable patients with a history of MI, PAD, diabetes, multiple risk factors, or diffuse disease, as per recommendations, dual pathway therapy may be considered for preventing atherothrombotic events in adults with CAD who are at high risk. These have been defined. It seems to be a time that now we have adequate DAPT, we have adequate DPI, we have to decide what we need to do. So thank you, ladies and gentlemen. To me, when Dr. Mohit Gupta asked me, I thought COMPASS has changed the management of chronic coronary syndromes. Thank you very much for your kind attention.
Dr. Kasliwal,
yes.
May I ask you, is it aspirin with rivaroxaban or aspirin with ticagrelor? Which is better dual antiplatelet?
No, this was the question I knew you'd ask, but see, then you are using P2Y12, you are using both agents which are looking at platelets.
Yeah.
Here, this is a totally new thinking. You are depressing platelets with the thromboxane antagonist, and which irreversibly blocks there. So fine, ASAs you are giving. And now what you've done is that you have utilized the factor 10, the factor 2A pathway as well. So in a sense, it made sense that those who are at high risk, they are not only at high risk because of platelet aggregation, but they are also at high risk because of atherothrombosis. For many years, what we have been doing is once we discharge our patients with after angioplasty, we would say, okay, look, let's have a look at their carotids, or let's have a look at their brachiofemorals. And I always intuitively felt that if it's a polyvascular disease, we should give this for a longer period of time. Till I came across COMPASS, and then talking to many colleagues, they said it intuitively made sense. And of course, the COMPASS study was the cohort was pretty big, and but also in his REACH registry said the same thing. But really, if you started with the ATLAS study, then it would become very clear to you that first is the period where I have to give DAPT, and then on a long-term basis, maybe I will. So I think if all of us, we are chair in our institutions, if we got together, certainly we could come out with our Indian compass and to make life easier for our own patients and also at cheaper rates. So that's what I feel.
This bleeding risk in the COMPASS, the bleeding risk also has increased when we were using rivaroxaban with the aspirin. Even it was low dose, probably 100 milligram with the 2.5 BD of the rivaroxaban. But the bleeding risk was offsetting the benefit was offset by the bleeding risk. What is your comment on that?
The bleeding risk was only high if you used 5 milligrams BD. With 2.5 milligram BD and 100 milligrams of aspirin, the bleeding risks were decidedly low, number one. And according to the ISTH criteria for hemorrhage, there was very little hemorrhage ICH. Intracranial.
Yeah, that's
yes,
right.
Yes. So that way, rivaroxaban 2.5 BD with aspirin 100 or 75 milligrams actually made more sense. I went through this very clearly because to all of us clinical cardiologists, one thing that hurts us most is, I was giving therapy for angina, I was giving therapy for a valve, but the patient came with ICH. It's a very, very bad situation. We all face it. But I went through this data carefully, and I realized that they specifically mentioned ICH was much less. So that's what I feel. But ICH can occur with aspirin alone also. So
actually they used the very loose criteria for the major bleeding. Just presentation to emergency department for major bleeding. That was the criteria. ICH, you are right. ICH was very low.
Yeah, ICH was very low. But I think that the study was conducted in good centers across the world. It was an NEJM article. And I think it may be a good idea for some of us, for many of us to get down together and then see for ourselves, because just as recurrent hospitalization is emotionally and financially breaking to the patient, similarly, recurrent angina, further procedures can break a patient in this day and age. That's what I feel.
Yeah, it's correct. Yeah. It requires a lot of thinking, and it has to come to guidelines.
Thank you very much, sir. Thank you. Really appreciate that.
Can we move to the next presentation from Dr. Aziz Kapoor? I hope Stan will be able to share.
Yeah. So I'm ready. Now I think my slides are visible.
Not yet.
You need to share your screen.
I think, yeah. Now it's visible?
Yes, sir. Just put it on the slideshow mode.
Yeah, I'm doing. Okay. Yeah. So thanks, Dr. Mohit and all the organizers for this meeting, for having me here. And I think it's really enthralling that we are having a nice discussion since morning about a variety of topics. So I think antiplatelets, anticoagulants, Dr. Kasliwal also really gave an overview of anticoagulation to be used in coronary heart disease patients. So I'm just touching upon all the aspects. Again, there may be some overlap in this. So choice of antiplatelets and anticoagulants in a patient of acute coronary syndrome. So objectives of my talk would be to utilize the current practice guidelines for the management of antiplatelet therapy in coronary artery disease patients, discuss the selection of different antiplatelet medications to determine the optimal duration of dual antiplatelet therapy, and assess the CV risk versus bleeding risk. I think this is a key point which we have been discussing since morning, which actually determines a lot that how to use and what's the duration to be used, what antiplatelets to be used, whether anticoagulants to be added if the patient is having atrial fibrillation. So all those points will be discussed in the due course. Recognize options of anticoagulation in atrial fibrillation. So antiplatelets, I'll just touch upon few slides. May not go into the detail as I think there is a lot of overlap. Aspirin, we all know, it has been discussed at length. I'll just skip few slides. So it's a comprehensive presentation. So I'm skipping and we'll be sticking to the slides of interest only. So we know aspirin for secondary prevention in coronary heart disease patients, there is ample evidence. The meta-analysis clearly tells that it's working much better than the placebo. Clopidogrel, this was the aspirin era, then came the clopidogrel. It's not moving. Okay, so provides a slightly greater risk reduction than aspirin. The dual antiplatelet therapy produces a greater benefit when used for 1 year, duration in non-STEMI acute coronary syndrome patients. So this actually, there was one trial of clopidogrel which paved the way that rather than aspirin alone, it's aspirin plus clopidogrel. If used for 1 year post ACS, it's going to give a much greater benefit than aspirin alone. The DAPT therapy produces a greater benefit when used for 1 year in post PCI patients also, that has been already discussed. The DAPT therapy also produces greater benefit in medically managed STEMI patients. So STEMI, non-STEMI and post PCI, the DAPT clearly was the winner. The routine use of DAPT for high-risk patients showed no benefit over aspirin alone. Again, the bleeding issue comes. Prasugrel, then came the prasugrel. So the Triton TIMI 38 was a landmark trial where the clopidogrel was of high-risk acute coronary syndrome patients scheduled for PCI. Now this is, again, it clearly mentioned that prasugrel is working much better than the counterpart clopidogrel. So in coronary syndrome going in for PCI, this trial again paved the guideline that the prasugrel plus aspirin would be better than clopidogrel plus aspirin. So this is for secondary prevention. Again, this is a trialogy, acute coronary syndrome. This mentioned that prasugrel is again better than clopidogrel. So summary wise, if we take prasugrel into account, medical management for ACS patients, no role. Invasive, so it has to be restricted to only patients of acute coronary syndromes going for PCI. For invasive management, PCI with no risk of bleeding complications, it's reasonable to think that prasugrel should be preferable over clopidogrel. But in patients who are more than 75 years of age, less than 60 kg of weight, and prior transient ischemic attack or stroke, prasugrel is not recommended or contraindicated totally. Then came the ticagrelor. It went on, it kept on improving further. So ticagrelor versus prasugrel, I think we all know the data, and now ticagrelor plus aspirin is the choice of antiplatelets for all the interventional cardiologists, for all the cardiologists for acute coronary syndrome, because there is no data of prasugrel to be used in patients of acute coronary syndrome as such. So it has to be restricted for acute coronary syndrome going in for PCI. So we have various data available with ticagrelor also. The Plateau was again a landmark trial, huge number of patients. So it clearly mentioned that ticagrelor is beneficial than clopidogrel plus aspirin. So ticagrelor plus aspirin combination was doing much better as compared to the other combination. Then the long-term thing. So this is probably what we are thinking at. The Pegasus TIMI 54 trial, it clearly mentioned that if we continue the ticagrelor with aspirin and decrease the dosage little bit, it still is working. So this trial mentioned that if ticagrelor dosage is reduced from 90 milligram twice a day to 60 milligram twice a day, probably this is better, but it was compared against placebo. It was not compared against aspirin and clopidogrel. It was compared against aspirin and placebo. But then there were no high bleeding incidences happening if the dosages are reduced further. So this mentioned that we can continue with ticagrelor plus aspirin at a reduced dosage in a long-term patients. So DAPT after a stent implantation, I think this was not the topic of for me, but there are a few slides into that. So this is a very important slide. We have to ascertain the fact that whether we are dealing with a patient of high ischemic event risk or we are dealing with a patient of high risk for bleeding events. There is a mid zone, which is a sweet spot where we are perfectly comfortable, but we may have to defer or deviate our decisions on the extreme sides. Let's simplify all this, which we have talked about. So aspirin dose in PCI patients, 81 milligram is enough as per all the studies. Regardless of the stent type, ideal duration is 1 year. DAPT in PCI is for stable ischemic heart disease, DAPT in PCI for acute coronary syndrome, and we have to take into account the bleeding risk. Stable ischemic heart disease, DAPT consists of aspirin plus clopidogrel. For bare metal, 1 month minimum DAPT should be given, and then we can switch over to a single antiplatelet. Current drug-eluting stents, 6 months is minimum, and if no bleeding risk, continue longer with both the groups. So ACS patients, at least 12 months for both bare metal and drug-eluting stents. Reasonable to prefer ticagrelor over clopidogrel, reasonable to prefer prasugrel over clopidogrel if the patient is not at a high bleeding risk or is not having a prior history of CVA. I'm cutting down a few points as I'm running out of time. Anticoagulation, just 2-3 slides. So atrial fibrillation is one dilemma issue. If the patient is having atrial fibrillation and presenting with acute coronary syndrome, this is one thing which is very important. Antithrombotic therapy is recommended for all patients of atrial fibrillation except those with low risk. Assessment of bleeding risk should be done when prescribing an oral anticoagulation therapy. Where oral anticoagulation is indicated, the newer oral anticoagulants should be used rather than warfarin. So CHAD-VASc score, we all are calculating. This is very important to decide whether to anticoagulate in patients of atrial fibrillation. So using the score, I think if the score is 0, no anticoagulation is required. If the score is 1, the second point is more important. If the score is 1, and if the score is 1 because of the gender only, still we may not decide to use the anticoagulation, or use only aspirin, or use anticoagulation. This is a gray zone if the score is 1. But if the score is 2 or more, clearly the oral anticoagulation is required. So direct oral anticoagulation, these are the things, and Dr. Kasliwal has really pointed out nicely. There is a study of COMPASS with rivaroxaban. Warfarin should be restricted for mechanical heart valves, valvular atrial fibrillation, and end-stage renal disease. Otherwise, in all patients, we should use the direct oral anticoagulation. So to conclude, the DAPT is indicated for at least 1 year after acute coronary syndrome. Duration of antiplatelet therapy is based on ischemic versus bleeding risk. Obviously, if the bleeding risk is high, we have to restrict the DAPT duration, which is 6 months, or it can be reduced to 3 months also if the bleeding risk is higher. Newer generation of stents, DAPT duration is shorter in special situations, like the patient is going ahead with the non-cardiac surgery. The protocol which we follow, at least 6 weeks of DAPT and then aspirin alone, and patient can go with non-cardiac surgery with the latest generation of drug-eluting stents. In patients with prior myocardial infarction, benefit with extending DAPT beyond 1 year. Calculate the bleeding risk for ischemic risk in assessing the duration. This is very, very important. I think the cornerstone of the whole discussion is based upon this fact, that whether to continue DAPT for more longer period of time, or we stop the DAPT early. Thank you.
Thank you, Dr. Rajneesh. I think we can take the last speaker, then we will have a discussion.
Yeah, sure.
So may I invite Dr. Narang, please?
Yeah, morning. Good afternoon, sorry, it's now. So I just like to share my screen here. Can you hear me, please?
Yeah, yeah.
Yes, sir.
Yeah, okay. So can you see the slides?
Yes, it's visible.
Can you see my slides, please?
It is visible, sir.
Right. Okay, thank you. Thank organizers for having me here. So I'll be talking about the perioperative management of antiplatelets agents, when and how to start and stop. So basically, this is a very common, important clinical situation where we have to deal with this. So first of all, I like to show an overview from Cochrane Library about the studies that have been done in this area, that in the perioperative settings, whether the stopping antiplatelet helps and how much does it help. So this was a Cochrane review in conducted in 2018, and they had looked at various aspects. And the key question that they were asking was that whether continuing to take antiplatelets or stopping before non-cardiac surgery increases the risk of serious bleeding or ischemic events or death in adults, and when compared to non-stopping, basically. So we have to try to find a simple answer whether to stop or not stop. Although theoretically we feel that it has to be stopped if the bleeding risk is there. However, the key results show that actually you can see the lines which are in bold. There was a little or no difference to the number of people who died, little or no difference to the incidence of bleeding serious enough to need a blood transfusion, and little or no difference to the bleeding serious enough to require further surgery, and also no difference between ischemic events such as stroke and heart attack. So this was a little surprising. The Cochrane Review has done an overview of the studies. However, the number of studies was a little smaller. 4 or 5 studies were only there, and the number of participants was also maximum of around 650 participants. So some less work has been done in this area, but whatever the data is available, we don't have hard data to say that stopping of the antiplatelet agents makes a difference. However, since data is not there, we have to go by our logical decision making and to find out. And therefore, most of the reviews and most of the guidelines, they have given a approach to what to do about antiplatelet agent in the perioperative setting. Now, basic thing as has been discussed by previous speakers also, we have to balance between the bleeding and the thrombotic risk. So a patient has, for example, classical example, patient has a coronary stent implanted and he undergoes a non-cardiac surgery. So he can have 2 complications. He can have a post-operative bleeding, excessive bleeding due to antiplatelet therapy. On the other hand, if the antiplatelets are stopped, then he can have a stent thrombosis and ischemic complications. So we have to balance between these 2. And so basically we have to try to quantify the thrombotic risk and the bleeding risk. So the thrombotic risk is shown in this table. We have to try to quantify the patient, whether it's a low risk, intermediate risk, or high risk. So if we focus on the intermediate risk, that after plain old balloon angioplasty POBA, it should be more than 2 weeks and less than 4 weeks, that is intermediate. Less than 2 weeks is high risk and more than 4 weeks is low risk. On the other hand, with the BMS, it is 1 to 6 months. They're hardly used now. And for the DS, 6 to 12 months is intermediate risk. Less than 6 months is high risk. And more than 12 months is low risk. So for the complex PCI, actually, more than 12 months also remains intermediate risk. So this is important. So on the other hand, we have to check the bleeding risk of these patients also. And that basically depends on the type of surgery which is being done. And so this also low, intermediate, or high bleeding risk we have to try to classify. And as can be seen in the rightmost column, the minor orthopedic, ENT, endoscopic procedures, breast surgery, carotid peripheral vascular surgeries, dental extractions, eye anterior chamber surgery, they are all low risk. On the other hand, most of the surgery which are major intrathoracic or intraperitoneal surgeries, cardiac surgery, open aorta, orthopedic, ENT, urology surgery, they are all in the intermediate risk. The intracranial neurosurgery and extensive thoracoabdominal dissection surgeries, they are high-risk surgeries. So these we have to keep in mind, and we have to, for advising any patient, we have to be clear what surgery the patient is undergoing. So now basically we have to we have 9 cells of 3 of the thrombotic risk versus 3 of the hemorrhagic risk. So these are the tables which have been created by different guidelines and different reviews. Fortunately, if we see carefully, much of the patients, they can be managed by a simple approach of continuing aspirin and discontinuing P2 vital receptor antagonists. So, that takes care of most of the patients who are in intermediate risk, and also patients who are in the low risk. Only patients who have got a high thrombotic risk there and low hemorrhagic risk, we should send the patient to continue on DAPT and to have a low risk surgery. That is what can be done. On the other hand, if the hemorrhagic risk is low and the thrombotic risk is also low, then we have to consider that in some patients, the patients may be even stopped aspirin also, no antiplatelet. Then generally this is done when the patient is on aspirin for primary prophylaxis. However, that is not being used anymore these days. So then there are some which are bridging therapies are there. Once we restart, because we have to restart antiplatelet agent soon after, as soon as possible after surgery, and generally this weighs from 24 to 72 hours. And in the meantime, one can apply some bridging therapies also, and so as to provide rapid antiplatelet effect by intravenous medication. And the agents which are available are cangrelor, and otherwise one can also use glycoprotein 2b3 inhibitors like abciximab, peptifibride, and tirofiban. So, however, one should be very careful that excessive dose of these may lead to bleeding, and generally loading dose is not given in this situation. So these are again the table showing the intravenous antiplatelet bridging agents that can be used. And one should note that the cangrelor has got a very short half-life, and therefore the offset of action will be in 1 hour only. So that is a very suitable agent in this setting. No bolus dose is given in this setting. So this is generally the kind of time which has been recommended, or flow which has been recommended. So at time 0 is the surgery, and one can stop the antiplatelet agents like clopidogrel and ticagrelor are best stopped around 5 days before surgery, and prasugrel has a longer half-life, it has to be stopped around 7 days before surgery. And in the meantime, from 5 days to or 4 days to the day of surgery, one can put them on cangrelor. Similarly, after surgery, as soon as the bleeding risk reduces, which can be within a few hours also, one can restart cangrelor, and simultaneously one can start an oral clopidogrel or oral other antiplatelet agent also. So other people have also, like British Committee of Standards, this is a popular guideline. They have shown similar one, which are generally used in the UK. So I'll just this is a similar table by the other things, by other committees also, and basically it is saying the same thing, that one has to weigh the bleeding versus the thrombotic risk and try to adjust according to the individual need of the patient. So this is another, some flowcharts are also there, which also put the same thing in a little algorithmic manner. So restarting platelet antiplatelet should be as early as possible. Loading dose can be given. IV cangrelor as a bridging therapy can be done. So there's some, for this one, I'll take a few seconds on this, that there are some antiplatelet reversal therapies are available, like tranexamic acid. So this can be given, the patient has to be taken urgently for surgery, and the patient is on antiplatelet agent, and one expects bleeding to occur during surgery, one can give a intravenous tranexamic acid. Other agents are also available, but tranexamic acid is the one which is most commonly used. So this is another point that, for in the current state of art, current research is going on in bedside genotyping and bedside point of care devices to find the platelet function test. And according to that, one can take up the patient for surgery. So this is the active area of interest for future development. So these are, I would just conclude by saying the multiple factors that need to be taken into account. Balancing thrombotic and bleeding risk is the central aim, and approach has to be individualized. Reversal agents are available and bridging agents are available, which are probably underutilized at this stage. And for future research, is point of care platelet function testing and genotyping are the main areas. Thank you.
Thank you, Dr. Narang. I think Dr. Omar is there. Any questions we have? Otherwise, we are already late by 20 minutes. 30 minutes.
I think all the lectures were very, very good and informative. I don't have anything to ask to. It's quite elaborate.
Sir, good afternoon. I have a question. Many a times we see we do pacemaker implantations on patients on dual antiplatelets. So where do you place the pacemaker implantation procedure? Where is it a non-cardiac surgery? Where there's a low risk or intermediate risk? Where do you place this? Because there is a device inside, and we are very worried of a hematoma formation.
Sure. So one can see, for example, one can see even CABG. CABG is also intermediate risk. The aspirin does not need to be stopped before CABG. The second point of the bleeding risk, we have to assess whether the bleeding can be stopped by local pressure, whether the bleeding is available locally or not. That is the main thing. And here is a site where the bleeding is largely available, amenable to local pressure, and therefore this would come in a patient, either low risk, low to intermediate risk. I won't keep it at high risk at all.
Sure, sir. And one more tricky situation we face, that many patients, it's not related to antiplatelets, but related to the antithrombotics. Like some patients of post-valve replacement, they are on anticoagulants and they need pacemaker implantations. So how to stop those agents?
Right. So anticoagulant is a different issue. So anticoagulant, that is why I did not touch it. It is a different area altogether. So I was so anticoagulant is a different issue. But of course, they are stronger agents. The bleeding risks are a little higher there, and the reversal agents are also different. So one has to then take into have a different approach. So one has to be a little more careful as compared to antiplatelets while pacemaker implantation.
Thank you, sir.
Sir, can we move to the next presentation from Dr. Ripin Gupta, since we are running behind our schedule by 30 minutes?
Visible?
लेक्चर था नहीं, चौथा लेक्चर कहाँ से है?
Is my screen visible?
Yeah, very much visible. It's nice.
Good afternoon, everyone. I'm going to talk on a new concept, basically ischemia with non-obstructive coronary artery disease. The current concept. Basically, we all see patients of INOCA. We used to label them as having no heart disease and send them out of our OPD once we have done angiography, which is normal. But now this is a well-established entity with a lot of studies going on. So let's see what is this INOCA, which we are not talking about. And angina pectoris, as we know, is a very common symptom of coronary artery disease affecting millions. But of the patients who go for an angiography, around half the patients will have some form of evidence of myocardial ischemia, either a positive treadmill test or a stress echo or a stress thallium. But once we do an angio, we just find a blockage which is not critical, less than 70%, maybe 20, 30, 40% blockage in the heart arteries. And we'll usually label this patient as having a non-cardiac chest pain, refer and send him out that, okay, you don't have any heart problem as of now. But now we have an entity known as INOCA, which is a non-obstructive coronary artery disease, but with a demonstrable ischemia on one of the tests. So, and this is how the flow goes. Patient has a chest pain. We do a diagnostic test, followed by an angiography. We find blocked arteries. We put in a stent or a bypass. This happens in 1 in 5 patients. But in 2 out of 5 patients will have non-obstructive coronary artery disease, which is INOCA. And these patients will always be managed in a stepmotherly fashion. We don't know how to manage these patients, and they will always come back with chest pain in our OPD. And a lot of these patients will re-attend more emergency admissions, because we again don't have an answer. And initially it was thought that this condition is benign, but we know that these patients are having more risk of cardiovascular events and even myocardial infarction as compared to a person with a totally normal coronary arteries. So clearly, INOCA is not a benign condition. And this is how a new labeling is proposed, where ischemic heart disease is divided into stable and acute coronary syndrome. And in stable, we have now obstructive coronary artery disease and INOCA as a second entity. And the 2 main mechanisms of INOCA are coronary microvascular dysfunction leading to microvascular angina and vasospastic angina, and these 2 can coexist also. And most of these patients will have some form of coronary atherosclerosis also. And there can be overlap between the 3 syndromes also. So a patient can have a 60-70% disease in one artery, which may not be contributing to his symptoms right now. And along with that, he can have a mixture of CMD and vasospastic angina also. And if you look at the studies, in one of the studies it was seen that around of INOCA patients, around half were having microvascular angina, 17 were having vasospastic angina alone, and 21%, that is 1 in 5, were having a mixture of 2. And the risk factors which for INOCA are not exactly similar to traditional cardiovascular risk factors. Smoking, age, hypertension, and dyslipidemia are associated, but pro-inflammatory markers may be very important. And it has been seen that in patients with SLE and rheumatoid arthritis, there is more evidence of CMD. That is, so these are at a risk patient for INOCA. And after menopause, we have more inflammatory disorders. So which may be the reason that more cases of INOCA are seen in females as compared to males. And psychosocial stress could also play an important role in INOCA. So there is a difference in this, and the risk factors also vary. If we divide microvascular angina and vasospastic angina, we can see that dyslipidemia and is more in microvascular angina, while vasospastic angina is more associated with smoking. And symptoms are more in microvascular angina as compared to vasospastic angina. And the symptoms could be similar to typical angina, or can patient have symptoms like breathlessness, pain between the shoulder blades, indigestion, nausea, extreme fatigue and weakness. So symptomatology can vary, and it is not a benign condition. If we divide the patient into normal coronary arteries with mild disease, and obstructive coronary artery disease, we can see that in various studies, the event rates are higher than as compared to normal coronaries. And the annual rate of death or cardiovascular disease is something like 2.5% per year, which is not as high as a obstructive coronary artery disease, but it is much more than a normal person. So clearly this condition is not benign. It carries morbidity and mortality, and so we need to diagnose this condition, and we should need to treat this condition. And how to evaluate a patient? Normal is that routine patient comes, we take the symptoms, history taking, a routine examination. ECG mostly is non-diagnostic, and then non-invasive testing is usually done. But for this, we need to do either a myocardial perfusion imaging or a cardiac magnetic resonance imaging to look for a functional defect, or a PET scan, or we can do a CT first to rule out obstructive coronary artery disease. So let's say we do a patient has typical angina, we did a CT which is showing a mild disease, then we have to do either a PET or a magnetic resonance imaging to detect whether this patient has evidence of CMD. Transthoracic imaging and looking at the Doppler flows in the LAD arteries is possible, but then that is only done by very experienced persons. Not all can do that easily. And once we have taken the patient for a coronary angiography, then we can do, after if the angiography showing a mild disease or borderline disease, we can do a diagnostic guide wire test and check the FFR and CFR and IMR. And if the FFR is more than 8, but CFR is more than 8, that is normal. There is no microvascular dysfunction present. But if the CFR is less than 2, then we have a coronary microvascular dysfunction present. And in patients where we don't find a coronary microvascular dysfunction, or we have a suspicion that something else is going on, we can do a vasoreactivity test with acetylcholine. Now, this is not easily available. So that's how the diagnosis of INOCA is not that easy to make, because most of the times the tests we are advising are not routinely done in our cath lab. So FFR guidewire, I think, is not available in all the cath labs. And vasoreactivity test also is not routinely done by most of us, mostly done as a part of a study. But with the amount of patients we are seeing, I think we should now integrate this into our clinical practice. And when we do acetylcholine test, if we find a more than 90% stenosis, diameter reduction, and plus angina, plus EC changes, then it is labeled as epicardial vasospastic angina. If patient has a coronary microvascular dysfunction also, and we find angina when the ECG changes on with us some reduction in diameter of the arterial acetylcholine test, then it is a combined microvascular and epicardial vasospastic angina. And the recommendation for this test is again not uniform. Guidewire-based CFR is a 2A indication, but intracoronary acetylcholine is a 2B indication, and transthoracic Doppler of LAD or CMR and PET is again a 2B indication. So I think all these investigations have not been clearly integrated into our routine clinical practice. They may be part of studies, but not as a routine clinical practice. And I think we now have to start using these therapies as a routine clinical practice to diagnose the INOCA patients. And this is how it looks, doing a coronary angiography, then an FFR, then an acetylcholine challenge test. But most of the times we are not able to do all the 3 things. The management is again based on lifestyle changes. That is for coronary artery disease, similar to coronary artery disease, because most of these patients already have some atherosclerosis. Then risk factor management is managing hypertension, dyslipidemia, diabetes. And once we come to medications, statins and ACE have been shown to be of benefit. Along with that, for microvascular angina, beta blocker is the first choice. Second agent is calcium channel blockers. We can also try nicorandil if the 2 agents are not working, or give ranolazine. Even ivabradine and trimetazidine has been tried in microvascular angina. While for vasospastic angina, the first choice is calcium channel blockers, followed by long-acting nitrates and nicorandil. This is a study which is showing that these patients are not well managed, and most of them are not on therapy.
Times up.
Yeah. So just 1 minute. So this shows that we should go for optimal medical management in these patients, and a strategy of where we are doing a proper treatment. In this study, they have shown a stratified medicine approach, that angiography is done, followed by defined into a arm where we are giving a treatment according to the diagnosis. The patient is benefiting from the therapy. And to conclude, INOCA is a major health problem associated with underdiagnosis, undertreatment, and poor prognosis. It should be recognized as a clinically important entity in daily clinical practice, and a systematic approach to diagnose and treat should be implemented, and future research is needed in this because, as I told clearly, that this entity, we are recognizing it now, but still we are not sure how to approach it to treat for obstructive coronary artery disease. Thank you.
Yeah. Thank you very much. Actually, your presentation was extensive and I think very detailed, and I think most of us we could understand, and still we have to wait for further how to take on such patients. I think we move to the next speaker. We have Dr. Mudali, who's going to talk about device to decrease the infarct size.
Thank you, sir.
In the meantime, sir, may I have a question from Dr. Rapian Gupta?
I think we
Yes.
keep the questions at the end. I think first.
Because this session is already over.
Achha, okay, I think you can take the question.
He came afterwards. Just take comment or question maybe with Dr. Ripin Gupta.
Ripin, do you have a question? I think you can ask, please.
Yeah. Dr. Ripin, recently you must have seen, I have come across 1 or 2 patients after vaccination. They had sudden MI and they were non-obstructive cases. So this may be one of the, what may be the cause of in such patient. And one patient you must have also seen in the literature news, that patient was given injection diclofenac and after vaccination, and on the spot he died after acute MI. So in these cases, spasm was the main problem or anything else?
Can I answer this question? Ripin, are you there?
Okay, sir, you can.
Yeah, basically, see, whenever you had any severe viral or COVID infection, because of the severe inflammatory systemic disease, you tend to have the incidence of thrombosis is high. If a patient already has some disease, he is already on platelets, he's protected. Or if we, the physician or cardiologist, we have done the markers, obviously these patients can be put either on low molecular weight heparin or they can be put on Novak, as we people were doing. And what happens is, if we use diclofenac, diclofenac alters at times because it is when we talk about these analgesics, we are talking about diclofenac and even the other anti-inflammatory drugs, they tend to further alter the coagulation, the thrombotic, they increase the thrombogenicity. So then such patients may have arrhythmia, and they may have some event which can be fatal in those patients. And since you were asking about these patients, Ripin spoke about these patients who had normal coronary artery disease. Whatever may be the mechanism, these are mainly in females who have small arteries. They have connective tissue disorders, or they may have family history where the type of collagen may be of different type, where they go into more vasospasm. And these are the patients who are basically who have the presentation like this with normal coronary arteries.
Must have gone through the recently one young doctor doing PG anesthesia, and after vaccination, she was given for pain, local pain, a body ache. Her husband has given, he was doing PG surgery, and the wife was PG anesthesia. He has given a diclofenac injection intramuscular. Come to the.
Similarly, we have incidents where people have gone into renal failure. Yeah. So these are the drugs which alter the, they have a negative effect on the inflammatory disease, and that is how we lead to problem. I think now we move to
I have
the
a small
second
question,
talk.
sir, very relevant. Very relevant. See, whether it was anaphylaxis or whether it is blood clotting, currently with the oral anticoagulants and blood thinners, you are not giving the vaccine as per the protocols. But is there any role for giving an antihistaminic or antiplatelet agent with a vaccine so that you don't have these problems?
Antiplatelets are not stopped. Second thing is, when anyone is on
Only they're following the
anticoagulation,
protocol. Even in my hospital, at least they say even the 1 week back, which is some fact sheet which has come, if a patient declares they are not giving the vaccine. So there is a mismatch between the,
Listen.
blood clotting.
Yeah, I'm answering your question. See, no, you're talking about stopping of antiplatelets and you're talking about anticoagulation.
The question is, whatever reactions we are having, if we are having, they are due to either clotting or anaphylaxis. Should all patients be given a tablet of Avil before a vaccine dose?
No, you can't do like this. No, see,
You
the
can't do
issue
like
is,
this. That is what I'm saying.
yeah, the incidence is
Otherwise, we
very
are
less.
discrediting the vaccines. That is what is happening.
No. See, the issue is when you have 100 people taking or 1,000 people, you will have at least 1 to 5 people who can have allergic reaction.
Exactly.
And at times what happens is, like if someone is say already had say viral fever say about 5 days back, and if this person takes, so then at that time the allergic reaction may be more. So it is the circumstances where, because anaphylaxis generally occurs very, very infrequently, because those individuals have to be very hypersensitive. But second is when you are not well and you have you take the vaccine. So then, because already the patient has an altered systemic profile where he can have some problem, and that time you take so that which we take it as a normal thing. So any fever, any viral fever, any gastroenteritis has to be taken seriously. You have to give a gap of 4 weeks before you take the vaccine. So that
even for a URI, simple URI, sir. Even for a simple URI, you should have a gap of 4 weeks.
No, the issue is.
So I think
yeah.
We should proceed, sir. This is not the relevant discussion.
Yeah, I think I agree with you. Yeah. So I think we go ahead with the next speaker, Dr. Mudali. Please. Yeah, you can.
My topic is on device-based approaches to infarct size reduction. So it's not moving forward.
Go to the share screen.
Can you see that?
Yeah, it is visible.
So mortality rate is recently a Sweden report suggested the mortality rate associated with STEMI has remained plateaued for last 1 decade, and it has remained at around 3 to 4% and for a 30-day mortality rate, even if patient receives PCI. And about 28% of patients post-MI, they go on to develop heart failure on 90 days despite available practices. So infarct size may be because of ischemia or even reperfusion injury. It strongly correlates with subsequent mortality, heart failure, and hospitalization related to heart failure. A report from GW Stone suggested that every 5% increase in infarct size has been seen to contribute to around 20% increase in the all-cause mortality rate or heart failure hospitalization at 1 year. So we can see here in this graph that the highest quartile patients who are whose infarct size was in the highest quartile, they were likely to have 7 times higher incidence of myocardial infarction and other cardiac events in comparison to patients who have infarct size in the lowest quartile. On the right side, we have walk plots. We suggest that this infarct size is independently associated with mortality and as well as the heart failure hospitalization. They're not exactly related to reinfarction, but still it is strongly correlates with mortality and heart failure. So these are the 3 devices which I would like to classify them into a failed therapy. They target primarily reperfusion injuries to prevent reperfusion injuries. This include manual aspiration, mechanical thrombectomy devices, and distal protection devices. The catheters like Export, Pronto, or Thrombostat, they are the manual aspiration catheter devices. They have been tested in Expira and Tapas. These are the 2 trials which suggested a beneficial effect of using manual aspiration. However, larger randomized trials like TEST and TOTA, they suggested otherwise. I mean, they could suggest that there was improvement in the ST resolution and even decrease in infarct size also, but this did not translate into clinical outcome study when they tested these manual aspiration devices. In total trial, they also found an increase in incidence of stroke risk, so thereby posing a safety concern. And after that, American Association guidelines, they have downgraded the use of this device from class 2 recommendation to a class 3 recommendation for routine use. The same is manual thrombectomy, including the angiojet and filter wire devices. They are also they are no more in routine use today. So you can see here The other devices, that is the sonothrombolysis, this is not exactly a device, but here what we do use a diagnostic transducer echo and use this high mechanical index impulses during infusion of a microbubble. So Mathia, they took 100 patients in a pilot randomized trial, and in 50 patients, they, along with this, just before PCI, they did the sonothrombolysis, and also to complete the sonothrombolysis, they also did the sonothrombolysis after PCI also. So 20 impulses were given in each view with a 50-minute duration. Each view means it has to be in apical 4-chamber view, or a 3-chamber view, and a 2-chamber view also. So what they found, the rate of culprit artery opening and ejection fraction, they are all improved, and infarct size is also reduced. The second category, that is, they have been found to be promising in trials, that is the interlesional application of GP2B3 inhibitors and stand-based exclusion devices, that is the MGUARD stand, and for interlesional delivery of GP2B3 inhibitors, the Clearway RX catheter, there is a local drug delivery catheter, microporous vaping PTFE balloon mounted catheter on a 2.75 inch rapid exchange guide. So these are the two devices which have shown some promise at least. You can see that in infuse AMI, the GPT-3 device was used, and it has reduced the infarct size, percentage of infarct mass, and abnormal wall motion scores are also improved. And in master trial, which used the MGUARD stand, and in very few patients the MGUARD prime stand, they could also find the same thing. However, in master 2 trial, that was more of a pivot trial, that was prematurely terminated because of higher rate of dislodgement of this MGUARD stand. MGUARD stand is a problem of dislodgement, along with because it is a two-layered stand, bare metal stand, and so it is higher chances of side branch occlusion, also higher rate of restenosis. So a drug-eluting stand version of this MGUARD is under development, is also need to be tested. This is a promising device, rather this is a proven device, that is giving supersaturated aqueous oxygen delivery system, that is Therox SSO2 system, which gives oxygen at a very high pressure, that is 760 to 1000 millimeter of mercury, by using a 7 French or 8 French guiding catheter directly into the lesion. Microscopically, you can see the area of infarction that has gone down from this to very small area, and microscopically it has been seen to reduce endothelial swelling and hence increase in the luminal flow. This was tested in AMIHOT-2 trial, which could show a 26% relative reduction in the median infarct size by using this supersaturated oxygen therapy, and also a comparable 30-day MACE results. On subset analysis, you can see the patients who presented within 6 hours or even less than 3 hours, they are more likely to be beneficial than others, and patients who had at presentation better TIMI flow, they are more likely to get the benefit of this supersaturated oxygen therapy beyond PCI. However, there is a concern of increased incidence of stent thrombosis and death by using this supersaturated oxygen therapy. So what they did, they modified the system and brought a simpler system, that is, and also changed the concept that instead of giving the oxygen therapy at the lesion site, they started giving the oxygen therapy at left main only, and using a very smaller size catheter, that is 5 French diagnostic catheter. They reduced down the duration of infusion from 90 minutes to 60 minutes. That is the optimized SSO2 delivery system. That was tested in ICE-HOT trial. 1 year result of which I am showing is the 1 year result of this ICE-HOT trial. All-cause death and new-onset heart failure was reduced down to 0, and it is significantly improved the outcome in comparison to patients who are not receiving supersaturated oxygen therapy. And basing on these results, FDA has approved this device for the treatment of patients with anterior MI undergoing primary PCI within 6 hours of symptom onset. And there are also emerging devices including LB, Impella CP, mild hypothermia, and Pixo. Impella CP, as we know, that is primarily unloads the left ventricle, and by delaying reperfusion by around 30 minutes, activates a cardioprotective mechanism that reduces mitral damage. So basically, what I told previously was targeting reperfusion injury. Now this device, by doing a myocardial unloading, it is targeting ischemic injury by delaying the perfusion for around 30 minutes. Now, the trial by Dr. Naveen Kapoor in anti-STEMI patient, 50 patients were taken. They did use STEMI trial. They were randomized to unloading with immediate revascularization or unloading after 30 minutes of delayed revascularization. And impella was continued for at least 3 hours after the procedure. This is a proof of concept study. This was not like a study like for showing a superiority or non-inferiority outcome. So this was a proof of concept study. What they could show that despite delaying that perfusion, what they could achieve was a similar infarct size and infarct salvage index and microvascular obstruction in comparison to patients who underwent immediate revascularization. So there was no harm signal by doing this myocardial unloading of and delaying the revascularization for next 30 minutes. At 1 month, they also could show that the end systolic dimensions as well as the end diastolic dimensions, the blue lines, they was found to be reduced at 1 month by the use of this myocardial unloading and then delaying the reperfusion. Another one being the hypothermia. There are many methods for doing hypothermia, reducing hypothermia by using endovascular cooling. Endovascular cooling methods are relatively
Mudali, time's up. So just your final, I think, final slide we want to see.
The another is the PIXO, that is intermittently increasing the mean coronary sinus pressure by using the balloon occlusion method. This results in redistribution of venous blood into the border zone, ischemic zone, and this also reduced the absolute. There was 7% absolute reduction in infarct size by using this PIXO device. And if we model that, then it comes to a 34% reduction in heart failure hospitalization and 25% reduction in mortality at 1 year. So coming to conclusion, despite successful primary PCI, microvascular dysfunction and reperfusion injuries, suboptimal mitral salvage and larger infarct size persist. Supersaturated oxygen therapy is the first FDA-approved device therapy that has been shown to safely reduce infarct size. Other devices have been promising, but the thing that we should remember that infarct size is surrogate marker. So reducing the infarct size may or may not convert to a beneficial clinical outcome. Thank you, sir.
I think you have covered most of the devices which are beneficial, and as you mentioned, the results we have not seen that too much of help in because nowadays we have good antiplatelets, and even the like we have more experienced people, so we are not facing too much of problems where we can document that to use these devices, because these are used only now infrequently. They would be required only infrequently, except you have a challenging situation where you have increased thrombotic load, where either you use a thrombolytic agent, or you may require infrequently glycoprotein 2b3 inhibitor. There, obviously, thrombosuction is also very important. And then you may put the patient on infusion in order to provide the decrease in the myocardial damage. But I think overall good presentation, and it was extensive, so we could really know about the various types of devices which could help us. So because infrequently we may require, and obviously we can use these devices to provide the benefits. Any other question? Anyone wants to ask any question? So I think we go to the next talk, which is by Dr. Krishna Mani, the pollution and cardiovascular disease. This is a very important and interesting topic, which let's see what we are going to hear from Dr. Krishna Mani.
Thank you, chairpersons and Dr. Mohan. And I would like to thank Dr. Mohit Gupta for having given me this topic. Are you able to hear me, please?
Yeah.
And in sharp contrast, and to take you all to the other end of the spectrum from Dr. Mudali's talk of high-tech prevention of the myocardial damage to a primary prevention at the ground levels. You'll all agree that STEMI plays a very important role for all of us in our all strategies And STEMI patients actually constitute the maximum in the whole in our treatment. I'll take you to a case. This was a case about, I did about 12 years back. He was a salesman, 32, very active person, non-hypertensive, non-diabetic, non-smoker, no alcohol, no family history, and vegetarian. Presented with severe chest pain around 9:30 a.m. with severe breathlessness, and he was brought to the casualty in a shock state. He was in pulmonary edema, his PO2 75, had an ECG, showed an extensive anti-wall MI. Echo is akinetic EF, and he was actually, because of he was taken to the cath lab and put in IABP and BiPAP. And actually, it's almost a 12-year-old. This you can see. This is May 2009. This I don't have the CD, which is corrupted, and fortunately I have this. This the first shot shocked me actually. There was a complete cutoff of the ostial LED along with the long big ramus, and there was a thrombus containing lesion. So I did this thrombus suction intracoronary streptokinase I had, So what all, I tried very hard, but the patient could not be, saved. I analyzed the history of the patient actually, and he's a young dynamic salesman, 17 years. He has been using two-wheeler across Delhi roads, including polluted, congested, narrow lanes, eating all roadside foods, vendors, use of extensive perfumes and deodorants. And the only risk factor I could that time would that is exposure to pollution. Coming on to what does the air pollution and chemistry, or what are this? The air pollution is a complex mixture of gases, phase, and particulate constituents. These particulate constituents are classified on the basis of the aerodynamic diameters, more than 10 microns to 2.5 to 10 coarse particles, less than 2.5 microns, and less than 1 ultrafine particle. The fine particles, less than 2.5 micron, pose the maximum health hazard. Over 90% of the pollutant mass in the mixture we breathe in our urban settings is from gases and vapor compounds, including volatile organic carbons. Ozone is one of the principal pollutants in addition to the number of inorganic, organic acids, both in gases and particulate phases. This is how the components of pollution are there. It consists of gaseous phase, mostly composed of carbon monoxide, ozone, sulfur dioxide, nitrogen dioxide. These are the components, if you find on the hoardings, you might have find on the crossroads, the carbon monoxide level, the ozone levels, the nitrogen dioxide levels, and the particulate levels. These are all are displayed on those, day-to-day basis. The hoardings are there. The fuel combustion accounts for 85% of this particular matter and 100% of these gaseous toxins, which we are breathing. This is how is the importance. Any particle which is less than 2.5 microns actually goes into the lung and gets absorbed, and all the particles which are ultra fine, less than 0.1, they are actually going to the bloodstream. And these are all the global data. I will not go into the details, but we can see that red line, India tops on the levels of toxic airs. China is next one, and this is India tops the list of Dubey's list of highest number of premature deaths due to ozone pollution. Air pollution thresholds and assessment. How do we measure? Measurements are done by the metric particulate matter. As I just alluded, this is the particle size that on the basis of the microns, and also the number of particles contained in cubic millimeter. This is how we quantify it. WHO recommends less than 10 micrograms per cubic millimeter for annual levels and less than 20 micrograms for the daily exposure. And air pollution over many parts of Asia exceed more than 35 all over, and where 99% of the people reside. The totality of the evidence demonstrates there is no lower concentration threshold below which exposure can be considered as safe at population level. There are some cardiometabolic effects of the, how does this mortality is affected. In JAMA, Mustafak had in a study, he had actually done 22 studies, actually, the meta-analysis. The short-term exposure of particulate matter of 2.5 or less than that increase the risk of acute MI by 2.5 to 5%. Given the fact that air pollution exposure occurs a lifetime, Repetitive, near continuous exposure to air pollution has been hypothesized to promote atherosclerosis and recurrent events. And also in a meta-analysis of 59 studies, each 10 microgram per cubic, this is an increment in the particulate matter was associated with absolute increase in the cardiovascular mortalities. In a meta-analysis of studies of short-term exposure to air exposure, the MI and myocardial infarction, that 2.5 particulate matter along with nitrogen dioxide and sulfur dioxide and carbon monoxide were associated with increased risk of myocardial infarction. In another trial in 2014 from in BMJ, it's a cohort study, showed 13% relative increase in non-fatal ACS with long-term exposure of particulate matter less than 2.5. Another Utah very important study, concurrent day exposure was associated of particulate matter less than 2.5 was with acute coronary syndrome. Even short term in a daily exposure basis also can lead to an acute coronary syndrome. Similarly, not only acute MI, the heart failure also has been associated with pollution. A systemic review and meta-analysis of 35 studies, a short-term increase in the gaseous components and particulate matter less than 2.5 was associated with risk of heart failure, hospitalization, and death. And in a recent study, 2018, from China, in 26 cities, high particulate matter less than 2.5, with an intraquartile increase of 2.5 associated with a relative increase, 1.3 increase in heart failure hospitalizations. And how does the relation with cardiometabolic risk? In the Journal of Hypertension 2016, a meta-analysis of 7 studies, a strong association was found between air pollution and hypertension. Short-term exposure less than a week of 2.5 micron, 210 microgram per cubic millimeters associated with 1.3 millimeter increase in both systolic and diastolic blood pressures, and long-term exposure will lead to chronic hypertension. Authors strongly recommend that of this particular trials, that the higher BP levels and hypertension is related morbidity is related to air pollution and it's in the global burden estimates. Similarly, insulin resistance and diabetes also is associated with pollution. In a meta-analysis of cohort studies involving a total of more than 2 lakhs participants, and type 2 diabetes and the relative risk of diabetes increased by 39% on exposure to exposure to the particulate matters of less than 2.5. And another meta-analysis of 13 studies also showed exposure to particulate matter and the gaseous toxins, especially the nitrogen dioxide, increased risk of diabetes and showed strong association with insulin resistance.
Krishnamani, final slide, please.
Okay, fine. The burden, and this is, there are a lot of markers. This is a 2018 review, and this is a concept of vulnerable plaque to vulnerable patient. And the air pollution has been associated with the arterial resistance. The mechanisms of mediated are through endothelial barriers, pro-traumatic pathway, autonomic imbalance, inflammation, central nervous system, epitonic changes, and all of them, the primary endpoint is oxidative stress. And we all know about oxidative stress in the endothelial dysfunction. We know the preventive measures at these, interestingly, no trials have demonstrated that any prevention, using a mask or something, can reduce clinical events. In summary, the environmental pollution is the largest cause of premature, irreversible death and disability in the world. In totality, all pollutions and exposure during the lifespan, air pollution is the largest or has the largest influence. Widely cited global burden disease study estimates about 9 million deaths directly related to environmental pollution. And other environmental factors like noise, temperature, psychological factors, they co-contribute along with the air pollution. In conclusion, epidemiological data has shown air pollution accounts for at least 6 million deaths per year. There is a compelling evidence of causal relationship between air pollution and cardiovascular death. Gaseous and particulate pollutants access the circulation through lungs. Indians are extremely prone to exposed to pollution and their effects. and maximum and N95 mask reduces the level of exposure, but the no scientific data has proven the benefits of cardiovascular health. 92% of the affected population are located in countries like India. Of cardiovascular risk factor, air pollution is the 5th most common cause of death after hypertension, diabetes, smoking, obesity. Available data shows, according to the that cardiovascular disease is all the factors, and WHO, AHA, ESA, all have formally declared air pollution as a risk factor for vascular disease. By thoroughly covering the broad spectrum, change in the air pollution may help the reverse the present course of avoidable disaster facing both the current and the human generation. Thank you all for the kind attention.
Thank you, Krishnamani, for extensive talk. I think you spoke in detail, and I think you covered all aspects of air pollution very nicely to tell us about the bad effects of pollution causing increased events. And we're already running late, so we're going to just go ahead to the next topic, which is by refractory angina by Dr. Sapal.
Yeah, is the PPT visible to all, sir?
Yes, sir. Please put on slideshow, sir.
Yeah.
They would just request to stick to the timeline.
Yes, yes. Yes, so in the interest of time, I'll start straight away. The topic I've been given is refractory angina in 2021. Now, somebody asked me, how does refractory angina in 2021 differ in any way from 2019, 18, 17, or 16? And frankly speaking, I'll say that the topic is easier to cover in 2021 vis-a-vis earlier, because many of the therapies that were being tried have by and large been shown to, well, at least in sham control trials, provide no benefit. So the guidelines have now restricted the number of feasible therapies to very few. So before we move to refractory angina, the first thing we need to be clear about what is refractory angina. And with regard to the definition itself, there are two schools of thought. One is that any kind of angina, whether it with obstructive disease or without obstructive disease that we cannot relieve, is refractory angina. And common sense says that they are correct. However, for sake of uniformity, I will stick to the other school of thought, and this definition is from the ESC 2019 consensus statement on chronic coronary syndromes. And they say long-lasting symptoms due to established reversible ischemia in the presence of obstructive CAD. So they take your entire INOCA subgroup out of the term refractory angina. And now if in presence of obstructive CAD, you have reversible ischemia, you cannot control it either by escalating all the medical armamentarium that you have. A surgeon says he cannot operate, reasons we will see subsequently, and an interventionist says he can do no help. Then that patient will qualify for a patient of refractory angina. So when will a surgeon say he cannot operate? The most common condition is diffusely diseased distal vessels where there are no targets for graft. And this is where an interventionist, this is the Achilles heel of the interventionist also, where your stents will have no outflow. And the second condition is extreme degree or extreme number of comorbidities where neither the surgeon will take up the patient nor the interventionist. So these two subgroups largely comprise those with obstructive disease who are having who are being treated for refractory angina. So what is the disease burden? Now see, when the definition itself will have two schools of thought, any estimated prevalence will vary widely. And as it can be seen, the different studies will put your prevalence anywhere between 2% to 24%. But largely studies which take obstructive CAD as the criteria will put it to somewhere between 5 to 10% of stable CAD patients. The disease burden in the US, from where we have some reliable data, US and Europe, would be around 75,000 new patients being diagnosed with refractory angina per year, and Europe around 30 to 50,000 per year. Now, it is important to note when we talk about refractory angina, what we, yes. Somebody will have to mute. Yeah. So when we talk of refractory angina, at the back of our mind, what we have is that these patients, if the angina is not controlled, they're going to die soon. Well, mortality is there, but it is not really as high as the symptoms would tell us. And large series would show us mortality somewhere between 3.5 to 4% per year. So the objective of treatment primarily here is symptom relief. And how do we get to that symptom relief? For that, let us first see the pathogenesis of angina, and very briefly, because each of these is a potential target. Obstructive CAD, that obstruction you need for most cases. Well, the target, you know, is opening up this obstruction where feasible. Vasospasm. Now, vasotonic dysfunction and a high LV EDP. Now, these are also targets for therapy, including coronary sinus reduction, which may counter this to some extent. And if you cannot control the pain, if you cannot control the cause of the pain, then you control the perception of the pain, and that is where your entire neurological pathway comes into play. With whether we talk about a spinal cord stimulation, or we talk about sympathectomy, or wherever, or TENS, SENS. So we either control the cause of the pain to the extent we can, or we control the perception of the pain. Therapies like TMLR, I said in 2021, the topics is easier to cover because this is clearly class 3. It is not to be done. Therapies like cell therapy, very promising, but as of today, only experimental. So, as per the guidelines, 3 therapies that have made it to the guidelines, all in 2B indications, are EECP, coronary sinus reducer, and spinal cord stimulation. That is all. TMLR has clearly made it to the guideline that it is harmful, it is not to be done. So I shall be, while the PPT is exhaustive, for want of time, I shall be focusing on the 3 that have been that have made it to the timelines. Trials that we have are very few and far between. Sham control trial for external counterpulsation is must. That is the only one that we have, but it has its own drawbacks, and not all patients were those of refractory angina. For shockwave, etc., there is no data available. I'll not be putting much focus on it. Yes, coronary sinus reduction, phase 2 trial, sham control trial, COSIRA, yes, and has got its approval for COSIRA 2. For TENS, SENS, these are nerve stimulation methods, transcutaneous or subcutaneous. No data as such available. For sympathectomy, effectively negative, like that it behaves like a placebo, placebo-like data is available. Gene therapy, autologous cell therapy, what we for hard-end data, if you look for, what we have is a prematurely ended trial, the RENEW. So coming to the one of the 3 that I shall be focusing on, the coronary sinus reducer. So the CSR, the coronary sinus reduction will be helpful. The idea first came way back in 1955. And however, after that, opening of the epicardial coronaries, the technology moved so fast that this went to the back burners. And today it is coming back, because where the antegrade opening of the coronaries is failing, maybe this is old concept is going to help us. What is the physiology behind it? Exercise-induced sympathetic mediated vasoconstriction of the epicardial coronaries. Normally, the flow to the subendocardial epicardial ratio is maintained, that is a 1.2. In CAD, the LV-EDP also rises and the subendocardial flow is reduced. You have a ratio dropping down to 0.8, that is subendocardial ischemia. So what do we want to do over here? To counter that, we want to increase the back pressures. How do we do that? By artificially constricting the coronary sinus. This is the coronary sinus reducer, and a balloon expandable hourglass shaped stent, basically, which is narrowest around 3 mm at the waist. The data that we have, around 70% patients do respond to this therapy. Who would be the non-responders? Well, it is yet to be identified, but possibly those who have alternate well-developed system of drainage, just reducing the coronary sinus may not help. So that is one group who will not help. Secondly, this device is deployed around 2 centimeters beyond the ostium of the CS. So the middle cardiac vein has already taken off. So for left-sided ischemia, this is good. For right-sided ischemia, it is really not going to help you. Now, this is what it would look like on fluoroscopy. And one of the concerns definitely is, what if this patient requires a future CRT? It has been proposed that you can dilate this waist and then go ahead with CRT, but yes, that remains a major drawback. So the trial, I shall not be going into great details, but yes, it was a sham controlled trial, the COSIRA, and now since around 2017, the COSIRA 2 has been enrolling, showed significant improvement in CCS class. CE approval, this device has received way back in 2011. COSIRA 2 has received FDA approval around 2017. The registry data comes from the reducer registry. So moving on to the next therapy, that is EECP. It is important to note now for EECP, the first thing that comes to the back of my mind is that this is one therapy which has been misused to a very great extent. And by us only, means by some among us, and strictly it should be for refractory angina. This is one therapy which between 2014 and 19 has been downgraded from a 2A indication to a 2B indication. The randomized trial that we have is the MUST trial. What is the concept on which it works? So it is very similar to the IABP, working on the concept of diastolic augmentation. And what is the method? 3 pairs of cuffs are wrapped around the calves, the lower thighs, the upper thighs, and buttocks, and intermittently inflated at around 300 mm mercury. There's sequential distal to proximal compression upon diastole and simultaneously release of pressure at end diastole. So we're working on diastolic augmentation basically. Around 35 sessions required. And this is the design of the MUST trial. A number of issues with regard to this trial, but as far as the results are concerned, yes, around 15% improvement in time to 1 mm ST depression and a 25% reduction in angina frequency. Of note, not all of these patients were really refractory angina patients in this trial. Coming to the third, the neuromodulation. So the concept of all the neuromodulatory therapies is simple. For a patient to perceive pain, if from the afferents where he is getting pain, if you give a lot of different stimuli, maybe it may just close the gate to the painful input. So though you busy those afferents with different stimuli so that the pain is not felt. The techniques are different. You can have transcutaneous electrical nerve stimulation, subcutaneous electrical nerve stimulation, spinal cord stimulation, which has found its way to the guidelines, and I'll also mention a word about sympathectomy. So TENS, well, as I already mentioned, not much data available, but what we are doing is transcutaneous patches. We are giving multiple electric low intensity currents. The only genuine use is if you're taking up a patient for spinal cord stimulation, which is an invasive procedure, you can try TNS first, and if he's really responding, then maybe you should go ahead with SCS.
Final slide, please.
Yeah, so the 3 that I had to cover, including spinal cord stimulation, I have already covered. This is an invasive procedure done by the neurology or the interventional neurologist or the neurosurgeon, and this is on fluoroscopy what the spinal cord stimulation device looks like. The others are already stated, I will be skipping. So coming to how do you manage a word about sympathectomy, the data in favor and the data against. At least one randomized trial we have which said whether you inject bupivacaine or you inject normal saline, the patients do improve, but in both cases they improve similarly. Is it a placebo effect? We do not know. So ESWL, no data. So coming to my my conclusion, which is stem cell therapy experimental. So which is this flow chart. Just concentrate on the ones where obstructive disease is present. Left coronary system, CSR is an option. Right coronary system, CSR as an option is out. ECP or neuromodulation. But what is most important is, first, do you designate a patient as no option angina? Be very careful. It is not that if the patient has a CTO and you cannot do that CTO, he becomes refractory angina. Conventional therapies, if people are better at it, please send it to those people. But yes, those who genuinely have no options, you need a multidisciplinary team, you need a pain specialist, you need possibly also a neurologist in your team, and they need to be managed by a dedicated multidisciplinary team. Thank you. Thank you, sir.
Yeah, we had a detailed discussion, and I think you covered practically all aspects where we can provide benefit to these patients. these are difficult sort of patients who, in spite of the multiple drugs, these are the methods by which some patients would definitely have benefit. ECCP is beneficial in the subset of patients, and you mentioned about the coronary sinus reduction. I think that's also effective therapy. And the surgical aspects, surgery treatment also, I think looking at the spinal level also would benefit these patients. More, even the studies which you, if you see angiogenesis and gene therapy, they have also shown some positive results, and I think one is hopeful that they would also provide by increasing the collateral flow. I think
New angiogenesis, yes.
Yeah. So thank you very much, and I think we would now move to the next topic, which is management of asymptomatic LV dysfunction by Dr. Ambuj Roy.
Sir, Dr. Ambuj Roy is not currently available. Oh, okay, sir, he's already here. Sorry.
I share my slide. Can you see my slides?
Yeah, we can see.
Yeah. Thank you, Delhi CSI, for giving me this opportunity, and good afternoon, chairpersons and others on this virtual platform. So in about 8 minutes, I have to speak about management of patients with asymptomatic severe LV dysfunction. And so I'll just really look at 3 things. What is the burden of this problem? Why must we treat these patients, and what is the evidence-based evidence-based therapies available for treating asymptomatic left ventricular dysfunction patients? So over those next 7-8 slides, I'll just discuss that. So actually, if you see, the prevalence varies depending on the age of the study. Age of the patients included in the study, and the definition of LV systolic dysfunction, but it is to the tune of 7 to 8% in most of the population-based studies. And what is more important, that 3 out of 4 of these patients of LV systolic dysfunction are asymptomatic. So again, looking at the stages of heart failure which have been used by ACC to define heart failure, the largest chunk of patients are, especially in those above 45 years of age, the largest chunk of patients, of people in the population actually belong to this asymptomatic heart failure stage, which is stage B. It's more than the normal population, according to this Olmsted study from the US. From our MACE registry, which is a registry of post-acute coronary syndrome patients, if we see post-STEMI, large chunks of our patients are left with LV dysfunction, probably because of delayed management and delayed presentation of ST elevation MI. And almost 70% of the patient would be left with some some LV systolic dysfunction after ST elevation MI. So obviously the burden is huge and needs to be aggressively managed. Why? Because if we look from the look at the cohort of asymptomatic left systolic dysfunction patients, for every in mild to moderate and in severe LV systolic dysfunction patients who are asymptomatic at the beginning of this cohort study, about 4% in the mild moderate group and 10 in people in the severe group will develop heart failure every year. The annual rate of mortality in these 2 groups was 7 and 11%. So obviously this is a huge problem, and it is a potentially fatal condition that needs to be addressed rather aggressively. And it's very important that almost 56% of the individuals who died in the asymptomatic LV dysfunction, systolic dysfunction patients who died, did not develop antecedent heart failure. So SCD, or sudden cardiac death, was a very important cause of death in these patients of asymptomatic LV dysfunction. But with the growing armamentarium over the last 2 decades in management of heart failure and LV dysfunction, there has been a great movement forward. And if we just look at the 3 basic medicines, that is ACE inhibitors, beta blockers, and MRAs, we can reduce mortality by 56%. And if we add ARNI to that, it becomes 63%. So even with the generic drugs, more than 50% of the mortality reduction can be achieved, and it is within our purview to reduce this mortality, and it should be treated aggressively. What about sudden cardiac death? Again, in sudden cardiac death, the interventions over the last few years, beginning from the RAIL study to now the Paradigm heart failure study, if you see the medically treated arm, there has been a 44% reduction in the sudden cardiac death trials also over this period. And this study from the Glasgow group has very provocatively said that the improving medical management of its LV dysfunction it will make it difficult to show a significant benefit of ICD implantation for primary prevention in most patients with heart failure with reduced ejection fraction in the current era. And actually this was seen in the Danish trial. So medical therapy has really improved over these time periods, and it is high time that we use these in our patients to reduce mortality and morbidity. So I'll just briefly go over the do's and don'ts for all patients of asymptomatic LV dysfunction, and what is the evidence-based therapies that we should and what we should not offer. So all patients with asymptomatic LV dysfunction, we must treat their hypertension. If they have coronary artery disease, aspirin and statins are mandatory to reduce future ischemic events. Smoking cessation cannot be overemphasized in these patients. The second class of drugs with the largest evidence base is ACE inhibitors. We have the SOLVE prevention trial and we have the SAVE trial, which have clearly shown that in asymptomatic LV systolic dysfunction, also there can be a 20 to 30% reduction in event rates when we use this in these drugs. ARBs, there are no definite studies, but they can be used as a substitute where ACE inhibition is not tolerated because of cough. Beta blockers, again, we have evidence from post-MI studies in asymptomatic LV dysfunction patients, and it has been clearly shown to reduce the MACE rates. If you look at the STRITCH trial, and 11% of the patients were class 1, they were asymptomatic, and it clearly showed that surgery led to a significant mortality benefit over a long extended follow-up. So revascularization will help wherever there is ischemic heart disease associated with LV dysfunction. ICD, again, is a useful therapy if the LV systolic function is less than 35%. In fact, in MIDED 2, if we see 40% of the patients were asymptomatic, and they had as much benefit as the symptomatic group. So all-cause mortality is reduced by ICD. Flu vaccination is something that does not have a very robust data, but it is a class 1 indication in CAD for secondary prevention. However, of course, in asymptomatic patients, there is no role for CRTD. There is very little data or no data on use of MRAs in these patients without class 1 patients with and just asymptomatic LV dysfunction. Again, as for ARNI, again, there's not much of an evidence as of now, because all the patients included in Paradigm heart failure trial were symptomatic patients. And again, for SGLT2, again, all the patients in the trials were symptomatic patients. So as of now, it would not be indicated in asymptomatic LV dysfunction, but the future could be different if we have evidence for its use. And similarly, of course, digitalis, another drug in heart failure, will not have a role in asymptomatic LV dysfunction. So this kind of slide sums up the range of therapies that we should and we should not use in patients with asymptomatic LV dysfunction. So there's a lot that we can do for these patients. And I'll just end with this quote, which says that, we have knowledge about this. Knowing is not enough, we must apply. And willing it is not enough, we must do. Thank you so much.
Thank you. We are running quite late. So next we have Dr. N.N. Khanna. He has to attend an emergency. So we would have N.N. Khanna who would take the next talk. Dr. N.N. Khanna, please.
So can I share my slide?
Yeah.
I don't see.
They have not come yet.
So it's at the center bottom. There you see a share screen option.
Yeah, but I don't see that option. Green option. Okay, got it. Can you see my slide?
Yeah. Now we can see.
Yes, sir. Please put on slideshow, sir.
Thank you, Dr. Bhargav, for calling me because I've got an acute emergency in the cath lab. And thank you for the Delhi CSI to give me this opportunity, Mohit. So I'm going to be speaking in the next 8 minutes on cutting-edge technologies in critical limb ischemia. And just to give you an introduction, what critical limb ischemia is and how is it different from acute limb ischemia. This is essentially a disease of chronic duration. It involves lesions at multiple sites, usually presents with ulceration or slow healing ulcers or gangrene or sepsis. And many a times, if you don't treat it, it actually leads to amputation. What is more important to understand is if you have a CLI, you have a multivascular disease at multivascular level. And it normally, that is why it's related to higher mortality and morbidity from strokes, from acute myocardial infarction, and from renal failure. So when we are treating with CLI, we are not only treating with, revascularization of the limb, we are also dealing with revascularization and control of risk factors for the entire body. So with this background, let's come to the limb. How do we see what is the pattern of the disease? If you look at CLI, about 10% of the patients would be having an ioto-iliac disease. But the more problem occurs below the inguinal ligament, where 15 to 70% lesions are present in superficial femoral artery or popliteal artery, and about 30 to 75% would have lesions in the below knee vessels as well. And with this diagram in mind, one has to understand that if you can establish at least one straight line flow from the aorta down to the pedal arteries, this would be enough to sustain that limb for the gangrene to be prevented and ulcer to heal. So in the least situation, our aim should be to at least have one straight line flow from top to bottom. And the more you can revascularize, the better it is. And then we have some angiosome concept with just like the neurotome concept. It normally works, but we have to understand this is not very universal. Many people don't follow it. But what has been important is now we have technologies, which is the main topic of today. And we have different ways to treat medical therapy, surgery, and endovascular therapies. What we are seeing here is that over the past decade, there is the mortality and morbidity and amputation rate from CLI is coming down. And this is primarily related to increase in number of endovascular procedures rather than surgery, which is also coming down. Now, there have been key developments in areas of SFA and below knee angioplasty. So one has to understand that, the fancy devices which we see in the coronary intervention have all been first used in peripheral intervention and then, modified to and miniaturized to the coronary intervention. We had the first vein graft bypass in 1948. Then the first catheter dilatation was done by Daughter before coronary angioplasty in 1964. The first angioplasty was done by Grunzig in 1974, and this is the peripheral angioplasty. The first PTFE graft was done in 1976. Then we have the atherectomy devices before we have had it in coronaries in the peripheral circulation in 86. In 87, we had the bare metal stents, and this was by Julio Palmer. And then we had the first covered stent by Craig in 1993, and the first drug-eluting stent in 2001, and drug-coated balloon in 2003. So you can see that all these technologies have predated, their use has predated the use in coronary circulation. So there have been a parallel device development, and there have been a number of stents and balloon technologies and wire technologies which have developed. And what is very important is that the stents have evolved right from the bare metal stents to drug-coated, to drug-eluting stents, to covered stents. And now we have the self-expanding nitinol stents and nitinol, drug-coated stents. So we have a number of technologies. I'm not going to be going to each detail, but I'll just give you the concept, run you through the concept. From 1986, when we just had a bare metal stent, the next decade was our drug-eluting stent. And then we had different advancements in the drug-eluting stents and the design of stents. And like coronaries, the material of the stent stud changed from stainless steel to nitinol. The PTFE coating actually became better. The drug coating became better. The polymer coating became better, and that is how we are now at a stage that we have both drug-eluting stents and bioabsorbable scaffolds. So the lower limb intervention the technology has gone from balloon angioplasty to stents, stent graft, atherectomy, drug-coated stents, and now drug-coated balloons. So this is how it has progressed. And let's talk briefly about drug-eluting technologies in lower limb, which is the in thing today. And here we have drug-coated balloons, drug delivery balloons, which is not delivering in a chronic setting, but it is delivering drug right in the acute setting. And the drugs delivered here are the steroids, basically. We also have drug-eluting stents, and we have bioabsorbable scaffolds. So how it works, we all know as cardiologists, but what is important is that it should have an anti-proliferative agent, which is usually paclitaxel, but now we also have sirolimus. And we should have a tissue transfer efficiency, and it should not be lost in circulation, and there should not be a paclitaxel residency. There are some technical aspects. Most of the balloons and technologies would use paclitaxel except two, which uses sirolimus. But there are some important things with drug-coated balloons it is very important that they, like coronaries, that there is a good pre-dilatation. The drug-coated balloons are not dilatation balloons; they are drug delivery balloons, and they have to be obtain at least 1:1 ratio after we have a good pre-dilatation, which has to be 1:1. The balloon transit time inside the body should not be more than 30 seconds, otherwise you lose a lot of drug in circulation. And the inflation pressures have to be more than 7 atmosphere. And the time of inflation should be more than 2 minutes. And the final diameter which you get should not have recoil more than 20%. And in case you have dissection, you need to then put in stents. So, and we did have some dissections, and all the lesions were not being able to be dilated, and the results to be sustained just by drug-coated balloon therapies. So there was a need for bioabsorbable scaffolds, and this is what I will be discussing also. So if you look at it, most of the drug-coated balloons would have paclitaxel. Some of them do have sirolimus now. And this is a good slide which actually takes in different trials which have been done in peripheral vasculature. And these are trials including PTA alone, PTA plus provisional stents, primary stents, drug-coated stents, drug delivery stents, drug-eluting stents, covered stents, and atherectomy plus drug-coated balloons.
Dr. Khanna, the time is up, so
yeah, this is
you
the
can
last
rush.
slide.
Okay.
So what has been seen here is that the binary restenosis rate in conventional PTA, it has come down with the use of nitinol stents and come down further with the use of either the covered stent or drug-coated technologies and drug-eluting stents. So now in India, we have started using bioabsorbable scaffolds. I am one of the primary PIs for this stent. This is known as the Credence BTK stent. This was the case done in India Live 2 years back. And now we have a 2 years angiographic data, which was presented both in PCT and EuroPCR, 30 cases of BRS. And the good thing is that this works very well, and the stent is absorbed at the end of the 2 years in most of the BTK lesions. So I would sort of stop here and stop before this case, which was the last case which showed the use of current technologies in different lesions at different sites. So thank you very much for your kind attention. If there's any question, I'll be happy to answer.
Yeah, thank you for the present. Actually, we are running very late. We are almost half an hour late. So we'll move to the next lecture, which is by Dr. Dhal. So I would request Dr. Dhal to talk on anti-inflammatory therapies for atherosclerosis.
Thank you very much.
So I actually thought Mohan had forgotten that I was waiting, and I was very happy to skip these slides. So there have been a lot of talk today, and we are discussing anti-inflammatory. Much of this material I've got from my good friend Kunal from Shimla. So I'll just recap very briefly that we all know that this group from Peter Libby and Paul Ritker have been talking about inflammation for a long time. And we all know that there is a relationship with inflammatory disease. Even people who have got rheumatoid have very badly calcific, severe disease. People who have Takayusu appear to have a mixture of inflammatory and atherosclerotic disease. Somebody needs to unmute. So this leads to a complex pathogenesis of atherosclerosis in inflammatory rheumatic disease. And therefore, this also offers us a little bit of a window of opportunity to decrease this risk. What about subclinical atherosclerosis? Spain's leading bank is Santander. And Santander, the CEO of Santander, pursued a study called the PISA study. And what did he do? He took people who had some risk factors, nose disease, followed them up with a lot of imaging, especially whole body MRI and PET, and looked for arterial inflammation, the heat before the storm. And what did we find is that actually, wherever there was going to be atherosclerosis, there was, in fact, a lot of evidence of inflammation. This was taken down further and observed that there was not just calcification, which would come later because these were subclinical disease. There was a large lipid burden in these patients, which was possibly coming from a glucovian effect in these vessels. Further, using different markers with the PET scans, we could find this evidence in all vascular trees. Related to the pathobiology, it could be during the initiation of inflammation, endothelial damage, and subsequently plaque instability and rupture. We can take any kind of algorithm. At different stage, there would be different inflammation, different association of chemokines, cellular adhesion molecules, and acute phase reactants. So if we try to combine it, we get to understand that where oxidized LDL is getting deposited, we also have a lot of inflammation which is occurring, and this, the foam cell formation could actually be leading to release of pro-inflammatory cytokines. There could be a lot of inflammatory pathways here, and to summarize this very simply, we understand a concept of what is called the cholesterol crystals could make in an atheroprone person they could stimulate an inflammasome, and the inflammasome offers us actually a window of opportunity. So what do we do today to decrease risk burden? We all know that after statins, there is considerable residual risk. We can decrease residual risk by being more aggressive with statins. We also have data with ezetimibe. We have data now with triglyceride lowering with IPE. We also have data which comes from the Fourier trial with PCSK9 inhibitors. Data from inclisiran is coming up. And we have a possibility that we could add inflammatory component. So the same group, Paul Ritker, tried to use it in the Jupiter trial, which was almost like 13 years ago, to try and put it into different quartiles of inflammation, trying to assess whether those, even with normal lipid levels, LDL levels, if they have an inflammatory component, should they benefit with more aggressive statin treatment? And this could be taken to other biomarkers, DVT reduction, and we know that the value of HSCRP was something which got established internationally. But whether it would be applicable in India, where there is a large amount of inflammation and infections, is something which is still sub judice. But truly, this was one trial which did give us that if you have a potent statin therapy and you have a elevated HSCRP, these patients could benefit. The similar thing was tried to be used also with FRSs, but both statins and FRSs improved but did not eliminate vascular inflammation. What about PCSK9 inhibition? And we know that the Fourier trial, when we had an inflammatory subcomponent, it was shown to decrease inflammation. So whether by looking at lipoprotein small a, which not only is got a risk amplifier function, which is atherogenic, thrombogenic, and maybe also inflammogenic. Also, an epigenetic protein inhibitors were used in the BET bromelain antagonist in hyperlipidemic mice, and this was thought to be beneficial. So what about cytokines as therapeutic targets? It was thought through everything, and cytokines IL-1 and IL-6 were strongly suggested to play a causal role in atherothrombosis, with IL-1 beta being the most dominant circulating form. And this also causes upregulation of IL-6, and it lies upstream in the pro-atherosclerotic IL-1 beta, IL-6 CRP inflammatory axis. And if you look at this, this is the concept of the NOD-like receptor family, pyrine domain containing protein, which is called NLRP3 inflammasome. The caspase 3 is like an enzyme, and we have various things by which we could act differently to either block the IL-1 beta, the IL-18, IL-6, or also the HSCRP. So all this led to different therapeutic agents being tried. We could have IL-1 beta, IL-18 or IL-6 inhibitors, or we could have direct potential targets. We know that a few years ago, we were looking at the lipoprotein-associated phospholipase A, and we had drugs like DAPT, which are used. We looked at the mitogen-activated protein kinase with drugs like lospimod, which are used. The leukocyte adhesion molecule P-selectin had a monoclonal antibody called inclacumab. And then we had low-dose methotrexate and canakinumab. And finally, for microtubule polymerization, we had colchicine. So this has been a big journey from CANTOS to CERT to COLCOT to clinic. And we know that if we could not achieve by reducing residual risk by adding either an aggressive statin or using improve it by using ezetimibe or using Fourier, like a Fourier type PCSK9 inhibition, we could decrease some of the inflammatory risk even when the LDL is below 70 by using canakinumab. Now, canakinumab is actually, canakinumab was used in the CANTOS trial, which is an anti-inflammatory thrombosis outcome study, and it had a great doses response effect. There were a lot of improvement in MACE, MACE plus. There was a 30 to 45% decrease in HSCRP and IL-6 without change in LDL-C. And this was consistent across different baseline characteristics. Of course, there was greater risk reduction in the cohort which had higher HSCRP. It also surprisingly decreased the potential to malignancy. The flip side, the cost. So the amount of cost would be almost 1.4 lakhs per vial of this drug called Ilaris. And if you were very if you were really affluent, maybe you could prevent a lot of coronary artery disease, atherosclerotic disease, and also some malignancies by using this very disruptive, thought-provoking hypothesis. The CERT program used low-dose methotrexate, but it did not work. It did not work because possibly, unlike the CANTOS, they did not want to have an HSCRP for inclusion in the CERT, and also because the methotrexate does not affect the IL-1 beta, IL-6, CRP axis, which is the prime target in the CANTOS. What about colchicine? We know colchicine may act at the microtubules. It inhibits neutrophil chemotaxis, inhibits the inflammasome signaling, reduces the production of IL-1 beta, reduces neutrophil platelet interaction, aggregation, and also has been shown in animal data to limit the plaque growth, reduces HSCRP, IL-6, and also decreases the instant stenosis in diabetics, and may also decrease myocardial reperfusion injury. It is cheap. It is reasonably well tolerated, safe over decades. We've used it in gout. It is affordable and readily available. So this was subjected to a trial in the Ludoco trial, where the primary outcome.
Dr. Dahl, please summarize.
Yeah, well, so just to complete, there was a Colcott trial. The Daralapidab did not work. The Ludoco trial, again, so observed benefits were the CERT did not work with methotrexate. Low-dose colchicine and canakinumab offer some potential hope. So just to conclude, CANTOS is proving that canakinumab may be a game changer, provided the costs can be brought down. Low-dose methotrexate does not work. Colchicine, with its unique anti-inflammatory action, may be practical, cheap, and easily available, and maybe it'll be part of our guidelines soon. This is promising activity. We need to work harder. Thank you very much.
Thank you very much, Dr. Dhal. Very difficult and important topic, I think, which you covered it very nicely and made us understand. So we hope for this particular therapy in atherosclerosis, which may possibly give us benefit as statin did. So I think questions we're going to skip. We are already 45 minutes late. We're going to go to the last talk, which is by Dr. Iser, drug treatment in pulmonary arterial hypertension. Thank you, Dr. Dhal.
Yeah, good evening, Dr. Mohan. Good evening, chairpersons.
Yeah. So you can share the screen from the center bottom.
Dr. Iser.
Dr. Iser has to unmute. He is mute.
Dr. Isa sir not responding, sir.
He is mute.
I think he's trying to rejoin. Just give us a second.
He's trying to put on the slides actually to get this. I think that he might be trying.
Hello, am I audible, Dr. Mohan?
Yeah.
So I tried to
please show your slide.
I'm trying to share a screen.
So it's at the center bottom.
Yeah, I'm doing that. I'm doing that only. Are my slides visible? No.
Not yet.
Not yet.
Not yet.
Okay. Just please.
Yeah, Dr. Sir, now it's visible.
Is it visible now? So,
Yeah.
yeah, okay. Now I'll quickly start.
Sir,
Try
not
to
visible, sir. Sir, not visible, sir.
Only the desktop is visible.
Slides are not visible?
No.
Okay, I don't know.
Just hit it on the.
Sir, you need to click on the slide.
On the slide, yeah.
Slideshow.
Yeah.
The screen is visible, but unfortunately, slides are not.
Is it visible now? No.
Not yet, sir.
I don't know. I can see the slides. I'm seeing the slides. Okay.
Sir, are your slides on full screen or?
It is full screen. I'm able to see it full screen, but
See there on the right side you have share. Once
doing
you
that,
share, then I think everyone would see.
I'm doing that only.
Now
Is
you
it
hit.
visible now?
No,
No.
not yet.
Actually, when you click the screen share, there will be multiple options. So you have to choose where you have opened the PPX.
Okay.
One thing is you might close the PPT and then reopen it again. Stop
Okay,
sharing, close your PPT and reopen again.
I'm doing that. I'll do that. So now I'm seeing application window, entire screen, Chrome tab. This is what I'm seeing.
Go to application window.
Okay. Application window.
There you will see your PowerPoint.
But I'm not able to see my slides on application window.
Have you opened your slides again? It should be open before you start sharing.
It was open actually before that.
Open again.
No, open it again.
Now is it visible? No.
You have to start sharing. I don't think you have start sharing. Yeah, now something is visible, but again, you've gone to the different slide.
Now is it visible?
No, sir. No, sir.
It is showing.
Sir, please share your PPT, my email.
Yeah.
I run my site, sir.
Since meanwhile, until you fix up the issue, can we move to?
Yeah, you can. Maybe go to next.
We have next session on.
Now it has come.
Now it has come.
It has again gone back.
It was there again. It is gone.
Okay. Is it now visible?
Yeah. Now it is.
Yeah,
visible.
now it's visible.
So I'll quickly do it. So is it visible now? And I'm
Yeah,
audible.
Yeah, it's visible.
The topic is drug therapy in pulmonary artery hypertension. How to initiate. So these are the causes of pulmonary hypertension: pre-capillary, post-capillary, veno-occlusive pulmonary causes. Pulmonary artery hypertension is pre-capillary. Pre-capillary it is in the group 1 pre-capillary is the pulmonary artery hypertension. So diagnosis of pulmonary artery hypertension is mean PA pressure is more than 25 millimeter, LA wedge pressure is less than 15, and resistance is more than 3 Wood's unit. This is the complete definition of pulmonary artery hypertension group 1. So causes are idiopathic, sporadic, genetic cases, or unknown or heritable cases. Then connective tissue disorders, HIV, infection, portal hypertension. Among the drugs, it is important that what we find that oral contraceptive and estrogen and smoking is unlikely cause of group 1 PAH. Now, goal of therapy for pulmonary artery hypertension treatment are to alleviate symptom, improve exercise capacity, improve cardiopulmonary hemodynamics, and to prevent right heart failure, and delay time to clinical worsening, reduce morbidity and mortality. So these are the objective goals to improve 6-minute walk distance to 380 to 440, and cardiopulmonary exercise testing. Goal is to peak VO2 should be more than 15 ml per minute per kg, functional class 1 or 2. BNP should be normal, echo should be near normal RV size and function. Hemodynamically, RA pressure should be less than 8, and cardiac index should be more than 2.5. These are the treatment goals of pulmonary artery hypertension treatment. So in the last, until 20 years ago, there were no effective treatment because pathogenesis was not known. So deeper understanding of pathogenesis and good clinical trials targeting different pathogenic pathways had led to effective development of treatment of pulmonary artery hypertension, and some good drugs are available now for PAH treatment. So how to assess the risk assessment? This is 1 year estimated mortality risk. Low risk is less than 5%, intermediate is 5 to 10%, and high risk is more than 10%. So we see clinical signs and symptoms, progression of symptoms, syncope, whether it is occasional syncope or repeated or no. This classifies into low, intermediate, and high risk. WHO functional class 1 and 2 is low risk, 3 is intermediate risk, and 4 is high risk. Similarly, 6-minute walk distance, cardiopulmonary exercise testing, BNP level and anti-pro BNP level less than 300, between 300 and 1400, and above 1400. And imaging echocardiography, RA area, and no pericardial effusion. If RA area is 18 to 26, it is intermediate. RA area more than 26 is high risk. And hemodynamics depend upon RA pressure, cardiac index, and systemic venous oxygen saturation. On these 3 parameters, it can be classified into low, moderate, and low, intermediate, and high risk PH patients with mortality less than 5% and between 5 to 10 and more than 10%. So after risk assessment, we have to initiate the medical therapy. We can there are options to initiate monotherapy and to sequentially add new drug, or to upfrontly add combination therapy. And if one drug is added, it is not effective, consider for switching of the therapies. These are the various options after risk assessment. Depending upon risk score, type of hypertension, we are not discussing secondary hypertension. I'm discussing only pulmonary artery hypertension, group 1. So these are the various pathways, target pathways for PAH treatment: nitric oxide pathway, endothelin pathway, and prostacyclin pathway. So these are the effective drugs in these 3 pathways: sildenafil and tadalafil and rosuvastatin in nitric acid pathway. Endothelin pathway is ambrisentan, bosentan, and macitentan. And prostacyclin pathway, IV epoprostenol and other prostacyclin analogs, inhaled and subcutaneous, and also IV. So these are the treatment modalities which can be done in PAH treatment depending upon risk scoring, functional class, presentation of the patient, and duration of pulmonary artery hypertension. So there is some evidence to start double or triple sequential therapy or combination therapy. These are various trials of double and triple therapy and upfront combination therapy. Serafin is a landmark trial with macitentan. So among all these drugs, macitentan, rosuvastatin, and prostacyclin, these 3 drugs have shown improvement in mortality and clinical endpoints. Is hard clinical endpoints improvement. Other trials are mostly based on 6-minute walk test and functional class and quality of life improvement only. So this is according to European Heart Journal guidelines, ESC, ERS guidelines. PAH is confirmed first pH is confirmed, then we have to do the vasoreactive testing. Vasoreactive testing is done with inhaled nitric oxide or prostacyclin or adenosine. So if less than 10%, 20%, 10 to 20% adults and around 30 to 40% children have positive vasoreactive test. In these patients, we can start calcium channel blocker therapy because this is a reactive pH and it is reversible with calcium channel blocker therapy for some time. Of course, it is not permanent treatment. It again goes into the irreversible phase. So once if it is vasoreactive test is negative, then options are initial monotherapy, initial combination therapy, or initial combination therapy including prostacyclin. In low group, initial monotherapy is preferred. In moderate intermediate group, 2 drugs can be upfront started, and in high risk class 4 patients, prostacyclin inhaled or in IV or inhaled therapy along with oral therapy will be required. If it is inadequate response, then consider for lung transplant, and double or triple sequential therapy can be added or modified or changed. And so this is further chart showing the same thing. This drugs marked in yellow show improvement in mortality, macitentan and epoprostenol as shown. So general measures are supportive measures, supportive oxygen therapy, digoxin, diuretics, oral anticoagulants are two-way indication in almost all the patients, and supportive exercise testing, physiotherapy, avoid pregnancy, influenza and pneumococcal vaccine. These are the general supportive measures for all patients. And if it is non-vasoreactive, then to initiate with PAH approved drugs. So class 1 recommendation for oral therapy is in functional class 2, functional class 3 and 4 require polytherapy or IV epoprostenol along with oral therapy. And if there is inadequate response, then again go to for cardiac transplant. There are some other therapies, balloon atrial septostomy, some other fancy and experimental therapy, balloon fenestrated atrial device, and pulmonary artery counterpulsation balloon or pulmonary artery denervation. These are experimental therapies. So this is for drug monotherapy. Monotherapy, ambrisentan, bosentan, and macitentan are class 1 indication for functional class 2 and 3. Similarly, tadalafil and sildenafil are also class 1 indicated for functional class 2 and functional class 4 require prostacyclin analog. Epoprostenol is class 1A for functional class 4. Rest oral therapies are to be added with IV or inhalation prostacyclin analogs for benefit in class 4. So group 1 PAH, this is again ambrisentan, bosentan and citaxetan are class 1 for functional class 2 and 3, and prostacyclins are class 1 for functional class 4, and class 3 both drugs can be used in functional class 3 patients. This is a recommendation for initial drug combination therapy. Drug combination, ambrisentan and tadalafil, these are studied therapies, and other ERA or prosta PD5 inhibitors can be added in place of ambrisentan or tadalafil. It is two-way indication. And bosentan and sildenafil is also class 2A for class 4 patients. And similarly, endothelial receptor antagonists, phosphodiesterase 5 inhibitors, and prostacyclin combination can be used in class 4 and class 3 patients. So this is chart regarding a recommendation for efficacy of sequential drug therapy. So macitentan can be added to sildenafil, riociguat can be added to bosentan. These are class 2 indication for functional class 2 and 3. For functional class 4, prostacyclin plus one of the endothelial receptor antagonist or phosphodiesterase 5 inhibitors can be added. So this is sequential therapy, one after other can be added. This is one other way of treating pulmonary artery hypertension. So recommended stepwise approach to combination therapy is treatment goal. If treatment goals are not met, initial treatment with endothelial receptor antagonist, addition of FDE5 inhibitors, addition of inhaled prostacyclins in class 4 patients, transition from inhaled to IV, and then need for transplantation. So use of ambrisentan plus tadalafil, I'll skip this slide. So there are some limitations of these studies also, that there is a trial of ambrisentan and tadalafil which has not shown improvement in functional class but improvement in other parameters. but we don't know whether this can be substituted, these emrisantan and tadalafil can be substituted for other drugs of the same class, or other drugs of the same class will have same effect as emrisantan and tadalafil. We don't know this. This is the limitation of these combination therapies, that whether this can be substituted for other drugs or not. So randomized controlled trials for morbidity and mortality studied trials are emrisantan plus tadalafil, selexipag, and macitentan, and prostacyclin. These are the drugs which have been approved for mortality reduction. So this is the algorithm for drug treatment selection: acute vasoreactive testing with adenosine, epoprostenol, or nitric oxide. If it is pulmonary, marked reduction in pulmonary artery pressure, then trial of calcium channel blocker is given. If there is response, it is continued. If there is no response, or there is this vasoreactive testing is negative, then to start with pulmonary artery specific therapy, pulmonary artery pH specific therapy for functional class 2 and 3, bosentan, sildenafil, or iloprost; for class 3 and 4, epoprostenol and treprostinil. If there is no response, then multiple drugs combinations can be added, and then final, if there is no response, then we have to go for lung transplant, single lung or double lung transplant.
Dr. Isa,
thank you very much. Thank you very much.
You're done. Okay. So this was the last speaker in this session. We had this miscellaneous topic which everyone covered wonderfully, and these were all difficult topics. So thanks to all the speakers. And now, since we are almost 50 minutes late, we're going to move to the next session.
Dr. Amitabh, can we have your presentation, if you can?
Yeah, sure.
Seriously.
Amitabh, hello.
Hello, sir. So, can you all see my slides?
Yes, sir. And we would request you to stick to the timeline. Unfortunately, we are running behind the schedule.
Yeah, I'll try to do that. So, thank you very much, CSI Delhi branch, and especially Mohit, for inviting me for this talk. So, it will be more of a debate. I don't know how well I can debate Dr. Lahari, but let me try. So, renal denervation carrying back to life. So, this is the Dunning-Kruger effect, which is basically a psychological concept which tells us as to whenever a new information or new knowledge is acquired by a person or a society, initially when you know little or nothing, you have a lot of confidence, and then when you gradually come to know about it, you lead into a valley of despair. So this is what actually is happening with renal denervation. So there was good experimental studies, then there were some proof of concept studies, and then Simplicity 1 and Simplicity 2 really rose our expectations with double-digit, in fact, in 20s and 30s decrease in systolic and diastolic blood pressure. So it was considered as the panacea for all hypertensive patients. But then when we ultimately had the results of Simplicity 3 trial, it was a dampener, and it led us to the valley of despair. And as you all know, it was the first sham-controlled randomized trial, and it was found that there was no difference in the office systolic blood pressure or ambulatory 24 hours blood pressure in denervation or STEM studies. However, one thing to remember, there was a significant decrease in the blood pressure after denervation, but there was almost a similar level of decrease in blood pressure in the sham trial also. So there was this problem with this trial. At the same time, when this trial was published, there was another trial, which was the DINER HTN trial. And it did show that it was another randomized controlled trial when a patient was randomized to renal denervation versus standard stepped care antihypertensive treatment. It was a small trial. However, it did show that even in a randomized controlled trial, renal denervation caused a larger decrease in blood pressure when compared to standardized stepwise antihypertensive treatment. So these were the two trials. So the first trial, primary safety endpoints were met, but primary efficacy endpoints were not met. And in the second trial, primary efficacy endpoints were met. So we were at a crossroad, whether simplicity hypertension 3 was the death nail of renal denervation, or there was some hope. So when analysis of the simplicity 3 trial was done, there were certain confounding factors that were identified, which were medication, study population, and procedure related. So in the medication part, we found that almost 40% of patients had change in their medication between baseline and 6 months. So what it did was it added a lot of noise to the data, and with this, any signal that of benefit of renal denervation was probably lost in the noise that was created because of these sudden and significant changes in the treatment protocol, medical treatment protocols. Another challenge of hypertension 3 trial was that there was a lot of patients with African American origin, and it was found that when you analyze them, these patients did not behave very well with renal denervation. And although they had a very significant decrease in their blood pressure, even in the sham arm. So whether these patients were actually resistant hypertension, or whether this was only because of the fact that they were not compliant to drugs. So when you have a control population which is showing a 17 to 21 millimeter decrease in blood pressure, then obviously any other treatment arm would not have a chance of showing any effect. Then there were some procedure related problems. So there was this, when you see the number of ablations that were done, and it was found that people who had larger number of ablations, the change in blood pressure, they had much more higher outcomes. However, when it was found that majority of patients had less than 9 ablations. So this was a new technique which was not really available to the US physicians, and probably this new technique, there was a little bit of a learning curve. And then another thing is, it is recommended that there should be 4-quadrant ablation in both the renal arteries. And if you analyze the hypertension 3 data, you will find that majority of these patients, in fact, almost 90% of patients had no 4-quadrant ablations, and only 19 patients, not even percent, only 19 patients had the recommended 2 4-quadrant ablations on both sides. So again, when you have good ablation, then the change in systolic blood pressure was significant. So to address these problems, after the Simplicity 3 trial, the company and the industry thought of redefining or reanalyzing or replanning their study. And they devised a multi-electrode catheter, which is the spiral catheter. It has 4 electrodes. 60 seconds simultaneous energy is delivered. And it is, since it's a spiral, it can be used even in smaller branch vessels. And it is now recommended that these branch vessels should also be addressed. The idea is that the nerves are much closer to the lumen as we go distal into the renal arteries. And so energy delivery and ablation of the nerves would be better if we do an energy delivery in the distal vessels. So it's a flexible catheter which allows for much better delivery, and it is a spiral thing. So you get a circumferential 4-quadrant ablation with simultaneous delivery of energy. Another technology that has been used is ultrasound-based technology, where it is causes ultrasonic heating, but it is an elegant design where you have a balloon which is cooled from inside. So you do not get endothelial damage, but you get heating of the adventitia where the renal nerves are. So again, this is the Paradise thermal catheter, and this was also used. So using these new catheters, there was these trials, which first one was the spiral hypertension of medicine trial. So this was an intuitive design in the sense that they keep these patients who are either drug naive or they had been discontinued on antihypertensive medications, so that the confounding factor of change in medication does not occur. And they were randomized to sham control, which was renal angiography or renal denervation. And at 3 months outcome, there was a significant decrease in the systolic and diastolic office blood pressure, as well as the systolic and diastolic ambulatory blood pressure. Similarly, the Radiance hypertension solo trial, it used the ultrasound catheter, and similarly, these patients are also not on any medication at the time of the trial, and again randomized into renal angiography or ultrasound denervation, and you found that there was a significant decrease in the blood pressure, systolic as well as diastolic blood pressure. Daytime ambulatory blood pressure was measured in this. Then another trial, which was the spiral hypertension on med trial. In this, the patients were included who are taking 1 to 3 antihypertensive drugs for at least six weeks before enrollment. And so these were drug on trials. However, the additional thing that was done was a drug adherence testing was done, where urinary metabolites of hypertensive drugs were measured. So this ensured that there was no additional drug or anything that was out of protocol that the patient was taking. And these patients were again randomized, and you can find that there was a significant decrease in the systolic and the diastolic blood pressure at 3 months, at 6 months interval. So after that, the spiral hypertension of medicine pivotal trial has been reported, and it was a primary endpoint was 24-hour systolic blood pressure at 3 months, and secondary endpoint was office systolic blood pressure. Safety profile was also measured, and it was a Bayesian adaptive study design, which is again a very good design, which is now adopted by many trials. So basically, from the pilot trial, they analyzed and they made it into a pivotal trial where they planned to enroll 353 patients, and the primary data set was maximum 433 patients. They did a Bayesian analysis, which was planned at after 210 patient enrollment, 240 patient and 300 patient enrollment, and if there was more than 97.5% probability of superiority, then stopping it could be stopped. And actually, this trial was stopped because this criteria was met. In fact, there was 99.9% probability of superiority of renal denervation. And
Dr. Amitabh, can
this
you
was
sum up the slides?
Yeah,
you'll get 2 more minutes after that, sir. You can take
okay.
So
there was a significant decrease in this trial. It was effective in overall control of blood pressure all along daytime. More importantly, there was absolutely no risk involved. There was only one admission due to hypertensive emergency crisis, and there was absolutely no side effects of renal denervation. So 4 trials that have been completed, 3 trials are underway, and from this valley of despair, we are now into a slope of enlightenment, entitlement, of plateau of sustainability. Recently, a new meta-analysis has been published, and it has found that out of these 7 trials, it favors renal denervation as when you consider 24 hours of BP monitoring or office blood pressure monitoring. And now it has now come into consensus statements. So Asian consensus statement, Taiwan consensus statement, Italian society consensus statements, they have all now defined that some patients may actually be primarily a target for renal denervation rather than waiting them for being resistant to drugs. So all these criteria have now been shown. Then there are benefits beyond blood pressure control. So there is renal denervation for ventricular arrhythmia. There is recently last week only this paper where renal sympathetic denervation has been found to improve heart failure parameters in patients with preserved ejection fraction. So renal denervation is not a paradise lost, but it is a paradise regained.
Thank you, Dr. Amitabh. Now we can take Dr. Subrat Lahiri, who will be talking against the motion for renal denervation. Dr. Lahiri, sir. We can have 2 minutes again after that for Dr. Amitabh.
Sir, unmute yourself.
Dr. Lahiri, can you unmute? Yes,
Yeah.
sir.
Can you hear me now?
We can hear. We can hear you, sir.
Yeah. Thank you very much. First of all, I would like to thank the organizers for giving me this opportunity to be here. And I thank Dr. Amitabh for wonderful presentation, also showing some caveats of renal denervation, making my job a little easier. So, okay. So I'll be talking against the motion, whether we need some more data regarding renal denervation. But initially the trials, the Simplicity Hypertension 1 and 2 had a robust decrease in the blood pressure, but it was short lasted and excitement was gone. When the sham control was introduced in the Simplicity 3, it was found that it was a failure, and there was no difference in between the RDN and your sham control group. There were severe, many pitfalls of that study. It is highlighted, but later on in the subsequent trials, it was shown that the sample sizes was very small, particularly around 80 or 90, which showed some promise of renal denervation. Now we look at the meta-analysis in the initial trials, which was shown that RDN was not beneficial over your sham control. But the latest meta-analysis, which came in JACC, which had a study of around 6 randomized controlled trials, where we had 3 second-generation randomized trials with a spiral catheter, which showed some benefit, but maybe to the tune of maybe around 3.65 millimeter in between the RDN arm compared to your sham arm. So in second generation trials, particularly the Radiant Solo and the spiral hypertension on and off showed some better benefit, but still it is around 3 to 5 millimeters, though it was significant. So here you can see the second generation trials. I'm sorry. You can see here the Radiant Hypertension Solo, hypertension off, and you can see the overall second generation trial had some marginal benefit. It was significant, maybe around minus 4.85 difference in between the RDN group and your sham group. And this was the ambulatory systolic pressure, and the diastolic pressure was even lower than that. So, there were several fallacies of these trials. If you look at the Radiant Solo and the spiral hypertension on and off trial, most of these trials, they have excluded your end-stage renal disease as advanced hypertension and isolated systolic hypertension. Like Radiant Solo had more of a mild to moderate hypertension, and the difference of daytime blood pressure was around 6.3 millimeters. And greater than 56% of the RDN patient required treatment after 2 months. You must understand that Radiant Solo was taken in patients who were basically treatment naive. So they were not on any medical therapy. So it was basically a proof of concept with the new catheter design. And it was found that still after 2 months, 56% of the RDN patient required treatment. And by 6 months, 1/3 of the patients required antihypertensive medication. And there was no effort to ensure medicine adherence in both the groups. In the sham group, mostly, there was no report of adherence. So in spiral hypertension on trial, the patients were on 3 drugs, and the mean difference in the ambulatory systolic blood pressure was 7 millimeters of mercury. These trials, basically the newer generation trials, they excluded basically very advanced hypertension, patients with target organ damage like end-stage renal disease, where exactly the renal resistant hypertension we talk about. So how over a period of time we have slowly brought down our expectations in device therapy that we must understand. And compared to the initial first generation trial, which was a very rigid control trial, these trials were very small and the sample size was quite small, and the difference in blood pressure reduction was just marginal. How much blood pressure reduction is achieved when RDN is compared to drugs? RDN at best is similar to drugs monotherapy if you use only, at best. In some trials it has shown that it's even less than that. This is a Prague 15 trial early on, and it showed that our renal denervation was not superior to medical therapy in true resistant hypertension. When I say true resistant hypertension, many patients are not on the criteria for multiple drugs along with the diuretic for selection. So if you are stringent controlling this subset of patients, then you will find that there is no real difference. And if spironolactone was added in this trial and tolerated and maintained, it was found that medical therapy was more effective in reducing blood pressure. So you can see here the optimized medical therapy arm and the RDN arm, there was no significant difference. And when complete RDN, when I say that complete RDN means the fourth quadrant was taken, some subset of patients, and they were compared to a spironolactone, which was added to the optimized medical therapy group, still there was no difference. In fact, spironolactone was a little better maybe. And we know that from DENAR hypertension trial, adding RDN was little beneficial to the optimized medical therapy group, but when spironolactone did also better, if not better than RDN, but we must know that the RDN group, we had patients with medical therapy as well. There are several problems of RDN. You know, the biggest problem is how to find out the non-responders. So we know that the sympathetic activity is important in the response of the patient, but finding out who is going to respond is a real problem here. And we know that we have elderly patients, majority of them will have isolated systolic hypertension, and this group of patients, they do not do better. And the data says that probably, that is exactly the reason that over a period of time, these patients were slowly segregated out from selection. So the problem of non-responder, whatever modality of treatment you choose. This is a slide from the radio sounds comparison study, where you either do a radio frequency ablation of the main artery or main artery with branches, or your with an ultrasound device. The response rate, non-responder rate is to the tune of 20 to 30%. And over a period of time, you understand that our expectations have come down to say the response. Initial trials had shown that for a response, it should be more than 10 millimeter blood pressure decline. But the newer trials are showing that it should be less than 5 millimeters. So we are satisfied with whatever we are going to achieve. Now here you can see here that whatever modality of treatment has been taken in the groups, whether it is an RF ablation of the main artery with branches, or ultrasound of the main arteries, we'll find that the patients with isolated systolic hypertension did not do better. And in fact, there was a significant gap in the blood pressure difference. Means that you need some adrenergic activity. We should understand that in patients with isolated systolic hypertension, the pulse wave velocity increases, the pulse pressure increases. So because of arteriosclerotic arteries, so adrenergic drive probably is not important in the pathophysiology of hypertension, and that probably is the reason that this group of patients, they don't benefit. The second problem here is that, like, you do an angioplasty and you see a gratifying result, and you feel that, I mean, your work is done and there is an endpoint to it. But you do an RDN and you do not know immediately whether the patient has responded or not. Clinical trial is fine, but what about patients who are, in the real world scenario? Here you can see here the initial trial, the reduced hypertension reinforced. They could not show a significant difference at 8 weeks in between the RDN and the sham arm. And these images from the OCT, I mean, the global registry has shown that there is the side effects of renal denervation is less in renal artery stenosis. But some OCT images are showing immediately after the procedure, showing thrombus formations, craters. They are not very pleasant. And we do not know in the long run what is the implication of this. Probably the global registry showed that benefit, but they didn't use any OCT for evaluation. So the question remains, is RDN firmly back in track with emerging data? Patient selection for RDN is very rigorous in studies. What about the real world scenario? Can RDN cure hypertension? How to select responders from non-responders? Is the delayed BP response to RDN at 3-6 months realistic in clinical practice? As the success of RDN is also operator dependent, the scope is also very narrow. We need some pragmatic trials where we should know that does RDN work under usual circumstances rather than ideal conditions? And future trials, we have challenges ahead because the predictors of response, these are the areas we need to see that how it is going to be beneficial. How are we going to assess the long-term durability? We know that there is sprouting of nerves and reinnervation is an issue. So till 3 years in global registry, it did not show that despite reinnervation, there was any clinical decline. in the effect, but we do not know in the long run. And what can this RDN reverse hypertension-mediated organ damage? So far, we do not know. So as far as Dr. Amitabh's view, I believe that it will take some time before this comes into real practice. Thank you very much.
Thank you, Dr. Lahiri. You have appropriately shown that there are still some controversies. Time may or may not come. At present, it's not come up with this renal denervation. We'll give some 1 minute more to Dr. Amitabh if you want to have answers to those questions which you have put on your last slide, sir.
Yeah, just a few comments and a few slides I would share. So this was the Renal Global Registry 3 years outcome. And isolytic systolic hypertension, although initially it was thought that patients do not respond, but when you see the 2 years and 3 years data, they also show a significant decrease of almost 10 millimeters of mercury decrease. Similarly, patients with CKD, they show a significant decrease. So although the trials, basically by definition, a trial should not include so many patients with varied complications, because then it becomes the data becomes difficult. That's why the renal patients, failure patients were not taken. So my question is only 3 questions that I would like to make. Device-based therapy for hypertension, it as was already mentioned by Dr. Lahiri, a monotherapy decreases it by 10 to 12 millimeters, and any second hypertensive agent increases it by 5 millimeters. So when you use monotherapy, it can at least be used as a monotherapy, as mentioned in the spiral hypertension and Redens trial. And as an adjunct, it can cause a further 9 millimeters decrease in blood pressure, as shown by the spiral hypertension trial. So there is still a role of using it as an adjunct.
Thank you, sir.
It has a reasonable safety records, and it has a sizable, we have a sizable patients who are resistant hypertensive. So I believe there is still a chance that whenever the patient has we can lower it without side effects, reasonably safe, effective up to 3 years. And unlike medication, it does not need to be repeated in daily fashion. So in real life, patients who are not very adherent to medications, I think it has a role.
Thank you, Dr.
Dr. 10 seconds, maybe.
Yeah, unless we have definite evidence of cure. So like in the real world scenario, if you give patients an option, the first of all is that, doc, look, we need to continue with the medicine despite we go for this therapy. I mean, how are you going to accept it? And then what is the response? How are you going to judge it so soon? I mean, for a clinical trial is different. 3-4 months, you wait for a trial having an effect. What in real world scenario? You do not have any gratifying result like an angioplasty. So I think that we still need some.
Yeah, definitely. These are definite challenges to the therapy, but as you say, I'm sure both of us agree to the fact that it is something which we have to look forward to, and in near future we'll see definite role of renal denervation in management of hypertension.
Thank you, sir. I think, we can summarize this discussion as it's a new modality. It's a good for a patient who has a resistant hypertension and who are non-compliant to medication. And in future, maybe this may come as a big way. We have one more discussion, very good discussion on PFO closure in a ischemic stroke. We have very learned speaker, Dr. Subhash Chandra. I will invite Dr. Subhash Chandra to speak for the motion. Dr. Subhash Chandra, sir.
If the speakers could, to stick to their time, it would be of immense help. Yeah.
Please, sir.
Thank you.
Thank you, Mr. Chairperson, for that kind invitation. So the second debate is on a PFO closure. Should a PFO be closed after an ischemic stroke? And I'm defending my motion by saying yes. So the PFO existed way back in 15th century when it was defined as a duct which connects the left and right atrium. And that's the culprit responsible for some of these cryptogenic or hidden cause strokes in younger population. The 25% of adults have a PFO that is 1 into 4, and 56% of cryptogenic stroke patients of less than 55 years of age have a PFO. That is the fact. The paradoxical embolism is known to be a mechanism for causing these strokes in PFO patients, and the presence of an atrial septal aneurysm or a large PFO may predict an increased risk of a stroke. And I'll defend it by showing you some data. There's no advantage of warfarin over aspirin, as was shown in some of the previous trials in 2002. Well, the PFO prevalence in cryptogenic stroke compared with healthy controls clearly shows that yes, the presence of PFO in this population is clearly high. And if you compare the cause of PFO versus the conventional stroke causes, then also the cryptogenic stroke in younger population PFO stands out in terms of its prevalence. Well, the attributable factors could be inflated or deflated depending upon these statistical numbers, that how many PFOs are having strokes and how many strokes had coexisting PFO. If we look at the conventional factors of causing a stroke, ranging from atherosclerotic to cardioembolic, cryptogenic is one minuscule entity causing a stroke, and that could happen because of a patent foramen ovale or atrial fibrillation, aortic arch atheromas, or some of the thrombophilias. And now, to define that whether a large PFO really exists in a patient, it could be done by two investigations, which is one transcranial Doppler, in which by various softwares or manual mechanism, you can define the counts. And the microembolic signal counts could be graded as per the ICC or Spencer's scale. Higher the count, higher is the likelihood of causing paradoxical embolism. One very popular score calculator is ROPE score, in which all the conventional absence of the conventional factors causing stroke, like hypertension, diabetes, or a previous TIA, or smoking, if that is there, then they are assigned 1 point. And the presence of cortical infarcts as opposed to the lacunar infarcts, which usually happen in elderly population, also earns 1 point. The younger patients earn much more points than the older patients as far as ROPE score is concerned. So to summarize, a maximum score of 10 would happen in a patient of less than 30 years who has no hypertension, no diabetes, no stroke in past, non-smoker, and a cortical infarct. As opposed to this, a 0 score would happen in a patient who is an elderly with hypertension, diabetes, prior stroke, or is a smoker and has no cortical infarct, but lacunar infarcts. So there's a clear distinction based on ROPE score, that if the ROPE score is in excess of 5, then it goes in favor of a cryptogenic stroke caused by a PFO. And that is pretty evident from this slide, that any score of ROPE more than 5 would establish a correlation between the large PFO and the cryptogenic stroke. Now, there's a watershed moment of 2016, before which the trials, randomized trials, Closure 1, Respect, and PC trial would earn a class 2 indication for closing PFO. However, post 2017, the follow-up data of Respect trial and Close and Reduce trial, where the follow-up has been in excess of 6 years and 5 years, and the modalities like Amplazar or Gore devices were used, it is clearly shown that those PFOs which are large or have atrial septal aneurysms are the ones which are responsible for causing paradoxical embolism and cryptogenic stroke in these trials. Let's have a look at the Respect trial, which is a very important landmark trial. And 2016, it earned class 1 indication from ACC for PFO closure in cryptogenic strokes. And devices like Amplazar and Gore have been approved for use in the United States of America. So in 2016 final analysis of intention to treat, it is clearly shown that 45% relative risk reduction for any recurrent ischemic stroke by closing large PFO with atrial septal aneurysm, and 62% relative risk reduction for reducing a stroke of undetermined cause with very high p values. And those patients in the trial who were for PFO closure group but could not have a device for some reason were the ones which proved this point clearly, that the large PFO with a history of stroke in past for secondary prevention of recurrent stroke cannot be left alone, and they should be fixed by the device. These, after the extended follow-up of Respect, the Reduce and Close trials, in which there was a clear evidence of large shunt and atrial septal aneurysm, and the absence of any conventional risk factor for stroke, have clearly shown that yes, a PFO which is large enough with septal aneurysm should be closed for causing cryptogenic strokes in future. And this is the huge data of 6 years follow-up of 1,000 patients across 70 centers, which has clearly shown that one needs to close these PFOs as a secondary prevention against a stroke. And these was the composite of primary endpoints were non-fatal and fatal strokes, and the stroke within 45 days were the points. If we look at the baseline characteristics of patients recruited in slide, we see that patients were largely young, of the age of 45, males were in excess, and the time to index a stroke was less than 6 months, as evident here. The absence of previous TIA stroke was just in about 10% population. Presence of migraine was there in 40% population, and the DVT and birth control pills taken were just about 4 to 8% patient. There was a presence of large right to left atrial shunt on transesophageal echo-valsalva maneuver in almost 50% of this population, and there was presence of atrial septal aneurysm in almost 35% population. And these are the two major indications for the PFO being closed in cryptogenic stroke. This is a large data, and it is clearly shown compared to the medical management arm, where they were free to use antiplatelets or even anticoagulants. The Ambulatory PFO included group were clearly scoring higher in terms of prevention of future recurrent strokes. So did the characteristics of PFO impact on benefit of PFO closure in the SPECT trial? Yes. The atrial septal aneurysm excess of 10 millimeter excursion and large shunts of more than 20 to 30 microbubbles within 3 cardiac sites appearing in the left atrium were the criteria to recruit patients for PFO closure. And the event-free probability was clearly superior in those groups who received the device. And this transformed to the 10-year expected frequency of recurrent stroke, where extrapolated from these data would reduce from 12.9% to 2.94% from PFO closure, with a calculated number needed to treat of only 10 patients to prevent 1 stroke. There is an apprehension about the complications or the appearance of fresh paroxysmal AF in these patients. Well, that too has been busted by some of the analysis of this data. And we know the technical success today is close to 99.1%, procedural success is 96%, the complete closure happens in 71%, and effective closure happens in close to 94% after device closure. The adverse events were no different between the PFO closure arm and the medical arm. The appearance of fresh AF, which occurs usually during the procedure, were non-significantly high in the closure arm, and the major bleeding and death was also not significantly different. And of note, DVT and pulmonary embolism perhaps were slightly high in the PFO closure group, and that comes from the fact that the medical arm group was receiving anticoagulants.
Dr. Subhas, I will request to summarize. We will come back to you after
finishing it, sir. And to add to this, there are several other trials which prove that yes, reduced trial, closed trial, and defense PFO trial have consistently shown that closing a large PFO with atrial septal aneurysm is the way to prevent secondary strokes in this population of cryptogenic strokes. So today the question is, instead of arguing endlessly about whether we should close it or not, we should argue that which is the patient who should be receiving PFO closure. And today the definition of cryptogenic stroke is being modified to PFO associated stroke, because it is very well established that selected patients with large PFOs should be receiving this device. And it has been incorporated in the newer guidelines. As you see in 2020 practice advisory update of the previous guidelines have happened here. So to summarize, this is the summary that cryptogenic stroke with PFO, younger patients, large shunt, atrial septal aneurysm, yes, PFO closure. Younger patient, small to moderate shunt, ROPE score of more than 5, yes, PFO closure. Younger patient, small to moderate shunt, less than 5 ROPE score, may consider, but any elderly patient more than 60 should be kept on medical therapy. Thank you so much.
Sir, I think it was very clear slides, very beautiful slides, and it was very clear that after 2017, some studies has clearly shown that PFO closure may help in recurrent strokes, especially in cryptogenic. But we have one more speaker from who will be talking against the motion, and is Dr. Neeraj Awasthi, and I will request him to just start his presentation without wasting any time.
Thank you.
Thank you, sir. I would like to thank the organizers for giving the opportunity to interact Is my slide visible?
Yes, yes.
Slide now, desktop is visible. You should have to run the PowerPoint. Yeah, it's up. Let's see.
And I would come straight to the point. We are running short of time, and I would start that my motion is
against the PFO.
To speak against a PFO closure. I'm sitting in a cath lab dress, and so is Dr. Subhash Chandra. So it's evident that we both are proponents of cath labs. But yes, PFO is normal present communication between right and left atrium, and 25% of the population has a PFO.
I will request Dr. Neeraj to stop the video and just keep your mic on, because your, I think, voice is breaking. Maybe some problem with wavelength. Wi-Fi connection.
Neeraj, is it okay?
Neeraj, can you stop your
stroke, as you all know?
Dr. Neeraj, can you stop your video and just run the slides and
I will
with the speaker?
Switch my video. I think that will help.
That will help in a Wi-Fi connection. Yeah.
Okay. So PFO is usually asymptomatic. Is typically found incidentally or on evaluation of a cryptogenic stroke. And my disclaimer, as I said, is I am not a neurologist. I am still a proponent where I was always thinking that PFO device closure should help, as Dr. Subhash Chandra has put it up nicely. He has made my job easy because he has put most of the points. We still do not know, I've taken it from Frontiers in Neurology, that we still do not know how PFO sends emboli to the brain. Paradoxical emboli from large veins in ischemic strokes are present in just 11% by pelvis study. Cryptogenic stroke or TIA with PFO are found to have 10-fold presence in pelvic DVTs, but this is the incidence increases to from 2%. Patients with proven DVT around the stroke may require a lifelong anticoagulation instead of PFO closures. So are we going to benefit in these group of patients who are anyway going to be on anticoagulants? Most of these patients would be having a DVT which may not get picked up by a routine ultrasound, as evident by pelvic study. And in 4% of the patients in PFO group, there will be almost 25% of the venous thromboembolic events occur during the trial. So in the RESPECT trial also, 25% of the venous thromboembolic event occurred in just 4% of the group. So they required anticoagulation anyway. If these patients require anticoagulation anyway, are they going to really benefit? Are we trying to close a communication to treat an abnormality? I mean, is it really justified of closed communication, or we are going to open up this hole which has already got called a PFO to justify our closing of a patent foramen ovale because of stroke? Is there a level of evidence? My job is easier because Dr. Subhash Chandra put it up nicely. And this is something which was published in June 2020. And it is in Frontiers in Neurology, and they concluded that cost effectiveness of the procedure cannot be proven for the time being, since there is no robust data on clinical outcome after PFO associated stroke. Let's look at the evidence, what they are quoting. These are the trials which are available. The initial trials, as Subhash sir has put, Closure 1, PC, RESPECT, they were all negative. And subsequent trials which showed some positivity. So let's talk of trials which talk of level against a PFO device closures. Closure 1 trial talked of closure not superior to PC trial, there were a lot of crossovers, and a RESPECT trial which showed that 10 of the patients of PFO had recurrent stroke even after closure of the PFO. Now, let me talk of level of evidence which is in favor. Say a Clone trial. Excellent trial which talked of points in favor. But the closure is superior to antiplatelet therapy in the presence of a septal aneurysm or a large shunt. So not all PFOs would really benefit. It clearly showed that there is a subgroup of PFO which might benefit with the closure of a PFO in selective group of patients. Let's talk of reduced trial. Reduced trial, which was again favor, it talks of a PFO presence was requisite for inclusion in atrial septal aneurysm and was not systemically screened before randomization. Patient with small shunt size, there was no significant trend to stroke reduction. Also, the incidence of atrial fibrillation or flutter occurred significantly more in the group where PFO was closed. So I have taken the points which were actually against a PFO in the trial which favored a PFO closure. Clearly, a small shunt was not significant, and there was an incidence of atrial fibrillation even after a PFO closure. That will itself predispose to a stroke. Talking of a defense PFO, again, a trial which favored a PFO device closure. It was a RCT done in 2018 with a PFO, Ambulatory PFO, and they compared with the medical therapy. 120 patients subject for 2.8 years. And they included a high-risk PFO groups, which included atrial septal aneurysm, hypermobile septum, or an increased PFO size with significant shunt. Definitely, there was a decrease in ischemic stroke after PFO closures. And number to treat a patient of stroke was 10 patients. Of the 10 patients, if you put a PFO, you are going to probably treat one stroke. So if I have to analyze all the data which are available to us, there are 37 patients, 37 of 1,889 patients who were randomized to PFO closure, and 79 patients in all the studies combined, of that means of 1,671 patients who were on antithrombotic therapy. New AF after a PFO closure was seen in 93 patients. This is again a significant group which predisposes to stroke, the presence of new AF. The procedural complications were seen in 2.4 patients, although I agree, all these patients were less than 60 years of age and they had no comorbidities. Once there is a comorbidity, obviously PFO closure would not help. And both of us agree, because this is what Dr. Subhash Chandra also agree, put it in the last slide. So my third question is, by doing a PFO closure, are we predisposing to stroke in an attempt to do a procedure? Look at these devices, which large surface areas. They have a time for endothelization. They have their own respective time where they will endothelize. And in those periods, there is always a risk that a clot may form over them. Of all the data which we have seen, there has been an incidence of chest pain, residual shunt, thrombus formation, effusion, perforations, even stroke after PFO closures, endocarditis. So is it an elephant we are just trying to push in by closing a PFO device? And this is all the list of positive RCTs. Positive RCTs means those who have shown points in favor of a PFO device closures, the gore, the respect, the close, and the defense. And these are all the side effects which we see, which include cardiac tamponades, discomforts, complications of the device, hemiparesis, incision site hematomas, pseudoaneurysms, pulmonary embolisms, infective endocarditis, pericardial effusions, vasovagal reactions to, if we talk of milder things. So all these side effects give us a perspective. I mean, are we really justified? So I would like to say that perspective is important. I've taken this slide from Dr. Subhash Chandra. As of now, instead of arguing endlessly whether we should close a PFO, we should move on to decide whether what PFO should be closed. Only a fraction benefit from PFO closure, but require an extensive diagnostic workup to rule out atherosclerotic stroke, to rule out AF-related stroke, to rule out small vessel disease, and a risk of embolism score, that is ROPE score, which beautifully Dr. Subhash put it, with the absence of history of hypertension, diabetes, or TIAs, and age being most important, especially 0 points for those who are above 70 years of age. So till 60 years, most of the trials are till 60 years of age. Echo characteristics of PFOs in the form of long tunnels, atrial septal aneurysms, thick septums, multiple orifices, or eustachian valves clearly point towards the presence of stroke. So in the end, I totally concede with what Dr. Subhash has said, that yes, PFO device closure should be reserved, but for selective group of patients which have got a high selective ROPE score, where echo is very characteristic in the form of enhanced reasons for a PFO closure, the prior venous thromboembolism, multiple infarcts, large CFOs, large atrial septal aneurysm, eustachian valve works, or who have got a significant shunt, more than 20 bubbles going right to left. So the heart will prevail over the brain only once we think wisely. Thank you.
Thank you, sir. I think after discussion, we know that it should be individualized, and PFO closure should be done in those subgroup of patients which both the speakers have clearly said. And I won't go for a rebuttal because organizers have clearly said that no more discussion because we are short of time. I will hand over the stage to again back to the organizers. Thank you, sir. Thank you, Dr. Mohit. Thank you, CSI.
Thank you so much. Thank you, Dr. Ghanshyam.
Thank you. Thank you, Dr. Subhas, Dr. Avasthi. Thank you.
I would request Dr. Sanjay Gupta to start the next sessions.
Yeah, good evening, friends. And thanks to CSI to give me this opportunity to talk this evening. And special thanks to Dr. Mohit Gupta for giving this invitation. We have a very, very important session regarding heart failure. And this is one of the upcoming, not only in the clinical cardiology, but also it's something which is very exciting for all the other parallel specialties, including diabetologies and endocrinologies. And this is the forum where a lot of interactive episodes are going on between the various consultancies and various specialities. We have as the first speaker, Dr. Seth, and he has to speak on, and we are already running extremely short of time. So I would request the speakers to please limit their talk to the requested amount of time. We have a session on the heart failure with preserved ejection fraction, which is something which is sort of an enigma. And we really are not sure how the various modalities of treatment will come out and how will we really treat these patients. So over to Dr. Sandeep Seth to please talk about this. Thank you.
Thank you, sir. So this is a patient which all of us see. This is an elderly lady with shortness of breath. She is obese, blood pressure of 170/90, has atrial fibrillation. Echo looks pretty normal. Ejection fraction of 65%. The ventricular cavity is normal. The wall thickness is normal. This is a chest X-ray. The lungs are full of fluid. And if you look at this clinical data, the systolic function is pretty normal. It's only when you look at the rest of the data that you get a real clue. So it's the Doppler which gives you the first clue. The E/E dash ratio is abnormal. It's 22. The left atrium is large. And when you look at the biomarkers, the NT-proBNP is elevated. So this is the typical picture of what I'm going to talk about today, heart failure with preserved ejection fraction. A large group of patients that we see nowadays have shortness of breath. Their standard echo, the echo as is done in a hurry, is usually normal. That means systolic function is normal, but they're coming with shortness of breath. Many of them are obese. They have some renal failure sometimes. They have diabetes. Some of them have atrial fibrillation, but all of them have shortness of breath. And so only when you look at the left atrium or you do a BNP, you find that there's something actually abnormal. You can't ignore them. Now, what is the burden of heart failure with preserved ejection fraction in India? This is the burden of heart failure overall in India, about 5 to 10 million patients. So if you look at preserved ejection fraction at the various registries, Inter-CHF and Trivandrum registry, about 17 to 25%. In our own registry from AIMS, when we looked at the villages in Vallabhgarh and 6 villages, almost 2/3 of these patients actually had heart failure with preserved ejection fraction. So it's not a small number. Depends on where you look at the patients. There are lots of causes, but if you look at the stars, the elderly patients, patients with chronic obstructive airway disease, patients with renal failure, diabetes, obesity, sleep apnea, post-radiotherapy. After you have treated aortic stenosis, the LVH is still persisting. Some of the storage disorders, hypertrophic cardiomyopathy, these are all conditions where you will actually have heart failure with preserved ejection fraction. So it's a pretty large number of patients. Diagnosis actually now is pretty simple. You have to have symptoms and signs of heart failure. And it's essential that the systolic function is normal. That means the ejection fraction is above 50%. Along with that, you have to have objective evidence that there is something wrong. That means you should have some raised natriuretic peptides along with evidence of a structural abnormality with left atrial enlargement, left ventricular hypertrophy, or diastolic dysfunction. This is a very simple way of trying to understand what is heart failure with preserved ejection fraction. The European Society some time ago tried to give more structure to this diagnosis. This is the HFA-PEFF diagnostic algorithm. It looks somewhat complicated if you look at it initially, but if you go into the detail, it's a pretty comprehensive algorithm. The first P actually is the initial workup. So there are symptoms and signs. You look at the various comorbidities which are listed. Look at the ECG, look at the standard echocardiogram, do the biomarkers, and assess the exercise capacity. Then you look at the various biomarkers, look at the echo in detail. I've just summarized them in the beginning. Basically, you're looking at the tissue Doppler. If it's less than, the lateral tissue Doppler of E dash is less than 10, the left atrium is more than 34, E by E dash is more than 15, the estimated PA pressure more than 35, the walls are thick, that means more than 12 millimeters, the NT-proBNP is more than 220, the global longitudinal strain less than 16. So basically, if these parameters are there, you give various points to each of the parameters, then you know that you're probably dealing with a patient with heart failure with preserved ejection fraction. If in spite of this, you're not very sure, but the patient is short of breath and other parameters look pretty normal, then you subject the patient to a stress echocardiogram. If on this, the parameters become abnormal and they fulfill the criteria of heart failure with preserved ejection fraction, you made a diagnosis. If in spite of this, you're still not sure, you can do an invasive study and do a hemodynamic study. And if you on catheterization, you find the left ventricular end-diastolic pressure, the wedge pressure is above 15, or on exercise, the wedge pressure goes above 25, then you can make a diagnosis of HFpEF. So this is in summary, the basic diagnosis. And then you look at the etiological diagnosis, look at what is the cause for all this. And this is how the diagnosis is made. Once the diagnosis is made, you look for the etiology in terms of doing an MRI, doing a biopsy, or looking at various causes. Now, when you made a diagnosis of HFpEF, then what have you achieved? Are you going to treat this patient differently from any other patient with uncontrolled hypertension or diabetes or obesity? But frankly speaking, your initial management of these patients is to reduce the preload. So it will be depending a lot on drugs like diuretics and vasodilators. If the patient is very sick, you would like to start with the drugs like NTG, maybe start with intravenous NTG in even loop diuretics. If the patient is in atrial fibrillation, many of these patients are in atrial fibrillation, then a good heart rate control will also do a lot towards improving these patients. You also like for heart failure with reduced ejection fraction. Similarly, here in HFpEF, you have to look at the triggers. So is the patient non-compliant with drug therapy as a result of which he's developed accelerated hypertension? Was there dietary indiscretion, NSAIDs? Has the patient developed atrial fibrillation? Is there something else like alcohol abuse or infection? So similarly, you look for any cause which is worsened heart failure. You correct that. If the patient is refractory, you go towards therapies like furosemide infusion. You can use metalazone. Sometimes you can even use ultrafiltration. Long-term management, you treat the comorbidities. Many of these patients may have anemia, CKD. You restrict fluids and you try to control the overflow, the patients going into fluid retention. So teach the patients to weigh themselves daily. In patients who are refractory, sodium restriction is also an option. In terms of long-term management, here you do perhaps want a good blood pressure control. So a target of 130 by 80 is a good target. Atrial fibrillation is a topic by itself, so I'll not go into that, but atrial fibrillation heart rate should be well managed. Anticoagulation is also obviously required. Now, if you look at the various trials for heart failure with preserved ejection fraction, if you look at the trials for trials with heart failure with reduced ejection fraction, there are lots of trials. They've all achieved good results. But if you have used the same drugs for heart failure with preserved ejection fraction, they have not really achieved benefit in terms of survival. Now, why is that happening? That has happened mainly because as when I showed you the causes, the causes of heart failure with preserved ejection fraction are diverse. Some patients are obese, some are diabetic, some patients could be post-AVR, some could be patients with hypertrophic cardiomyopathy. So there are very diverse groups. So it's possibly that's the reason why not achieve similar results. In spite of that, there are some drugs which have been found to be beneficial. Drugs like spironolactone have been found to be useful. And also these patients have a lot of comorbidities. So these patients, many of these are diabetic, many of them have renal failure. And sometimes the cause of death in these patients could not be actually related to heart failure. We are still trying to find newer and newer forms of therapy in patients with heart failure, preserved ejection fraction, because as I showed in the beginning, this is a large group of the patients that we are going to see. So just thinking that we don't have forms of therapy will not do. So trying to create an interatrial shunt by using a transcatheter implant is one form of therapy which is being tried. Various forms of drugs are being tried. The ARNI group of drugs have been tried in multiple trials, including the Paragon, though initially the Paragon trial was supposed to be negative, but some recent data suggests that maybe at least in some of the patients with heart failure with preserved ejection fraction, we can still use ARNI to control the symptoms. Various other drugs have been tried, and some of the patients may also benefit from SGLT2 inhibitors. Can you prevent heart failure with preserved ejection fraction? Once you know that you have some causes, you know that hypertension will ultimately cause HFpEF, so hypertension should be controlled, hyperlipidemia, diabetes should all be controlled, obesity should be prevented. Indapamide has been found to reduce the incidence of heart failure with preserved ejection fraction. Chlorthalidone has also been found to be useful both in the treatment and prevention of HFpEF. And as I said, ARNI has also been found to be useful in some subgroups of patients with heart failure preserved ejection fraction. So in summary, I would say that HFpEF is a subgroup of patients which we are seeing more and more, and it's something which cannot be ignored. But yes, if we know the causes, if we know the diagnosis, it is fairly easy to treat. Thank you very much.
Thank you, Dr. Seth, for a very nice presentation of a very complex subject.
I would just like to interrupt. May I request all the speakers to please exactly stick to the time, because unfortunately we are running a little bit late. And I think Anna is not here, so we would invite Dr. Rakesh Gupta sir to give his talk. Dr. Rakesh Gupta?
He's not yet joined, I think.
No, he is there with the Jharap Institute. We can go to the next one till the time he...
No, I'm there. Allow me to share my slides. It's okay. Because I thought somebody is there before me, so I was a little relaxed. Good evening and good afternoon, everybody. Let's talk about a heart failure. When to order an echocardiogram? Well, this is one modality which is widely available, portable, and no radiation, and relatively very low cost. The only hindrance is we need a good window, and which number of time is pretty poor when we have an acute congestive heart failures. Look at this data from European Society of Cardiology guidelines. Transthoracic echo is a method of choice for assessment of myocardial systolic and diastolic function, both of LV as well as RV. And apart from that, it gives you an integrative approach of structural changes, functional parameters, and which were a couple of them were eluded by Dr. Sandeep Seth a few minutes back. We can look at the etiology of heart failure, like mitral stenosis, mitral regurgitations. And if you look at the recommendation by European Heart Journal for heart failure, transthoracic echo is good for myocardial structure and function, ejection fraction assessment, valves, and on top of that, the myocardial functions in subject exposed to treatment like chemotherapy. So it's a class 1 indication with grade of evidence C. On top of that, I said smaller portable machines which can be moved to a bedside situation, though this smaller machine is not available in India because of draconian policy of PCP and DT, but certainly they are useful. And looking at this recommendation, echocardiography is recommended immediately in hemodynamic unstable patients of acute heart failure. Within 48 hours, repeat the same echocardiography studies. And in all patients with suspected cardiogenic shock, immediate ECG and echocardiography is recommended, again, are class 1 indications. Now, when to order an echocardiogram? All of us understand every time we have an ordered echocardiogram. But let me show a couple of advanced modality which makes a lot of difference in those patients who are not ready for intervention and they want to have a follow-ups. So let's look at this myocardium. This work has been there for almost now 10 years or more. We look at a longitudinal stain, we look at a radial stain, we look at a circumferential stain, and we get an average global longitudinal stain which is being utilized in day-to-day practice as on today. Here is example with DCM with a GLS of only 4.2 versus a coronary artery disease with a GLS of 12.9, suggesting a global versus regional myocardial deformation, which can be estimated in people with heart failures. Look at these three examples: normal, apical hypertrophy, and amyloidosis. Look at the gradual reduction. I don't say gradual. They have a different GLS in these people, though their ejection fraction was normal or supernormal as compared to normal subjects. So we look at all these factors when we're looking for a heart failures. Most important thing is monitoring and follow-ups. Let's look at a diagnosis quickly. We look at the ejection fraction, less than 40, more than 50, heart failure with preserved ejection fraction, and a mid-range. Here is an example for a patient of a reduced ejection fractions. And this cardiomyopathy can be, whether ischemic versus non-ischemic, can be devolved or evolved or evaluated by tissue Doppler imaging. And here is a paper. If you have a differential to TDI velocity of S wave, possibly it's ischemic, and if it's generalized reduced, it's possibly a non-ischemic pathology. On top of that, if you are doing a chemotherapy to a patient, you can really detect a subclinical LV dysfunction because these people are breathless. And this is an example of a patient who had a normal S wave of a TDI, which reduced with chemotherapeutic procedure over a period of time. And now the ejection fraction was normal. And similarly, we can look at a GLS, more than 15% of a GLS from a resting phase to after a chemotherapy is considered to be a significant. And not only that, this paper of 2019 categorically suggests if you use prophylactic beta blockers, we help to reduce the effect of these chemotherapeutic agents for a cardiomyopathies. Diagnosis of pulmonary embolism is COVID-19 people. Many times we have used this diagnosis where generalized reduced two-dimensional stain was present in RV, where as in acute pulmonary embolism, it was apical sparing was present. Similarly, we use a subclinical LV dysfunction during COVID-19 period where initially LV function was normal, but GLS is low, and subsequently the GLS improved significantly. A couple of examples from our own center: patient presenting with breathlessness. What modality can give you a immediate diagnosis? Look at us here. Patient has got a paravalvular leak. Second thing, a patient came with a breathlessness with the prosthetic valve, and here is Hancock 3, Hancock 2 have a degenerative strut. Similarly, another prosthetic valve presenting with a mass. And look at this mass, which can be easily picked up by three-dimensional transesophageal echocardiography. Patient presented with left-sided failure. Look at the cleft AML, which can be categorically seen in this patient of a cleft AML. So order an echocardiogram for right-sided failure. Here is a classical ARVC, which the patient was suffering. As far as prognosis is concerned, we can look at a pulmonary artery pressure and can really tell you with these pressures we're going to make a difference for their future or not. Similarly, we look at a prognostic value of tricuspid annulus velocity in heart failure with atrial fibrillation. And if the tricuspid annulus velocity is less than 9 centimeter, they have a poor prognosis versus who have got a good tricuspid velocities. If you move further, right ventricular myocardial systolic dysfunction in heart failure with normal ejection fraction, as my previous speaker was talking about. You look at the GLS, despite the fact their GLS of the right ventricle is low versus GLS of the right ventricle normal, these people, they have a poor prognosis as compared with normal or right ventricular GLS. Role in pregnancy, I'm not going to talk much on this, but most important thing is if we look at the GLS, we can really pick it out which of these people are going to have a subsequent problems or a cumulative mortality and morbidities. LBB, every one of us looked at LBB with ejection fraction. If the GLS is less than more than 12.2 and ejection fraction is less than 40, look at the cumulative event-free survival of these people. Prognostication in ischemic cardiomyopathy. Well, that is where we can look at many people. If the GLS is less than 7 versus more than 7, that gives you a cumulative value of all this. Therapeutics, IV, small IVC versus normal IVC. And this is categorically said in this paper published in JACC 2013, talking of this therapeutic procedure of IVC. Similarly, when we look at the beta blockers and a diuretic ACE inhibitors to look for their diastolic function, that gives you a lot of value to assess. Then assessment of myocardial viabilities. A CRT device, we have to do all this before and after implantation, presence and absence of diastolic MR. And lastly, I'll just say these words. This modality is of significant use when we are doing a multiple intravascular procedures like mitral clip or a tricuspid clip altogether. Thank you very much. I'm sure the time is so small that you cannot cover all the subset of this heart failure in minuscule time.
Can we request Dr. Vivek Chaturvedi to start his presentation? Sir, you need to unmute yourself.
Yeah. So yes, hi. I would like to thank the organizers for asking me to speak on this important topic. I would be speaking about heart rate reduction in heart failure and balancing when to give beta blocker and when to give ivabradine. The slides is stuck.
The slides, sir.
Yeah. Okay. So they have no role in preserved ejection fraction, and I think all of us know that. Just two clinical scenarios. So one is a young female who just had myocarditis and has developed severe LV dysfunction. Her heart ejection fraction is 25%. She's class 3. She started on ramipril, spironolactone, metoprolol, and torsemide. Her heart rate is 92, and her blood pressure in sitting position is 90/60. So what next? Are you going to increase metoprolol or stop it and add ivabradine? The next scenario can be a 65-year-old male who's 80 kgs and who has had a recent anterior MI. His LV is 30%. He's class 2. He's on sacubitril, valsartan, eplerenone, torsemide, ivabradine, 5 mg BD, and other things. His heart rate is 78, and his blood pressure in sitting position is 106/54. So you would rather, increase ivabradine here to 7.5 mg BD or add a beta blocker. So this is one of the largest collaborative beta blocker groups with individual patient-level meta-analysis of more than 80,000 patients. And clearly it shows that the heart rate has almost a linear correlation with a variety of heart failure parameters, including all-cause mortality. This holds true mostly for sinus rhythm. Now, the same collaborative group did this meta-analysis of 18,000 patients, and it is very clear from this slide that the relative risk reduction is impressive, irrespective of the baseline heart rate. So that means that even if you start with a lower heart rate, by adding beta blockers, you're further depressing their mortality and heart failure-related hospitalization. So then why aren't we using beta blockers in everybody? The simple reason is that in a lot of patients, either we fail to reach the target dose, and in many people, we are not able to even start them. And that is because of COPD, the fact that people have low blood pressure to begin with, which is very common in Indians, very common in dilated cardiomyopathy. They can have asthma, they can have bradycardia, Raynaud's, and they can have decompensated status. So all these things lead to either beta blockers being precluded to be started from, or the failure to up titrate their therapy. Just to put a perspective on this, in inter-CHF study, India, 57% patients only were on beta blockers. So here comes the role of ivabradine, and it's a very potent heart rate lowering molecule, whether you are on a beta blocker or not on a beta blocker. So if you were to look at the change in heart rate of ivabradine minus placebo in the SHIFT trial from day 28 to day 0, and so this is the heart reduction achieved, and this is the baseline rate, and this is the beta blocker rate. So obviously the highest reduction happens in people who were not on a beta blocker and who had a very high rate to begin with. But this heart rate reduction is seen in virtually everybody, irrespective of their starting heart rate and whether they were on a beta blocker or no. And this translates into the fact that the variety of endpoints, and you would remember that in SHIFT trial, it was cardiovascular mortality along with heart failure hospitalization, which was significant. On its own, cardiovascular death and all-cause mortality were not significant. However, heart failure-related death and heart failure-related hospitalization were highly significant. But if you were to look at the primary endpoint, it is very clear that irrespective of the beta blocker dose, the benefits of ivabradine were present. If we dissect the SHIFT trial a little bit more, again, we see the potent effect of the outcomes when we look at the placebo component of the baseline heart rate and the outcomes of heart failure. It's very clear that people with very high heart rates have a higher risk of suffering from an event. Now, if you look at the effects of ivabradine, then it is clear that the effects are much more when you have a higher heart rate to begin with. The effects are quite unimpressive if the heart rate was low to begin with. And then if you look at this curve, which is very important, if despite using ivabradine, if your heart rate remains high, then virtually there is no benefit of ivabradine. So the ultimate take home from these 3 slides, which are a little bit complicated, is that ivabradine is a very good heart rate lowering agent. If the heart rate is lowered, then the benefit is there, otherwise it's not there. And then because of this heart rate lowering, there is increase in ejection fraction in this meta-analysis. And in the meta-analysis, if you specifically look at people with higher heart rate, then there are all sorts of different cardiovascular endpoints which become highly significant and robust. Now, as compared to the beta blocker collaborative group, this meta-analysis from McAllister et al. Clearly shows you that the beta blocker impact on vascular and heart failure mortality is dependent on the heart rate. So if you have a higher heart reduction, there is higher impact. With lower heart reduction, there is a lower impact. So it is very clear that beta blockers are very good. However, the effect is somehow to some extent dependent on heart rate, not fully though. And to support this contention, I have presented here this data from a separate trial called Heart Failure Action Trial, which was on exercise, but this is a post hoc analysis. And you would clearly see here that the death risk is, is much lower even in people who have low heart rate and a high beta blocker dose, or high heart rate and high beta blocker dose. Basically, anybody on beta blocker seems to be benefiting despite their heart rate. So the jury is still out there. Some people like to believe that beta blockers are the sole effect of beta blockers is because of the high heart rate. I think overall it is not so. And so that is why the take home messages, as far as I am concerned for this, is that the beta blockers reduce, I'll just take 30 seconds more. The beta blockers reduce mortality irrespective of the heart rate at baseline or follow-up. The exact proportion of their effect due to heart rate lowering is not known. Heart rate lowering also itself reduces events in heart failure with reduced ejection fraction irrespective of beta blocker use. However, this, when achieved by ivabradine, is dependent on baseline and achieved heart rates. Hemodynamic and other factors often preclude achieving a good beta blocker dosage, and ivabradine is an attractive proposition for precisely these many patients. However, at any point of time, these patients, the hemodynamics may improve, so efforts should always be made to initiate or uptitrate beta blockers. Coming back to the scenario, in my opinion, this first case, a lady with DCM, I think because of the borderline blood pressures, and this may cause falls and other problems later, diffuse perfusion, she should probably be added ivabradine to this small dose of beta blocker. The gentleman with CAD, I think the evidence is overwhelming in this case that we should put him on beta blockers besides ivabradine. Thank you so much for your time.
Can we request Dr. Rajiv Pasi to start his presentation?
Dr. Rajiv Pasi.
So can we have Dr. Sethi then presenting his
Dr. Rajiv, are you sharing your slides?
Yeah, I am sharing my slides.
Please do that, sir.
Yeah, sure.
Please do that.
Hello, are the slides visible and am I audible? Should I start?
Yes, please go ahead.
Yeah. Okay, thank you. My sincere thanks to Dr. Mohit, Dr. Balbir and Delhi CSI for giving me this opportunity. It's an unusual topic. It is something which is a little out of the blue. Which is something which is not a part of our clinical practice as such. This is cardiac contractility modulation in treatment of patients with heart failure. What are the benefits? What is the available evidence at the moment? We all know that management of heart failure is now on ARNI, ACE inhibitors, ARBs, beta blockers, MRAs, and SGLT2 inhibitors. This is optimized medical management. The role of ICD and CRTD, when the QRS is more than 130 milliseconds, is established and is a widespread practice both in India and abroad. And we have been putting these devices for almost last 15-20 years. But there is a group of patients who, despite optimal medical management and a QRS less than 120, do not benefit, and the heart failure tends to persist. This is a group which can be offered CCM, that is cardiac contractility modulation. This is through a device which is an implantable pulse generator, which has been used for past few years with variable benefits. In the next few slides, I would like to bring out what are the benefits and what is the evidence which is available to us at the moment. So as I said, CCM is basically a preclinical or prior clinical studies have demonstrated that CCM leads to an increased cardiac contractility. It reduces myocardial work, produces LV reverse modeling, and induces molecular change in genes, in proteins, and in phosphorylation, indicative of improved calcium handling and contractile function. So this is basically a concept in which the electric signal is given in the absolute refractory period of the cardiac cycle, resulting in a modulation of the cardiac contractility, and the benefits can be both in acute phase and in chronic phase of heart failure. They can be observed. As this slide illustrates, that this signal can be applied in the refractory period, in the absolute refractory period, and results in a significantly improved contraction. So this mechanism is dependent on multiple factors. It is time dependent. There is a rapid improvement in some cases to cardiac contractility modulation, which occurs in minutes to hours by local electrotonic spread of signal, leading to rapid formation and improved contractile force. The intermediate or hours to week benefit is because of failure to normal, local effects which improve contraction at the global level. And the benefits is over weeks is due to globular ventricular properties and the reversal of or alteration of remodeling of the heart, which ultimately leads to a benefit in these patients. So this is how the device is. Basically, it is this is the device which was the 3-lead device which was being used previously. The optimizer 3 and a septal lead, the ventricular septal lead.
Rajiv, you need to switch off your video so that you can be heard.
The benefits have been equivocal as far as the various trials have been done. A total of almost 1,500 patients have been done. Hello.
Rajiv, your signal is weak probably.
I think Dr. Pasi is facing some technical issues.
Maybe you can go on to the next talk.
And Dr. Sethi, can you present your slides?
Okay, is it visible and am I audible?
Yes, yes.
Thank you very much. I can see the timer coming up suddenly. Thank you very much to the organizers, and we're running short of time. My take today is to talk on iron deficiency and what's its role in management of heart failure. Now, all of us have experienced in the past that despite appropriate medical therapy, several patients with heart failure and reduced ejection fraction continue to suffer because of continuing symptoms. They have poor quality of life. They run a risk of repeated hospitalizations because of decompensation, and also have an increased risk of mortality. Now, most of it has been attributed to presence of comorbidities. There are several of which have been listed in this 2017 document from ACC-AHA, and you can see that anemia and iron deficiency form a significant component of these comorbidities, which are often present in patients with congestive cardiac failure. It is often not realized that iron deficiency is present in more than half of patients with congestive cardiac failure, irrespective of presence or absence of anemia. There are several causes for iron deficiency in patients with heart failure, mainly GI blood loss, malabsorption, loss of appetite with malnutrition, or the presence of a chronic inflammatory state with hepcidin-mediated malabsorption and pooling of iron in the reticuloendothelial system so that it is not available for utilization by the tissues that need it the most. And that results in all the problems that I alluded to earlier, namely reduced exercise capacity, increased risk of hospitalization, increased risk of death, etc., etc. Now, that also, this slide shows the problems that iron deficiency with or without anemia can cause, and this is data on peak oxygen consumption, normal individual, anemia present without iron deficiency, anemia, no anemia but iron deficiency present, and anemia and iron deficiency both present, and you can see a gradual reduction in peak oxygen consumption as we change these parameters. And similarly, without anemia, the hazard ratio for mortality taken as 1, no iron deficiency but anemia, slight increase, no anemia but iron deficiency, there is a further increase. I can't see this, this is just too large. We need to reduce the size of this screen probably to see the slides in their entirety. And as we have a combination of both anemia and iron deficiency, the risk of mortality becomes the highest. Oral therapy is not so effective, and I would just suffice is to say there that there are several reasons: poorly tolerated, GI absorption impaired, hepcidin issues, and so on. And with intravenous iron, there have been 2 randomized controlled studies, namely FAIR heart failure and confirm heart failure, which are not very large studies, and therefore, you know, the results have been put into a meta-analysis of 4 of these studies, which are all relatively small, that are shown here to get the overall effect. But individually speaking, in the FAIR heart failure study, which was about 500-600 patient study, you would notice that with intravenous iron therapy, there is an improvement with the parameters that were looked at, namely the 6-minute walk test, the patient global assessment, as well as the NYHA functional class. And this was a 24-week follow-up. The confirmed heart failure study was a 52-week follow-up, again approximately 800 patients only, and that showed improvement in 6-minute walk test at week 24 and 52. And also patient self-reported global assessment score, as well as New York Heart Association functional class. The impact of intravenous ferric carboxymaltose has also been seen on renal function, as we know that many of these patients, approximately half of them, actually have impaired renal function, which has an impact on outcomes. And ferric carboxymaltose has been shown to improve the eGFR in the FAIR heart failure study sub-analysis at 24-week follow-up. This is the meta-analysis that I was talking about, the most recent one that is available in 2018, effect of ferric carboxymaltose in hospitalizations and mortality rates in iron deficient heart failure patients with the individual patient data meta-analysis. In this, you can see there are about 800 patients, including all these 4 studies that I alluded to. 68 years is the average age. And despite the fact that more than 90% of these patients were on guideline-directed medical therapy, you notice that almost 70% were still in class 3. That is a patient that was selected for these trials. And outcomes in iron deficient heart failure patients who are given iron vis-a-vis placebo, you will notice that there is a significant reduction in the rate ratios of all these important endpoints like CV hospitalization and CV mortality, heart failure hospitalization and all-cause mortality, all-cause hospitalization and all-cause mortality, and so on. So this is the first time that we have a patient-level meta-analysis that has shown us these beneficial effects, because the individual studies have been relatively small. 2016 ESC guidelines have included in the diagnostic tests with patients with heart failure that levels of ferritin and transferrin saturation be measured in all patients who are being investigated for heart failure. And the diagnosis of iron deficiency should be made if serum ferritin is less than 100 nanograms per ml, or if the ferritin is more than 100 but less than 300 nanograms per ml when transferrin saturation is less than 20%. And in all these patients, intravenous ferric carboxymaltose should be considered if these patients are significantly symptomatic. So key home messages before I finish the 8 minutes allotted to me is that iron deficiency is an important comorbidity and is prevalent in approximately 50 to 75% of the patients, especially in patients with a chronic heart failure, but also in acute decompensated heart failure, results in number of comorbidities, and treatment with results in number of deficiencies and symptoms in these patients. Treatment with ferric carboxymaltose improves morbidity and mortality in heart failure with iron deficiency. In future, of course, we have to look at in patients with heart failure and preserved ejection fraction in whom we do not have any data at this time, and also have more systematic studies in patients with acute decompensated heart failure. Thank you very much.
Thank you.
So Sandeep, there's a share screen option at the center bottom.
Now, ARNI in heart failure with reduced ejection fraction by Sandeep. Should I start your video? Host has right now given screen sharing rights to Dr. Sandeep Bansal since he is going to be lecturing. But there are other videos.
Sandeep sir, please open first, follow your PPT, then go to Zoom. First, follow, open your PPT.
Yeah.
Should I?
Yes, Dr. Bansal, welcome.
Thank you, sir.
What a pleasure to see you in this colorful attire. And let the lives of cardiac patients be also colorful.
Thank you.
With your wisdom. We welcome Dr. Sandeep Bansal, an excellent speaker, excellent orator, wonderful teacher. I think I'll not go on praising, otherwise the whole lecture schedule will go in his praise.
Thank you.
Please go ahead.
Yeah.
Sir, please share your screen, sir.
Is my screen visible now?
Yes, sir.
Yes,
Go ahead.
Okay.
Yes, it's visible, Sandeep.
Thank you.
Chalo.
Thank you.
Thank you very much. And my job this evening is to discuss on this niche area, and that is about ARNI in HFrEF, whether we started de novo or we switch it from the ACE inhibitors or ARBs. And as we all know, these are the 5 pillars of HFrEF therapy starting
Sandeep,
2020.
you need to switch off your video.
Inhibitors came in. Some people say there are. You're telling me?
Yeah. Otherwise the signal is not good.
Okay, I'm stopping my video.
Yeah, better.
Okay. See, many people put the RAS inhibition together. So they say there are 4 pillars. We also know that the paradigm heart failure was the landmark trial which brought in the LCZ 696 or ARNI as we know, and it was after a long time that we saw a reduction in total mortality. Following many years, there was a drug which could reduce mortality.
However, as we see here, there were some limitations. If we look at these inclusion criteria in the paradigm heart failure, we find that all patients, I mean, look at ACE inhibitors, look at ARBs, all patients, 100% of the patients were either on ACE inhibitors or ARBs. So we never had an evidence whether we could use them de novo, or we had to always use it after an ACE inhibitor or an ARB. Now, based on the fact that there were early benefits with ARNI, particularly in reduction hospitalization for heart failure, for several years, the ACC said that you could start ARNI de novo also, or you could start it following the usage of ACE or ARB. The ESC said that it should only be given after trial of ACE inhibitors or ARBs. Now, further down, people have tried to see whether we could use them, from chronic heart failure to a time which is pre-discharge or, just after discharge from acute decompensation of heart failure. And also people have tried to use it in de novo heart failure versus in those patients, and also in those patients wherein there is a chronic heart failure and acute worsening. So this was a transition study wherein de novo heart failure was present in about a third of patients, and prior heart failure was present in 2/3 of the patients, and they all had presented with acute decompensated heart failure. What was seen was that in this, it was noted that if you started these patients pre-discharge on valsartan and sacubitril combination, then there was absolutely no difference in the outcomes. The baseline characteristics in this were similar. The endpoints were also pretty much similar, and the safety was also established. Of importance is this particular area of the slide, which actually shows that even in de novo, those patients inhibitors or ARBs, even in those who had prior CHF, there were some patients who were not on those drugs. There are no separate slides for that, but it has been mentioned in the literature that those who were on ACE or ARB or were not, irrespective of that, the benefits were pretty much similar. So they concluded that it was okay to start de novo versus to shift from ACE inhibitors. The major endpoint of this trial was not that. The major endpoint was that they could be started pre-discharge. Now, having said that, there is another study called the Pioneer Heart Failure Study. And in Pioneer Heart Failure Study, again, there is a 2x2 kind of factor design to see whether the patients were on prior ACE inhibitor or not, and de novo and chronic heart failure. Now, what has been seen is that overall, whether your patients are on ACE inhibitor or are on pre-existing ACE inhibitors or not, the benefits are pretty much similar. In fact, if we see at this red graph, this is the patients who were not on ACE inhibitors and ARBs. The degree of benefit is greater than it is if the patients were on pre-existing ACE or ARB. This is data from among those patients who were on chronic heart failure worsened. These are the common garden variety of patients and that we have. And what was seen was that whether the patients were not on ACE inhibitors or ARBs or were on ACE inhibitors and ARBs, the benefits accrued. There was a significant benefit in terms of percentage change in the NT-proBNP. That's the thing that we have. And there was a tendency for similar benefits in terms of clinical events also. And so therefore, from the Pioneer Heart Failure Study, we noted that again, 2/3 of the patients, the blue and the black, they were on prior ACE inhibitors or ARBs, and 1/3 of the patients were those who were, were not on ACE or ARB. The exact percentage was actually very small. This trial also concluded that sacubitril valsartan combination was safe, produced a greater reduction in NT-proBNP, and improved clinical outcomes when compared with enalapril, irrespective of heart failure history or pre-treatment with ACE or ARB. So we really don't have absolute evidence in a common garden stable heart failure patient if he comes to our clinic, whether we start on ACE and then shift or not. But in majority of the trials where it has been started after an acute decompensated heart failure, there is an absolutely clear benefit if we start the ARNI de novo. And based on that, this February 2021 update to the 2017 expert consensus clearly says, it has a segment which clearly says initiation of an ARNI de novo without prior exposure to ACE or ARB. And it says, I'll read the verbatim, it says that directly initiating rather than giving a pre-treatment is a safe and effective strategy. Those who were ACE ARB naive, there were versus those who were started after ACE and ARB, there were no unexpected events. This is from the titration study. From PROVE heart failure, again, this is a very small fraction of patients who were without, who were naive to ACE or ARBs, but there was again a similar and significant cardiac remodeling which was noted with about a 10% increase in ejection fraction at 1 year, and supported by the data that I already showed, the pioneer in the transition. It is clear that because, in total, if you consider a direct ARNI approach, instead of, shifting pre-treatment with ACE or ARB and then shifting is the way to go about. So this is the current ACC recommendation, and it clearly says that ACE and ARNI are to be preferred. I haven't included one slide, but there is also a recent paper from Milton Packer and John McMurray, which actually talks of accelerated, starting of all the 4 drugs, which says that initially you can start with beta blockers and SGLT2 inhibitors, and 2 weeks down the line, you start these patients on ARNI and subsequently start these patients on MRAs. So we have a lot of dynamic thing going on in the area, but it is clear that it is absolutely safe to start the patients on ARNI without, the pre-treatment with ACE or ARB. I thank you for your kind attention.
Thank you, Sandeep. With the permission of Dr. Kaul, Dr. V.K. Chopra has to leave early. So, sir, if you permit, can he give the talk before you, sir?
I'm sorry, I have a session starting at 7. I'm just looking at my watch.
Okay, sir. Then after you, maybe then he can give a talk. That's okay.
I'm sorry, because
that's okay.
That's a problem. Okay.
So we have a talk by Dr. Kaul on SGLT2 inhibitors in renal failure with heart failure.
Yeah, but almost, I'm sorry, I'm Vijay here. I also have another session going at 7
we'll stick to the schedule, and if we stay on time, probably we'll finish on time.
That's a problem. You're running late.
I think we're all running late. That doesn't matter. We'll stick to time.
No problem. I will not exceed 10 minutes.
Second out of 5
Let me start on this important topic in this very educative symposium on saving the sinking heart. And I'm going to talk about SGLT2 inhibitors and GLP-1 agonists. What is their role? We all know that the evolution of heart failure management starts from prevention of heart failure to treatment of heart failure. And we know that if we take a diabetic, There's a preclinical stage for about 5 to 10 years. And then there's a clinical stage, and then the patient develops heart failure. We have enough data from canagliflozin, dapagliflozin, and empagliflozin showing that we can prevent heart failure, we can postpone heart failure in diabetics. And we have now data from a number of studies, DAPA-HF study and the EMPEROR-reduced study, which I'm going to discuss in little more detail. And also we have data from soloist study in which the sotagliflozin from Boehringer, which has also shown to be of great utility. Now, if we look at the DAPA-HF study, which was a large study of more than 4,700 patients, and the usual inclusion criteria, all with reduced ejection fraction, with or without diabetes, all with elevated NT-proBNP, and the eGFR more than 30, with the primary endpoint of first occurrence of any of the composites of cardiovascular death or hospitalization for heart failure or an urgent heart failure visit. And then the EMPEROR reduced, which came within 6 months of the earlier one. Once again, it was empagliflozin in reduced ejection fraction, less than 40%, and both the drugs had a standard dose. It was not out of dose titration, 10 milligrams there. And then there was a confirmed composite primary endpoint of almost the same, time to first event of adjudicated heart failure or hospitalization or death. Now, if we look at the baseline characteristics, they are quite similar. DAPA study was a little larger study with about close to 5,000 patients, and EMPEROR with about 3,600 patients. Mean age is close to 65. 25% of the patients are females. And as you can see, most of them are either class 2 or class 3 NYHA, with hardly any patients with NYHA 4. Ejection fraction was low, and it was lower in EMPEROR reduced, around 27 versus 31 in DAPA-HF. NT-proBNPs were quite high, and about 1/3 of the patients in EMPEROR study had hospitalization for heart failure in the recent past, and about 1/4 in DAPA heart failure. Interestingly, both the studies had 50% patients non-diabetics and 50% diabetics, and eGFR was less than 60. eGFR more than 60 was kept as this thing, but there were many patients with less than 60 also. And very important, these drugs were given over and above ACE inhibitors, ARBs, ARNI, which we're discussing in the last lecture, and also aldosterone antagonists. And 1/3 of the patients had ICD or CRTD, as we see in the real world in the EMPEROR study, and 26% in DAPA-HF study. So once again indicating that they were sick patients, probably sicker patients in EMPEROR are reduced. Meta-analysis of these two, because inclusion criteria are almost the same, you can easily see that there is a 26% reduction in the composite primary endpoint of first hospitalization for heart failure or cardiovascular death. And first hospitalization for heart failure is reduced by about 31%. If we look at all-cause mortality, which is a very robust endpoint, there is a 23% reduction. There's a 13% reduction in all-cause mortality. And if we look at cardiovascular death, there's a 14% reduction in cardiovascular death, both very significant statistically. If we look at diabetic versus non-diabetic, they behave the same. So it doesn't matter whether the patient is diabetic or patient is not diabetic, 50% each in both the studies. If we look at the renal function and we look at whether the eGFR is less than 60 or it is more than 60, the benefits are the same. They are useful equally in patients with eGFR less than 60 also. If we look at what about ARNI, because ARNI is supposed to be a very useful addition to the drugs of heart failure, you can see that in both the trials, over and above ARNI, there is a very clear-cut 22% reduction in the primary endpoint, and which is same is as not receiving ARNI. So whether the patient is on ARNI or not ARNI, it doesn't make them less efficacious. Safety was one of the very important points, and there was hardly any volume depletion, hardly any fractures and amputation, which were highlighted in, as you know, in the Canvas study. Hypoglycemia was not a problem. Ketoacidosis was not a problem. And serious adverse events are very low. It's very important to see that in 2016 guidelines, although these drugs were available, but they were not tested in heart failure, they are not mentioned anywhere. But now if we see ARNI, beta blocker, aldosterone antagonist, SGLT2 blockers, all of them can reduce the relative risk by 73% and reduce the absolute reduction of mortality by about 26%. That would mean that if we have all the drugs on board, then you have to treat only 4 patients to reduce 1 death in 24 months, which is, I think, an extremely gratifying development which has happened over the years. This slide was shown by Dr. Bansal also, that he was focusing on aldosterone antagonist here and ARNI, but you can see that SGLT2 has been indicated in patients who have got an adequate EGFR as a very important drug after ARNI. And Canadian classifications initially had diabetics only, but then now they say without concomitant diabetes. So now we have this SGLT2 inhibitor knocking at the door to come into the guidelines. And we also were told by Dr. Bansal in his last part that this sequencing, that means give ACE inhibitor first, then beta blocker, then MRA, and then ARNI, and then finally SGLT2, will waste a lot of time, and you will lose some patients and they will not get optimal benefit. So this particular study and the sequencing, which has been brought to notice by Milton Packer and McBurney, says that our first step should be beta blocker with SGLT2, and then you go to add ARNI and then MRA, so that within 4 weeks' time, all the 4 drugs are on board. So let me come to GLP-1 receptor agonists. Well, we know that GLP-1 agonists are a very important part of the management of patients with vascular disease, and many of them have heart failure. They have multifactorial inaction. They improve the vascular protection. They reduce weight. They improve the renal function. And the liraglutide study, which the leader study had very clearly shown that it reduces the mortality by 13% and 22% risk reduction. In addition, it produces 0.7 to 1% reduction in the HbA1c and maybe about 5 to 10% reduction in the weight also. So we can treat 98 patients who are eligible with vascular events, and will prevent 98 patients and will prevent 1 death over 3 years. And evidence of liraglutide usefulness in heart failure is very clear, that you can use it over and above all the drugs of heart failure. Heart failure presence does not change the efficacy of liraglutide in patients who need for vascular protection. And liraglutide can be safely used. And if we come to this thing that SGLT2, the efficacy becomes very marginal, and they're not used in, stage 5 chronic kidney disease, less than 30. And we know now that in some countries we're using 30 to 45 also, although we're still told that use should be restricted in less than 45, but most of us do use it. But GLP-1 analogs can be used up to 15 EGFR. That is one of the advantages of these agents. So that is one of the very important things. And that's why these guidelines have come in, that ADA 2019 and European Society has very clearly said that indicators of high risk or established atherosclerotic cardiovascular disease, CKD, or heart failure, you can use GLP-1 analogs easily. The same is the ESC 2019, and same is the guidelines of 2020. So one of the issues with these GLP-1 analogs is we know they have life-saving benefits, But at the same time, it has been seen that there's the inertia in using these GLP-1 analogs by cardiologists. And as this slide shows, that only 15% of cardiologists were found in this large study that they were using GLP-1 analogs. And a patient with type 2 diabetes with cardiovascular disease has 4 to 5 times more chance of coming to a cardiologist than an endocrinologist. So we cardiologists have to remember that we have this group of drugs. So I'd like to conclude by giving some take-home messages that new therapies with SGLT2 inhibitors and GLP-1 analogs have really managed to revolutionize the management of heart failure with or without diabetes. We need to start SGLT2 early in the management and with or without diabetes, along with beta blockers as the initial drug. Both dapagliflozin and empagliflozin have been shown to reduce mortality and recurrent hospitalization over and above the standard of care with beta blockers, ARNI, and aldosterone antagonists. GLP-1 agonists like liraglutide, semaglutide, which is once a week only injection, is going to come. Dulaglutide is already available. They reduce the vascular events and are common in obese diabetics, irrespective of heart failure, and up to 15 ml per minute of eGFR. Cardiologist inertia in doing it is concerning and needs to be aggressive in managing these patients using these agents. Thank you very much.
Thank you, sir. Let's hope that cardiologist inertia goes away. And continuing on that theme, moving on to renal failure, we have Dr. Kher now.
Thank you. I must take this opportunity to thank the organizers for giving me this opportunity to speak about this double whammy of renal dysfunction and heart failure. Obviously, there is a crosstalk between the kidney and the heart, and you can see that fluid overload, retention of salt and water, and cardio congestion are common in patients with chronic kidney disease. There is a neurohormonal activation of RAS, activation of sympathetic nervous system, both in heart failure as well as in patients with kidney disease. And there is a chronic inflammatory state with activation of the cellular immunity, malnutrition, cachexia, wasting are common, bone mineral disorder, acid-base disorders, anemia, and cardiorenal anemia are common in patients of heart failure as well as in kidney disease. You can see in this slide, what it shows is that the risk of heart failure in patients with chronic kidney disease.
You need to share the
not
slides.
Visible. Oh, let me go back. Are they visible now?
Not yet, sir.
Sir, please share the screen, sir.
Yeah, I don't know.
Sir, you need to share a screen from the center bottom.
Press share and then click the slides. You'll see the slides on the screen.
Yeah. Let me get out first. I need to. Are they visible now?
I think they're about to come. Yeah, they're there. You can
They're
start
visible.
with the first slide now.
Okay.
Okay, fine.
Okay, yeah. This was the crosstalk that I was talking about, the kidney and the heart talking to each other. And you can see in this slide is that as the kidney function deteriorates from patients without kidney disease to patients going up to stage 5 kidney disease, the incidence of heart failure you can find is increasing in patients with declining kidney function. And if you look at patients across pre-ESRD and ESRD, the yellow lines which show you the incidence of congestive heart failure out of the various cardiovascular mortality, which remains the commonest cause of death in patients of kidney failure, you can see that heart failure is fairly common in patients with progressive chronic kidney disease. And with declining GFR, you can see that patients of heart failure have an increasing mortality. As the kidney function declines with GFR more than 90, going up to a GFR less than 30, you can see that there is a progressive increase in the mortality or hospitalization in these patients. So the evidence of drugs which have been found to be effective in patients with chronic kidney disease as well as in patients with heart failure is that you find that ACE inhibitors are being used in patients with chronic kidney disease at all stages. And these are drugs of choice till ARNI and SGLT2 were available in patients with heart failure. Beta blockers, you've been hearing since morning, I guess. MRAs are also drugs which are used both in heart failure. In patients with early kidney disease, say up to stage 3, MRAs are found to be useful in preventing progression of renal disease. Angiotensin receptor blockers are same. Ivabradine as well as hydralazine, and they are drugs if in patients with heart failure, in fact, they have progressive kidney disease. These are drugs which can be used across all boards of chronic kidney disease as such in these patients. Now, ACE inhibitors have demonstrated survival benefits in patients with or without renal dysfunction in patients with heart failure. And you can see that the hospitalization as well as congestive heart failure who have required ACE inhibitors, you can see that there is event rates are lower in patients who have been given captopril in this study. Beta blockers have also demonstrated benefit in patients with heart failure, and irrespective of whatever level of GFR1 is looking at. Mineralocorticoid receptor inhibitors, again, have been shown to be useful in patients of moderate chronic kidney disease. Obviously, they're not effective in patients with stage 4 and 5 kidney disease. And same is true with ACE inhibitors in stage 5 kidney disease, as well as ARNIs and SGLT2 inhibitors have also not been used in patients with GFRs less than 30 ml or so. Although in DAPA-CKD study now, there is evidence that people have, the DAPA-CKD study, which included both diabetic and non-diabetic patients, there the patients went up to a GFR of about 20. And now AMPA-CKD study is also including patients where the GFR is about 15 ml or so. So stage 4 kidney disease is also being included now in newer studies which are showing effects related to the SGLT2, and the ARNI also is now being used up to a GFR of about 20 ml or so. And there is a study, although the benefits of ARNI at a GFR of lower than 20 ml or so is not very evident. But in this study, actually, you can see that whether the GFR was CKD stage less than 60 or more than 60, you can see that the benefits of ARNI were evident in the Paragon trial, which has been discussed by earlier people here itself. What is becoming evident is actually that there is a deterioration in renal function, both associated with heart failure, and when you introduce diuretics, RAS inhibitors or ARNI in these patients, and even this is true with SGLT2 inhibitors, there is a sudden decline in the GFR, and that's related to the effects at the tubuloglomerular feedback which occurs because there is an afferent and efferent arteriolar dilatation which occurs with these inhibitors, and therefore there may be a sudden decline. If the GFR remains less than 30 ml or so, then you don't need to worry too much about it, and you need to continue it, and over a period of time this decline will recover, and the further decline in renal function has been shown to be slower both with ACE inhibitors, ARBs, and with ARNI also. And in patients with ARNI, those who were compared were also on ACE and ARBs. There was a further slowing of the progression of kidney disease, and that's become evident in these patients. But if the deterioration goes to more than 30% and it is persistent, or progressive decline in renal function, rapid decline in renal function occurs, then one might have to stop these drugs temporarily for some period of time, look for the factors, and the most important factor which needs to be taken care of is volume depletion in these patients. And these are the patients who both with SGLT2 inhibitors as well as with ARNI will have a slight greater decline in renal function. Let the volume repletion occur, and then you can restart these drugs earlier. And this has been shown that in real life, mineralocorticoid receptor blockers, because of the effects on the potassium and renal function, in deteriorating renal function, you may not be optimally able to use it. But in early stages of chronic kidney disease, these are again useful drugs, not only for heart failure, but also for progressive renal decline. The evidence for heart failure therapies obviously declines exponentially when you go into advanced stages of kidney disease. In fact, actually, none of the drugs have been studied very effectively in stage 4 and stage 5. Most of the trials have excluded patients with GFR less than 30 ml or so. So therefore, you do not have evidence of utility of these drugs. But there is more and more evidence coming that now people are started using these drugs, and especially the SGLT2 inhibitors, which have shown huge promise. And the cardiologists, obviously, I don't think I need to tell them that these are drugs for heart failure. It's like taking coals to the castle. But I will show you evidence that these drugs are also effective and found to be very useful in patients with slowing down the progression of kidney failure. These are various SGLT2 inhibitors, and you can see that the benefit of SGLT2 inhibitors in patients with renal failure, renal disease is evident from all across. All the trials have shown benefit in the renal endpoints in these, whether it is ESKD or more than 40% or 50% decline in GFR or renal death. And you can see that DAPA gliflozin, this slide shows us that is effective across the GFRs, ranging from 100 to 30, and below 30 they have not been sort of studied. However, in DAPA-CKD study, which included both diabetic and non-diabetic study, as Dr. Kaul was talking about, DAPA heart failure study, where it was shown to be extremely effective in reducing mortality or hospitalization or death related to heart failure, had also shown benefits with renal evidence. And in this study, you can see that these are various patients who were diabetic and non-diabetic, 4,000 patients included in this study. And you can see that the renal benefits are extremely beneficial. 40% reduction in number needed to treat is about 19 to prevent one renal endpoint. And you can see that the benefits were whether the patients had type 2 diabetes or no, whether the proteinuria was more than 1,000 or less than 1,000 milligrams, whether the GFR was less than 45 or it was more than 45. The benefits of DAPA in this study, DAPA-CKD study, was evident. Obviously, you have already seen the benefits. I don't need to emphasize on the benefits of on heart failure itself. And this is, again, showing overall benefit of DAPA in patients with chronic kidney disease. And these are the secondary outcomes which were looked at: 30% decline in mortality, 29% decline in cardiovascular death or hospitalization due to heart failure. And you can see that Dr. Kaul had also shown you the slides of the safety of SGLT2 inhibitors has again been documented, although initially there was some evidence suggesting that there may be an acute kidney injury and bone fractures and others, but that has not been documented by these large trials. And the ERA EDT has also included in the guidelines that now these drugs for diabetic kidney disease, as well as now for, I'm sure they will include for non-diabetic CKD as well, that these drugs could be used for preventing, not only reducing the morbidity and mortality related to diabetes, but also related to non-diabetic. And KDIGO guidelines have also included that just either metformin and SGLT2 inhibitors are rising in the charts for initiation of these therapies. So with this, I will stop and say that SGLT2 are going to be the paradigm change in the management of progressive renal disease, as well as patients with heart failure, which occurs in about 50% of patients with progressive chronic kidney disease. So these are drugs which are going to be changing the paradigm, making a paradigm shift in the management of these patients. Thank you very much for the opportunity.
Thank you, sir. So finally, when we listen to Dr. Chopra on what is the current status of SGLT2 inhibitors.
State of the art of management of HF.
Thank you. I think most of what I am going to speak has already been mentioned by Dr. Kaul and Dr. Kher. So I'll probably take just about 5 minutes to finish this. So this is the topic given to me. Are there diamonds in the rough? Let's see whether it is true or not. We know that despite beta blockers ACE inhibitors, and mineralocorticoid receptors, there is still a residual risk. And although it was reduced by ARNI by a further 20%, there is still a residual risk. Over the last 2 or 3 years, apart from COVID, probably there's been no other topic which has attracted as many publications and interests as SGLT2 inhibitors. Starting with EMPA-REG outcomes, where it was a result of serendipity that even the investigators were surprised to find there was a reduction in cardiovascular endpoints driven mainly by reduction in heart failure hospitalizations. And this was subsequently replicated in DECLARE and CANVAS programs also, which focused at preclinical or clinical stages of the disease. Then subsequently, investigators went on to see whether we can use these drugs to treat heart failure, and since they do not cause hypoglycemia, if they would be effective also in non-diabetic patients. And indeed, this is what was shown in DAPA-HF trial and the recently presented EMPEROR-PRESERVE trial. The SOLOIST and the SCORE trials, which were dealing with sotagliflozin, which is SGLT1 and 2 inhibitor, also showed similar results, although the trial was stopped early due to financial problems and due to COVID epidemic. But results all pointed towards the same direction. So again, this has been seen that whether the patient has a history of heart failure or they have no history of heart failure, all the SGLT2 trials have shown significant benefit in cardiovascular outcomes and also in reduction of heart failure and cardiovascular death and first hospitalization of heart failure. Each trial has shown significant benefit, and the test of heterogeneity has been 0.89, indicating that although there are minor differences in the results, basically they all point towards the same direction. The CV mortality and all-cause mortality also has been significantly reduced. DAPA-HF had a little more reduction in mortality as compared to EMPEROR, and there have been various discussions as to why this happened, but let's not go into that at this time. And as Dr. Kaul mentioned, whether a person has diabetes or no diabetes, the results are similar. Whether the patients had a GFR of less than 60 or over 60, again, the results were equally beneficial. On a background of ARNI, which again has been alluded to, whether the patients were receiving ARNI or they were not receiving ARNI, the incremental benefit continued to accrue with SGLT2 inhibitors. Overall safety and adverse events in DAPA-HF and indeed also in EMPEROR reduced were pretty close to that of placebo, the only difference being a slight increase in genital infection, which can be easily handled by proper instructions about genital hygiene. For our patients of heart failure, for our heart failure patients, kidney outcomes are extremely important. And as we know, DAPA-CKD trial, which dealt with chronic kidney disease with low EGFR, was stopped prematurely due to overwhelming superiority. And also in EMPEROR reduced, we saw a whopping 50% reduction in end-stage kidney disease and composite or sustained profound decrease in EGFR, indicating that these drugs have powerful effects. As cardiologists, we are always interested in find out what are the mechanisms and are there any mechanistic studies. So this is a small summary of the mechanistic studies which have been done. On echocardiography, reversal of LV remodeling has been shown. Reduction of LV mass on MRI has been shown. Reduction in pulmonary capillary wedge pressure has been shown. And reduction in congestion by reduction in NT-proBNP has been shown in different studies by the use of SGLT2 inhibitors. And these are all important considerations in management of patients of heart failure. Ultimately, for what matters for patient is a quality of life. And this is what was seen in EMPEROR reduced study, that there was a greater number of patients who had improvement in quality of life, and there was a lesser number of patients who had deterioration in the quality of life with the use of empagliflozin. Again, Dr. Kaul has mentioned that if we use all the 4 therapies, ARNI, beta blockers, aldosterone, and SGLT2 inhibitors, there's a very significant relative risk reduction in mortality, and absolute reduction in all-cause mortality is again very, very significant. So based on these, most of the guidelines have already started putting out the role of SGLT2 inhibitors. The position paper of ESC mentioned that dapagliflozin could be considered in the treatment of patients with HFrEF with and without type 2 diabetes, and this was mentioned after the DAPA-HF trial. ACC and AHA updates also, again, this slide has been shown, which indicates that SGLT2 inhibitors will occupy a very prominent place in the management of HFrEF. I'm pretty sure that these recommendations will come in their official guidelines. There's a proposed modification by Dr. Rosano, which was published last year, that ACE inhibitor, ARM, and beta blocker add MRA. But if you see on the right side, SGLT2 inhibitors are there right throughout in symptomatic HFrEF. Again, this stepped up care therapy was mentioned by Dr. Call, which was put out by Dr. Milton Packer and Dr. McMurray, indicating that first step could be beta blockers and SGLT2 inhibitors, and later on the other two drugs can be added on. But of course, it depends upon the hemodynamic profile of the patient. If the patient was hypertensive, earlier. Within 2 or 3 weeks or 4 weeks, all the 4 drugs should be on board, used carefully, and then the doses can be stepped up. This was an article that we published in Indian Heart Journal, and looks like that SGLT2 inhibitors will come to occupy a center stage in the management of heart failure. So I would say it's no longer a diamond in the rough, but it is very well polished. What are we looking for in a drug? Efficacy, that has been established. Side effects should be minimal, that is true. There is no problem with heart rate, blood pressure, and electrolytes of any significance. These are easy to use drugs, can be introduced at any time in management of heart failure. Single dose, no titration is needed. They can be safely combined with all heart failure therapies which are currently available. And they show remarkable benefits in renal endpoints also, which is very important in heart failure patients. Cost still remains an issue, but with generic drugs coming in, probably this also factor will be taken care of. So I would say that they were no longer diamonds in the rough, but they're very well polished. And with that, I will close. Thank you very much.
Thank you, sir. And we have the final talk now. Dr. Tapan Ghosh, how do we treat heart failure? Is it stepped care or a sledgehammer? Dr. Tapan, please. Dr. Tapan, can you start your talk, please?
Are you able to see the slide?
Yeah, slides are okay.
Yeah, right. So good afternoon, everyone. I think most of the part of my talk has finished. I have just to summarize the findings. So friends, you know that heart failure is a illness which is really more malignant than cancer. The 5-year mortality is 50%. So a lot of research is ongoing and very rapid change in the pharmacotherapy. And these are the host of positive trials over the last 20 years and is changing landscape. We had ACE or ARB, which was the earlier therapy. Then we had added beta blocker, then MRA, and then host of other agents. And the mortality gradually is declining from 15% to 6.09% in recent times with the addition of different agents. And various scientific societies have given stepwise management, and this is the ESC 2016 guidelines, which showed that we should start ACE and beta blocker, then up titrate the drug, and then go to ARNI. These are the earlier indications and class 1 indications showing that how to go about the therapy. This is in heart failure with reduced ejection fraction therapy, the ACC guidelines 2017. They recommended stepwise therapy, step 1, 2, 3, 4, 5. In step 1, you look into the total clinical picture, and then in step 2, you look into the NOH class and whether the drugs are on or not, then go to a step 3, and then up titrate the drug, step 4, reassess, and step 5, again reinforced. That's the how it's going. In 2017 Canadian guideline also, there was a stepwise therapy again recommended. And all these stepwise approach showed that ACE and beta blockers are the established starting therapy with evidence of reduction in heart failure mortality. Stepwise therapy is preferred and drugs should be added only after the patient remains symptomatic after maximal tolerated doses of conventional therapy. Polypharmacy should be avoided, and the adverse event profile conventional therapy is well established and they can be taken care. Now, how are we faring? Are we using optimal guideline-directed medical therapy? Let's look into it. The evidence suggests that no, we are not using. Most of the time, even in ACE, ARB, RNA, beta blocker, whatever you address, most of the time we are not doing properly. So there is inertia on the clinical side that the drugs are not given in a proper dosage, up titration is not done, and proper drugs are not selected. So, these are the data showing that most of the patients do not receive the optimal optimal dose of the drug, and 1% receive triple therapy at right doses. That means most of the drugs are not given properly. Now, let's look into the utilization of the medical therapy. First, ACE and ARB. Overall uptake 77%, but only 17% achieve the guideline recommended dosage. And lowest in China and Japan, highest in Indonesia and South Korea. This is what the ACE and ARB. So, utilization. Let's look into beta blocker. And again, beta blocker utilization, overall uptake 79%, but only 13% achieved guideline recommended dosage, and lowest in India, highest in Malaysia and Thailand. So actually we again are using lowest number of beta blocker. What about the device? And if you look into the device, that most of our patients don't receive the device. And India, there are only 4.9% patients receive the device. In Japan, it was the highest, 52%. So that there is our underutilization of the available technologies. Now, by income group, if you divide the whole world, low income, middle income, and high income countries, it is seen that low income countries, drugs use are the lowest, and highest was the high income countries, middle is the middle income group. And what are the newer drugs? And and these are the conventional drugs, ACE, ARB, beta blocker, DEEG showed reduced hospitalization. And at very low dose, there is some mortality benefits. Sub-analysis of the DEEG trial showing that an aldosterone antagonist, adrenaline dinyetri in black patient, RNA you have heard, enivabrudine reduces hospitalization. So these are the host of drugs which are available. And on the top of that, we have, DAPA heart failure trial showing SGLT2 inhibitor. Then Victoria trial, very so good, showing that in a patient, it reduces hospitalization if you select it correctly. And hemodynamic neutrality, is one of the, added benefit because it doesn't lower the blood pressure. Enivabrudine again showed reduced hospitalization. So paradigm heart failure, change the, management of heart failure. And since, the beginning of the consensus trial, we have been using enalapril, and enalapril had been the gold standard of therapy for heart failure. But then this again on the top of enalapril, it showed that there is additional 17 to 18% reduction in the mortality, and mortality benefit is there. So practically all the guidelines in the world has replaced and advocated ARNI on the top of, conventional drugs. DAPA heart failure, you have seen this slide and time and again, and dapagliflozin 10 milligram reduced mortality and heart failure hospitalization. So addition of a new drug class yields greater benefit than up titration of the existing classes. And in the up titration also, we really cannot up titrate most of the time the drugs. And this is data from the qualified trial. And benefit are shown with SGLT2 at very early. At 28 days, there's benefit shown with the dapagliflozin. So every opportunity should be used for using these drugs at very early. Again, this drug is showing that, benefit are greatest with patients who are hospitalized recently, less than 12 months. And primary endpoint, all these drugs showed that DAPA was better, whether the patient was on a beta blocker, ACE, ARB, irrespective of the doses, irrespective of gender, and dapagliflozin benefit consistent with the background therapy. And it shows that analysis shows that if you can use dapagliflozin in addition to the existing therapy, lot of more lives will be saved, and there will be 26% reduction, absolute reduction in the mortality in heart failure patients if you can use this. You have seen these slides again and again. Only you have to treat 4 patients to get benefit of saving 1 patient's life. So the take away message from this analysis of Bhaduganathan et al. Was that earlier use of SGLT2 inhibitor in therapeutic pathway will save more lives. Now, how should we sequence this? So there had been a lot of proposition. The limitation of traditional therapy is that a long time is required, and at least if you go by the trial method, then you'd require more than 3 months, up to 6 months to go to all these 4 drugs. That's what is a sequence. The issues with conventional therapy is that physicians prioritize to achievement of a target dose of each drug class. It may take 6 months, and delay of 6 months is not acceptable in this situation because the mortality remains very high, and we have to reduce the mortality. And this is what the new proposition: beta blocker plus SGLT2 inhibitor initially, and then add ARNI, then MRA, and the whole sequence should take place within a 4 weeks period of time. And the principles of which the recommended algorithm is based: simultaneous initiation of treatment with a beta blocker and SGLT2 will help reduce the congestion, and you will confirm the risk of reducing death in these patients because beta blocker you have initiated. So beta blocker SGLT2 initiation really gives the patients 2 benefits. Number 1, reduction in the sudden death. Number 2, reduction in the hospitalization. Then you can add the other drugs. You have seen this slide. So the proposition is that SGLT2 inhibitor should be added very early in the course of the illness. Now, what are the consideration? Now, SGLT2 inhibitor has a diuretic effect, and this drug reduces the dose requirement for diuretics. And when you are using, you should down titrate the diuretic, very important. Blood pressure, less blood pressure reduction with SGLT2 and an MRA, then the sacubitril valsartan. So at the initiation, you don't have any issue. Electrolyte imbalance is not seen, and renal function, although at the initiation of beta blocker SGLT2, there can be some increment is in the creatinine, and little fall in the calculated EGFR, but it stabilizes, and thereafter the fall in the EGFR is reduced by this SGLT2 beta blocker and then ARNI combination. So the take-home message is that we use all these drugs at very early, and we should use the first opportunity to give the patient the maximal benefit of saving lives. Use them, use early. Most of the agents should be initiated within 4 weeks period, and the first is that we initiate with a diuretic, and then beta blocker, SGLT2, and if tolerated, MRA can be given at the same time, probably after a few days, or in the next visit you can give ARNI or ACE inhibitor as per your choice. I think that is my last slide. So we should prevent death at any cost. Thank you very much.
Thank you very much, sir. We'll conclude this session since we don't really have any extra time. I'll now request Dr. Manchanda to take over the next session, please. Thank you very much.
Thank you.
Good evening, sir. Nice to see you, sir. Dr. Manchanda,
Yeah.
sir.
Good evening, Dr. Sud. Nice to see you.
Great seeing
there
you, sir.
throughout the day. I was
resting
in between. Yeah, I'm glad.
Monica, we can't see you on the screen right now. Monica, we can't see you on the. Yes. Welcome. I think, sir, Monica, I don't know. I'll just introduce Monica, and then you introduce the topic of the program because it says something which medical field doesn't teach you, any of the medical books don't teach you. But in the current world, this is what is required. So she's a brand storyteller. I'll just give a few words about her, although she's got a long biodata. Sir, she's a brand storyteller, a digital strategist who has served the industry for over a decade, and she rose to become the country head, and she's worked with companies like Canon, Huawei, Microsoft, India TV, Wipro, Honda, and other MNCs. Then she created her own entrepreneurship, and she's created a brand communication agency called Interactive Bees. And naam to bahut suna tha, ye nahi pata tha Monica. She is the brain behind this. So in 12 years of its existence, she's worked with the government agencies, National Skill, Pradhan Mantri Kaushal, NASOCAM, 10,000 startups, 10,000. Canon India, Council of, and then Singapore, Century Ply Group, Huawei Telecommunications, and Fortis Hospitals and Max Group, Bennett University, JP University, and Technology Mahindra. This agency, under her entrepreneurship, got the prestigious Red Herring Top 100 Asia Company in 2016 and India 5000 Best MSc Awards in 2017. She was the driver of Digital Summit Awards. She got that award in 18 and 19. So many number of awards recognized, this company was recognized as 50 most valuable technology companies by Inside Success, and this popular IT magazine, Inside Success, labeled as among the 50 most empowering women in business. I've never met one, so you are the first one I have met within the first of 50. So she has been honored with the Eminent Achiever Award in Integrated Marketing Communication by Indian Conventions. She also received an appreciation by CIOs of India, and she got the most prominent Women Empowerment Awards by Merit Awards and Market Research. She has been associated with Brahma Kumaris for over 35 years, and everyone and basic thing is she's talking about disruptive solutions. And I think listening to a person like you in a CSI forum would be a great thing, and we are very honored to have you here, sir. And I would request Dr. Manchanda to introduce the topic further, sir.
Thank you so much.
Well, thank you, Roksud. And Monica, welcome to this talk again for the doctors. We heard you last year. We know that how excellent your talk was. I think it helped large number of doctors. Today, she is going to talk about time and target management, how to control self and manage the time. I think this is key to happiness. Doctors may be very bright. They are really discussing academics like anything, but I know that most of them are not happy. And only yesterday was the happiness day, and it's very unfortunate that India was 129 out of 139 countries. We are at the bottom of happiness index. This was yesterday. Finland is number 1. And when we have people like Monica, who is a devoted Brahmkumari, to tell us, I think if we follow that, we can be happy also, we can be stress-free also. Doctors are under tremendous stress. As you all know, Brahmkumari organization, I have known for the last about 50 years and all. It's doing a human service. It has changed the lives of millions of professionals, including doctors and all, control their stress and all, and give them a new vision of life, that is to live in a spiritual dimension rather than a physical dimension and all. I think without taking much time, I know she is an outstanding speaker, and this talk will be extremely useful for each one of us. I think we should listen because we are under stress. We are really not happy. So she is going to tell us how to manage our time and target to remain happy. Monica, please.
Thank you so much, sir. Thank you so much for such a warm and heartwarming introduction by both of you, sir. It's my absolute pleasure to be back again and sharing my thoughts and views on this lovely topic, time and target management. So in this small deck that I have tried to create for this August gathering, well, the intent is to bring forth, the things, how life has changed. Well, I was all this while sitting here and just listening to this wonderful discussion and forum which was going on. And I was seeing everybody was rushing while we all want to have as much, because there is so much of, knowledge, and suddenly there is an explosion of knowledge which is happening. And everybody is game to have as much. But you see, something which is constantly ticking and moving is time. And that's what. So we cannot control the time. But yes, the intent is definitely that we do something, that we become winners. And this very rightly said by Sir, that the intent is we attain a happy life. So let me just take you all to a small journey. Sit back relaxed in a very comfortable posture. And let's just look just today, today's day. Ever since you got up, how things started progressing. You knew about this conference. There were a lot of things which were coming in. There were a lot of priorities which were coming in. Managing and juggling your time and energies through everything. How beautifully you were steering your life. Well, that's exactly what is happening on a daily basis. We all know that time is money. We also know that time waits for no one. We know that lost time is never found again. Still, what happens? We end up spending this most important and the most valued asset that we have, and keep struggling between these questions on a daily basis. What is time management? What is target management? Is there a way that I can manage my time? Is there a way that I can manage my targets? Is it really required to have targets at all, if at all we really have to? What is it that's eating up my time? And if I know that what is eating my time, can I be empowered enough to stop that right now? My dear friends, my dear teachers and professors, my request to you would be, let's go on to this wonderful journey. It's very much possible. And how? Let's just keep exploring. Let's just understand, what is the dream of our life? Well, we wanted a life which has happiness. I remember when you would have entered the medical school, you would have dreamt of a life which has happiness, which has peace, which has comfortability. Doctors ban jayenge to thoda comfort milega. We wanted a life which is ever growing. We are having a wonderful growth. We wanted a life which is more organized and more sorted. But what have we really ended up creating? Well, very rightly said by Sir, I think we are creating a more stressful life. Doctors as a profession is becoming more and more stressed. And today, with this poor time management, what has it brought in our life? If I were to talk about the professional upheavals which have come in our life, are ineffective workflows leading to low quality of work outputs. Clinical productivity is getting impacted. Umpteen times, you feel so tired and somewhere your best is not going, even though you want to, but you're having such stretched times that even though we want, we still are not able to give our best. Missed deadlines and appointments. Procrastination and lack of focus is also slowly getting into our professional lives. The poor professional reputation that is impeding to the growth within the institution, and slowly, which is leading to bleak possibility of appraisals, ultimately reducing my job satisfaction. Not only this, you see, this poor time management, poor you see management has led to our personal life problems also. It has led to undermining the overall sense of satisfaction. Work and personal life imbalance is becoming a bigger problem. Today, we have sessions on work-life integration, and that's exactly we as doctors are also facing. Strained relations with our family members. And not only this, leading to increased burnt out syndromes, leading to a stressed life. Well, let's understand. Any organization or any hospital for that matter, because a hospital is also an organization, the biggest asset we all know are people. And what are these people bringing along with themselves? They bring along knowledge, they bring along talent and skill sets, and they also bring along commitment, motivation, and creativity. But when does this creativity works? When you have time, when you are more positive. And what is happening is everything is going on toss because we do not do these things timely, neither do we have time. We know the most valuable resource, and we also know that we keep wasting this resource on a daily basis. So it's time to pause and ponder and just look in silence that where have we actually gone wrong. You see, we all understand what is time management when we are effectively, giving right time to do right things, or balancing our time in such a way that we are assigning specific time slots to specific things and making the best use of this wonderful resource. But today, my dear friends, distractions are eating away our time. And there are two things which have today become, very important. And this increase of distraction in the world is because of accessibility and affordability. These two words, accessibility and affordability, has led to increase in distractions. So let's just have a quick peek into what are these factors which are constantly impacting our productivity. The first thing is growing number of increasingly complex diseases and complications in patients. Constantly there is mutations which are happening, constantly number of diseases are increasing, and the number of people who are impacted or affected by these diseases is constantly on an increase and toll. And hence you are required to spend your time in managing those programs, creating solutions for those, managing them, and then operationalizing in such a way that you effectively end up establishing those programs and implementing those programs to the world at large. Natural calamities are actually on an increase, and when such calamities happen, you are forced to actually shift your focus from one thing to another. I think Corona has changed the way we live. Corona changed exactly, people who were specialized into cardiology or into any other specific fields. Everybody was busy solving these diseases and ailments. Not only this, as doctors, we are today also spending our time and energy with dealing with large amount of administrative and paperwork most of the time. At personal level, if I were to talk about, we are also spending lot of time in our own thoughts. And what are these thoughts? Well, these are a variety of thoughts, baggages of the past that we are carrying along with, stresses of the present, and fear of the future. These are the three variants which we always keep carrying along. Somebody said very rightly in Hindi that भूतकाल एक सपना है, भविष्य एक कल्पना है, वर्तमान अपना है. तो जो चीज अपनी है उसको हमें enjoy करना चाहिए. We should actually enjoy the present that we have from God. But you see, there are other factors also which are constantly wasting our time. And the bigger pressure which we as doctors, we as professionals are facing while we are working in an organization is the gossips of people, which sucks our energy. And hence, there are three emotions which are constantly created. And I call them CCJ. The first emotion being competition. The second emotion being, whenever you have a competition, how is he getting better perks than me? How is he performing better than me? Then this competition is leading to comparisons. And then finally leading to jealousy. When you have these three emotions, which are considered to be negative emotions, a negative emotion can never lead to positive results. Let us remember that. If I want to, succeed as an organization, if I want to be successful as an individual, it is important only positivity can create, positive emotions can create positivity, can create successful results. If we are creating negative results, they are constantly sucking my energy. Not only this, there are various other situations that we as professionals are constantly exposed to. You started from home on time. Suddenly there was a traffic jam, and Delhi, it's very often. In fact, major metros, or you talk about any city in India, we thought that, there is corona, there is lockdown. There's no lockdown. Everybody is on roads. And despite of the fact I plan my day, these situations are constantly creating a lot of pressure. I had an operation to conduct, but because of these problems and pressures, it is creating a lot of issues. And the bigger problem, or the bigger factor which is creating a bigger upheaval in our life, is media at large. This media is eating away our attention span. You see, I'm sure you remember these facts that I had shared with you, that these facts are on a logarithmic increase. Today, our media consumption patterns have changed drastically. And thanks to lovely Geo, you see, they have given a hockey curve growth to our usage patterns. Today, approximately 8 hours a person is spending on these media and technologies, out of which approximately 2.5 hours we are spending on social media, 2 to 3 hours we are spending on video watching, and 1.5 hours on some of the podcast or music. That's what we are spending on. So today, distraction is truly accessible and affordable. You press a button and you can download anything. You download 100,000s of songs, 100,000s of movies, videos, whatever you wish to. But ask yourself, do I have time to watch that? Not only this, these media distractions are leading to decreased productivity and growth. And there have been umpteen, I would say, studies which have been conducted. Today, these technologies are becoming like a digital cocaine. Constantly, we are, flipping our phone, watching what is coming, what is the next notification which is coming to us. And there are amazing facts which have been shown through these studies. I'm sure you would remember this Facebook curve. The distractions, the interruptions which we are receiving constantly are increasing asymptotically. And today, these interruptions have almost approached zero. While you all are sitting here listening to me, I'm sure your phone would be full of notifications. Gone are the days when in 80s, we had was a telephone device. And then came a whole range of things. We had pagers, we had blog, Facebook, Twitter, Instagram, and a whole range of things. And today, WhatsApp, which has totally changed the way we communicate. And not only that, today we have hazard apps on our mobile device, which are constantly giving us notifications and eating up and sucking our time. You see, imagine. You open 10 different files on your system, even the best of the system starts hanging and slowing down. That's exactly is happening here also, my dear friends. If we are not giving time for our brain to process things, we are increasing, increasing interruptions and reducing my attention span. And somebody very rightly said that if you keep increasing these interruptions, your attention span is reducing. And if the attention is reducing, it's making you more of a continuous partial attention person. So today we have become individuals with continuous partial attention, and as a result, we are not enjoying our life. We are unable to manage our time. We have best of the things, best of the technology available. We have more approachable, communication patterns, but that time where we could sit with our own folks and enjoy our life, I think that is somewhere lost completely. So these distractions are slowly destroying our mental, physical, and emotional capabilities. So let's just pause and ponder, and together create that lovely winning strategy for our own selves. And it begins with, establishing a goal for ourselves. In your minds, just ask yourself, what is your goal of your own life? What kind of dream that you had seen for your own life? Because let me tell you very clearly, the most important person in our life is me, myself. If I say I love to speak with somebody, you see what I said, I love to speak with somebody. If I speak with somebody, it's me who is happy. If I want to spend time with somebody, it's because I want to spend time. Because I like that person is okay, but that person is giving me comfort, or doing a particular job, doing a particular operation, doing a particular surgery, I enjoy, and hence I'm doing. So the most important person in my life is me, myself. So let me today have the goal of my life very clearly set. And you may ask, what is this goal going to give to us? You see, goal is a long-term vision and a short-term motivation. It helps us, focus our acquisition of knowledge. What is that I really wish to spend my time on? Align our goals and make most out of them. It reminds me of a wonderful story. When Alice went to the Wonderland and she lost her way, she met Cheshire Cat, and she said, "What road do I follow?" So Cheshire Cat said, "Well, where are you going?" She said, "I don't know." And then very beautiful answer with Cheshire Cat, the fat cat, she said was, "Well, if you don't know where you are going, then it really doesn't matter. Any road can get you there." My dear friends, let's just ask ourselves. This time and target management, and this done effectively, can enhance our performance. It helps us achieve our desired goals with less effort and more effective strategies. Let's just have a quick, stage show created for our own selves. Imagine there is a nice news which is on air that Corona has gone. Everything is back to normal. Everything is absolutely fine. You can enjoy your life the way you were doing before. If I were to ask you, kaisa thought hai? What is the quality of thought? What would you all say? Is it good? Is it a nice news? Would you really enjoy it? Anybody would like to say that? Yeah? Huh? Anybody? You see, my dear friends, if something like this gets on air, we say that it's a great news. Everything is back to normal because we all have been yearning for this. And if today something like this happens and we decide, let's organize a big gala event to share our happiness, and let's call our families also. So for us to organize this kind of a stage show and create a great and an effective event, it's important that following has to be kept in mind. We have to deliver a great experience, avoid any confusion, and everything should go as per plan. The first thing that you are going to do is you are going to organize a committee, a planning committee. And that committee, I'm sure you are going to organize and plan that this work would be implemented by this committee. So once that is done, I'm sure you are going to organize that who is going to perform when. There would be an MC for the program, and everybody would be invited on the stage. Once one activity is done, then only you are going to allow the other person to get on the stage, if we really want to deliver results. Now let us just very clearly assume my mind as a stage, my mind as a stage. And on this stage, various thoughts, various activities or inputs which are coming to me constantly in form of a phone call, in form of a call from some senior, junior, patient, anybody, as an input. Now, if I want this thing, the stage show, to work well, to do effectively, perform effectively, then I have to only make sure that I take up one thing at a time. If everything gets on here in one go, it just creates a mess. And that's why Sir very rightly said that today doctors are becoming very stressed. A very simple 6P formula, which I'm going to share with you all, is proper prior planning prevents proper performance. If we can do a proper planning, but I'm sure you would say, well, these are utopian thoughts. For doctors, there is no proper planning because patients keep coming along. Yes, I sure, and I totally with you, and I totally agree. And I have some interesting solutions on that. Well, if you want your day to be great, you must make sure that your morning is winning. If you want to win a morning, we have to make sure that I have a winning night. So my dear friends, that planning that we really need to incorporate in our life starts from the previous day night. Can we quickly sit down and see and have a great plan created for us? And this planning would entail very simple things, that we decide exactly what we want to achieve tomorrow. Think and plan on paper, because studies have very clearly shown that those people who plan using paper are hardly 3%. And it is only these people who are actually likely to achieve more. Now, by planning, I simply mean that there are a list of certain priorities, certain jobs, which we can plan on a broader level. Make a list, and you can start achieving those as goals, because putting them into action is also very important. Making deadlines and achieving them is again an important thing. Then comes prioritizing. And a very simple formula of A, B, C, D, E is very important, where A stands for very important work leading to huge consequences. B stands for important work, but moderate consequences. C stands for good to do work with no consequences. D stands for work that others can also accomplish. So it's not that everything I have to do. I might have my juniors, my subordinates, or somebody who can do it for me. And E is something which you can even eliminate. Somebody has given a very beautiful formula, which is an 80-20 principle. 80% of results come from 20% of actions. And this is what is known as smart work. We really need to understand what is that thing that I should do, which gets me 80% of results. You see, in corporates, we say that 20% of clients are giving me 80% of complaints. Or I can say that 20% of customers are giving me 80% of benefit. Would I not focus upon those 20% of the customers which are giving me the most of the profit, or those jobs which are giving me the utmost benefit? Let's just look into it. And then you see, when you are delegating your work, it's also very important that am I giving it to the right person? I might give it to anybody, but if I give it to anybody, it's like, you are asking a fish to climb a tree or asking a squirrel to swim in the water, which is absolutely impossible. And hence, not only time, but everything just gets wasted in such a scenario. So the key thing is act now to avoid procrastinations. My dear friends, with best of the plans, sometimes there is every possibility that they can even fail. Because let's understand, we are living in VUCA world, which symbolizes a world which is volatile, a world which is uncertain, a world which is constantly very complex, a world which is ambiguous. Constantly volatility, uncertainty, complexity, and ambiguity is ruling my life. And we all say that this is the new normal. Well, yes, this is the new normal. Then how do we actually manage our time? So the key to success is not not just time management or target management. The key to all these management lies with mind management. If I can manage my mind, if I can learn to manage my own self, well, I can do time management, I can do target management, I can do change management, I can do VUCA management also. And all these problems will keep coming in. But the biggest, failure comes when I succumb here. So let me just learn this very simple art of mind management. You see, these distractions which we were talking about, problems coming in, situations coming in, lot of patients and complexities coming in. How are we interacting? How am I interacting to these distractions at large? If you were to see, we as a person or I as an individual, I am interacting to these distractions with my 5 senses. How? I heard a bad news, I heard a news, or I heard an information, and immediately something starts here. My thought process, it starts working like a machine. I saw something, immediately input had gone inside and the thought process started happening. So these 5, I touched something and a thought process started. I tasted something, the thought process started. I smelled something which was not good, a thought process started. So all these distractions are constantly interacting with my 5 senses. But to resolve this bigger question and lead to mind management, it is important for me to understand this powerful cycle, wherein it all starts with thoughts. The moment this distraction went inside, it started creating thoughts. These thoughts started creating feelings, a positive feeling, a negative feeling. Corona बढ़ रहा है, the numbers are increasing, so we want more doctors, we want faster implementation, we want better medications to be given to the world at large. Now the thoughts started. Feeling of irritation, feeling of stress, that we have to work for extra hours. Now this negative feeling creating a negative attitude, negative action. And then accordingly, it is creating my habit. Habit is leading to personality, which is further leading to my destiny. So where did it all start? It started from thoughts. A negative news came. I am an empowered personality. The thought came and I said, no, don't worry. I'm going to deal with it. This thought created a positive feeling, empowered feeling, empowered attitude, empowered actions, and empowered habits. And these habits are creating me as an empowered personality. And what am I doing? I'm creating a winning destiny for myself, because people would say, oh, she's very positive. She's very, perfect in doing things, and she's very helping. And yes, we would want to be friends with her. So you've created a destiny, which is a winning destiny. So can we today, decide for ourselves that let us stop blaming others and take the remote control of my happiness in my own hands. Because I am what I think and believe. If I think that others are responsible for wasting time, others are responsible for wasting my time and reducing my happiness, then what am I doing? I'm giving my happiness remote control in their hands. And now they have a choice to actually press the button of unhappiness and make me unhappy and make me cry and succumb. So today, let us just take back that remote control in my own hands and understand that happiness is mine. Let us understand the basis, the seed itself. Where did this thought started at all? So, you see, this is a human body. There is something, and this something makes a person a living person. And you as professionals, you say we are human beings. In medical sciences, we heard everything and anything about human body. Anatomy, physiology, biochemistry, everything about human body. But what is this being? An unexplored, I would say, subject, absolutely. Well, we understand this human is made up of 5 elements, which is the earth, water, air, space, and fire. But what is this being? Being is nothing but the energy within or the driver within, which moment it enters my body and my body comes in action. And I say this is a living body. So like this human has 5 senses, which we just saw, which keeps on interacting with the external world. Similarly, being has 3 faculties. And these 3 faculties are mind, intellect, and resolves. Mind is the thinking faculty, constantly thinking. Intellect is nothing but the judgment power or the visualization seed. And resolves are nothing but our habits, constantly putting and implementing those actions, and these actions leaving an impact, and they become habit forming. So these are the 3 faculties of my soul. If I buy a simple mixie at my home, and what we typically do is the moment we have the machine coming to my home, we immediately see the user manual. How do we operate it? So that we utilize all the functions of that particular machine. Similarly, ever thought of understanding or having the user manual of this bigger machine? We have been living with it. And we thought as doctors, we know everything about body. But we never thought about this body in a way that who's the driver within? What leaves the body when the person dies? Everything is perfect. Heart is intact, brain is there. But what leaves the body is nothing but the being. The one who's responsible for creating, the one which is responsible and having these 3 faculties, which is mind, intellect, and resolves. And mind is constantly creating 4 varieties of thoughts, which is positive, negative, waste, and essential. सोच रहे हैं, constantly सोच रहे हैं. You ask them, what are you thinking? No, if this wouldn't have happened, that wouldn't have happened, that wouldn't have happened, then that would. अभी तो कुछ हुआ ही नहीं है ना. Why are we procrastinating? We keep thinking and thinking as if sitting on the car is in neutral and keep pressing the race. You keep pressing it for 2 hours, you are still standing there. If we really want to move in our life, we'll have to focus upon positive and essential thoughts. So there was a very beautiful study created by Huffington's Post, and which very clearly said that a human being today is creating 30 to 70,000 thoughts. Wow, what kind of energy we are creating. And they thought, let us just study the human patterns. What kind of thought patterns are there? And interestingly, they said that 90% of the thoughts which people are creating are waste and negative. And it's only 5% of the thoughts which are essential and 5% are positive. Imagine if this is a factory which is running out there, and you being the owner of the factory, would you ever want to continue with such a factory? Wherein 90% of the production is waste and it's only 10% of the production which is really useful. My dear friends, that production is happening here constantly. And we say we feel tired, we feel succumbed, we feel unhappy, and we don't have time. We are busy, we don't have time. And today we want such a session on time management. So let us just pause and ponder and understand that each one of us, be it any caste, creed, religion, sex, age, everybody has being within. A point of light and might that is shining in the center of the forehead. This is no spirituality. This is no dharam, not at all. This is science. Let's understand it. It's an eternal, immortal, and imperishable being. Cannot be destroyed, because in science and physics, we have studied it very clearly that energy can neither be created nor destroyed. Similarly, my dear friends, the soul, the being, cannot be burned, cannot be destroyed. It's eternal, it's immortal, it's imperishable. And it requires these 7 values, which are knowledge, purity, peace, happiness, love, bliss, and power. Everybody, be it anybody, any age group, any sex, any religion, every soul wants this knowledge, purity, peace, happiness, love, bliss, and power. Are we ready to really get that? And yes, that's possible. Because you see, all this while we had been driving our car at the maximum speed, thinking that if I drive fast, I'm going to reach the destination fast, forgetting that if I'm driving fast, I'm also exposing myself to a lot of problems. First, there is every possibility I can meet with an accident. There is every possibility that there is huge amount of wear and tear. There is every possibility on a personal level I'm not enjoying. That's exactly what is happening. So my simple solution is, let us learn to traffic control our mind, or let us learn the art of meditation. You see, when you are driving and there is a traffic signal coming, there is a red light, you immediately stop your car, no matter whatever speed you are at. Because if you don't do it these days, they are going to send you the challan at your home, and you get a digital challan at your home or on your mobile device. Similarly, can I learn the art to traffic control my mind? Let me show you a very interesting thing. If I were to ask you, is it easy for you, what I have written on this particular slide, is it easy for you to read? Versus if I show you this slide, is this easy or this easy? I'm sure you all would say, well, this is much more easier for you to read. And what is the reason? Why is it easy for you to read this? Let's just read it out, what I have written. It's no secret that age-old practice of meditation has gained mass appeal. Meditative practices are no longer just for health gurus and yogis. They are now embraced by politicians, celebrities, athletes, and even for those who do not make the cover of US Weekly. Well, yes, meditative practices are really very simple and easy. And why and what is the difference between this slide versus this slide? I'm sure you would say that the spaces have made the whole range of difference. That's exactly what I want to bring to your kind notice, that the moment I added space in my second slide, it just made things easier for you. You were thinking less, you were thinking slow, and you were thinking better. That's exactly when we say traffic controlling my mind, I immediately start increasing the spaces in my mind. I start charging my mind. They say you should have, for a healthy lifestyle, you should have small meals, but you should have repeated meals. Similarly, can I also learn to empower the master within? Can I learn the art to empower the driver within, so that if I have an empowered driver, I will have an empowered mind. If I have an empowered mind, no matter what are the situations, no matter what are the problems which are coming, natural calamities, diseases, ailments, complications, everything you can deal with, because you are doctors and people say that you are all next to God. So the next to God have to definitely learn the art to keep themselves cured and healthy. So meditation is a very simple exercise. It's a process of self-introspecting in a very relaxed state. It's an ability to talk to your own selves, talk to, consciously creating those positive thoughts, those powerful thoughts for your own self, understanding my true identity and understanding the supreme, and constantly keep myself empowered. Meditation is actually like dwelling on the nature of supreme. It's not an event, not at all. It's a daily process. It's a journey. And it's a very beautiful journey where we are constantly creating pure, positive, powerful thoughts. And if we constantly create pure, positive, and powerful thoughts, then what am I getting in return? I have a clear vision, a constructive vision, and my mind becomes creative. And a creative mind is a dancing mind, is a joyous mind. And that's all what we want to achieve. So let me take you to a small meditative journey. With such a hectic day, wherein we were trying to feed in and put in everything that was coming to us, trying to manage the time, but let's just go on to a very simple, small relaxation exercise. I would request all of you to sit in a very comfortable posture. And I'm going to give you some nice thoughts. Om Shanti. Sit back, relaxed, in a very comfortable posture. And I tell myself, the whole day is gone. For almost 1.5 to 2 months, we were looking forward to this wonderful conference, planning, putting things to practice. And today is the D-Day, when everything is live and in action. It's the creation of mind, which I see today in action. Similarly, my life is what I think, what I believe, how I act. All this while, we've studied so much about the body, the soma, in my medical profession, but never thought of understanding the energy within, the driver, the controller. I thought when things outside are going to change, when things outside would be positive, would be good, as per me, I will be happy. But I forgot. It's all about inside out. When things change within me, the things change outside me. And today is that great, lovely day when I have known about who I really am. I am a point of light and might that resides in the center of the forehead. Seeing this beautiful world through these lovely eyes, hearing through my ear, I've understood. All these sense organs are mine. The body is mine. I'm not the body. I am the driver within, the master within. I have the power to create positive thoughts. I have the power to create my own destiny. And today, I have decided to take back that lost sovereignty which I had given in hands of others. Today I have decided to take back my own remote control and lead a happy and a blissful life. To become a double doctor, a doctor that gives solace, not physically, but mentally empowers the patients. Today I have decided to become the true healer. Om Shanti, Shanti, Shanti. Om Shanti. Om Shanti, and thank you so much for giving me time.
Thank you very much. Outstanding as usual. I think it is this talk was one of the best that we ever had in our conference and all. In very simple terms, you have told us how to manage our time through mind-body interaction, and such a simple way you have taught us meditation. The benefits of meditation are known to many doctors now because, as you said, not only it brings peace inside, it heals us and also makes us positive persons, and the negative thoughts disappear from that. And you're quite right, the doctors are very poor in managing their time. I have been a teacher for the last 50 years, and I have seen these young people, they are just running after money, and they have no time even for lunch, and all their family members also complain that they have no time for the family. The children, they don't have really family time at all. So I always tell them that you are earning something which is not going to go with you. When you go, you will not be. So the result is a lot of stress is there. And this stress is shortening the lives of doctors. It's very unfortunate. The healers themselves live 10 years shorter than the general population. And I think this talk is going to be of great value. I am a very strong believer of meditation. And I have been telling my patients also that once they meditate, their time management, because the mind becomes strong. I ask them, why don't you do exercise? They all know exercise is good. They know meditation is good. They say, doctor, where is the time? I always say 24 hours. You have to manage the morning. You get up half an hour early. And once they meditate, I ask them, why don't they exercise? He says, when I get up, I want to go, but my mind says, don't go today. You're slaves of the mind. But once they do meditation, after a month, they change. And the mind accepts what you are trying to do.
Yes. The mind becomes your friend, actually.
Otherwise, you're slaves of the mind. Now you have the mind becomes your slave. And similarly, this is true of not only that, in a party you go, you eat bad things normally. And once you are meditating, you always think positive. I think positivity reflects in everything that you do, not only in talking, but eating, interacting with the family. You don't lose your temper and so on and so on. Thank you very much. I think this is going to be of
Thank you so much, sir.
to the doctors, and I'm sure next time we will have a big course of meditation for those doctors who are not really learning this, because I believe this is going to be extremely good, because they become better healers, as you said. They have compassion, they have empathy.
It's all scientific and it's all facts.
A lot of data is there, yes.
Yeah.
I've done myself a lot of research papers are there.
Right.
And my friend Dr. Gupta from Kumari has done that reversal of study. I had done that earlier. We have also published large number of articles and the cardiovascular benefits. Thank you very much once again.
Thank you so much, sir. Thanks a lot.
Is Professor Jamal also there on the program? I can't hear it. Anyway, thank you, sir, for your words.
Yes, sir, I'm also here, but I was carrying
please,
your
I'm waiting for you. Please speak.
No, sir. It was as usual, no words for the lecture of Monica.
Thank you so much. Thanks so much,
the
sir.
inspiration for every generation. Koi confusion. I always like her, and we always follow her thoughts very seriously, and everyone follow her very seriously.
She's doctor of
even the whole family, not
Nice,
only
sir.
Monica,
That's
Mohit,
amazing.
Mummy, Papa, everyone has their own imagination and visual.
Absolutely kind of you, Bhaiya. It's always
We like him very much.
Pleasure.
Thank you, Monica, for your grant like this.
Thank you.
It's my pleasure.
Pleasure.
Thank you, sir, for all your wisdom, words of wisdom coming from you. And a beautiful talk. Ma'am, one of the best I've heard. I've
One of the
heard a lot
best.
of talks. मैंने दीपक चोपड़ा बहुत सारे लोगों को सुना है, but this was one of the best talks. The way you combined time and target management and with meditation, and the links and the slides are just beautiful. And I happen to know your father also, but I never knew he had such an intelligent and a beautiful daughter first. So thanks to Mohit also for bringing you in. And really it's an eye opener. मैंने meditation में बहुत सुना है, पर इस तरह से वो presentation जो आपने दी है कि I just was glued to the thing and I was just trying to catch up. मुझे लगा एक बार में मैं सब कुछ समझ भी नहीं पा रहा हूँ. Probably I'll have to listen to this lecture again.
Visual impact is mind-boggling, beyond doubt.
Thank you so much. Glad that you gave me chance and gave me chance to actually share my views on such a lovely forum. And it's always a pleasure to share my thoughts with such an august gathering of doctors. And आप सब तो आदरणीय हैं, आप सब ने इतना कुछ achieve किया है, and it's always wonderful. But these are facts of life. And it's very simple. People are scared of meditation. It's that simple. चलते फिरते कुछ भी कर सकते हैं. See, आप यहाँ बैठे हैं. If I were to just simply ask you a question, while you're sitting here, your family members are not around. Just think about them. Just be to your office. अगर मैं आपसे बोलूँ आप एक सेकंड में अपने हॉस्पिटल पहुँच जाइए या अपने क्लिनिक पहुँच जाइए, I'm sure you can simply go and enter inside the clinic. If I say just open the door of your clinic or open the door of your room, sit on your table जहाँ पर आप रोज जाकर के patient से मिलते हैं, you can say yes हम वहीं बैठ गए हैं, पहुँच गए हैं. If I say that आपका peon आया and he is offering you a cup of tea or coffee, whatever you take on a daily basis, yes, that tea is there and you can now start sipping it. You will have the flavor of the tea. While the tea is not there, the peon is not there, your office is not there, nothing is there. What is this? This is 100% meditation. This is 100% experience. You are experiencing it and I am imagining it. मैं imagine कर रही हूँ. सर हैं, सर का हॉस्पिटल कौन सा होगा, कैसा कमरा होगा, चाय पी रहे होंगे, कॉफी पी रहे होंगे, क्या पी रहे होंगे. I'm imagining. But you are meditating. That's meditation. For meditation, we don't have to go anywhere outside in the world. No, it's just I have to go here. And this place is a little difficult for people to go because it's easy to see outside. If I start going inside, it's beautiful. It just takes a second and it starts. That's how simple meditation is. It's just being myself and empowering myself with energy. That's it. Oh, Shanti.
Dr. Manchanda, sir, please.
Thank you. Thank you, madam, for your outstanding talk. And I said it is really beneficial to each one of us, but so simple. and I think extremely useful. We must give it to all the doctors who have not been able to listen to this, because I believe whatever we said is true. Every word of it is true, and every word that you said is really golden. Thank you very much once again, Mani.
I think we have Ashish also, who was one of the panelists, or if he wants to speak anything.
Yeah.
I'm just seeing him on the screen. Ashish, are you there? You're not audible, please.
Yeah, am I audible now, sir?
Yes, you are audible.
Yeah, thank you, sir.
Light
Thank
नहीं
you,
आ
sir.
रही है, पर audio आ रहा है.
Yeah, sir, it's a wonderful talk, and what I want to tell that every day we face the similar situations in our daily life. Whenever we go to the hospital, I can just relate to each and every slide what ma'am has told, and we face the same situations every day. And then we, whenever I encounter such situations, I always think about the thoughts provided by ma'am in our last lecture also. And I always try to meditate and always try to think about how to decrease our competition levels, how to, stop comparing between ourselves. So a wonderful lecture. And I must say that we must incorporate these things in our everyday practice, and never, go for the competition or comparison between our colleagues, to achieve the goals. We have to set our own goals and, target those, not target the other person's goal.
I think very rightly said, sir, because we are our own biggest competitor. That's what even I have felt in, whatever little number of years that I have given to my profession. And that's what has really brought a lot of laurels to our company. Every year we set up our own goals and constantly keep outsmarting them. I think that's wonderful. Thank you so much. Thanks a lot. Bye. Cheers.
Om Shanti.
Om Shanti.